Doctors, we are live.
Thank you. So, dear all delegates, faculty, welcome to the BOA MOS Summer Focus Symposium. And today's the first day, first show. We start with the refractive session, and here with me we have stalwarts who are panelists and chairing the sessions. Dr. Partha Vishwas sir, our chairman, Scientific Committee AIOS. Dr. Kuresh Maskudi sir, past president of All India Ophthalmic Society. Dr. Nitin Malkan sir from Mumbai. Dr. Gopal Arora sir, the past president of MOS. And I would like to request Dr. Partha sir to give the opening remarks and also to introduce the first speaker. Thank you.
Thank you very much, Vardhaman. I thank BOA and MOS from the bottom of my heart to have this scientific session live on this particular day, the 9th of May, 9 o'clock. So what does it mean? The 9th of May is Mother's Day. And today, let's pray to Mother Earth for deliverance from the evil of this pandemic. Let the human race survive this and come up strong. This is a small prayer that we need to do for ourselves, our community. So let us go on to our first speaker, and this session on refractive surgery does open a great vista. In today's life, the first wave, we have crossed, the second wave, we are there. And let us see and let us hear from Tanvi what the groundwork for a refractive surgery case should be in today's time. Is it any different from what we had previously? Tanvi, please.
Thank you, sir. Good morning, everyone. At the outset, I want to thank BOA for giving me this opportunity. We know that a good preoperative workup goes a long way in giving us an acceptable postoperative result. We know refractive surgery can be cornea-based or lens-based. Today, I'm going to discuss the groundwork required for the cornea-based ones. Why is it needed? Now, these 4 steps are all that comprise of my talk today. We must assess the patient's goal for the surgery and his expectations. We have to evaluate his eye and rule out any risk factors for the procedures. So it sounds simple, right? A good starting point is always the history. The patient can give off many red flags all the time. His manners with your staff, his impatience to wait for the tests done, his reaction when told he may need glasses after surgery. Now, these are patients who are best avoided or at least well counseled before surgery. To sum up, I would say that this is your ideal patient, someone who's easygoing, has a positive outlook, he is having a well-adjusted personality, and is currently using less than a full correction and shows a willingness to wear glasses if required post-op. Now, each and every point in this slide is important for different reasons, and it shouldn't be missed. Some of this will help us decide which procedure we may opt for. For example, a wrestler or a patient applying for Army or Navy services, we may change the option from LASIK to PRK. In a dry eye patient, we would prefer SMILE, or if the patient has a tendency for abnormal healing, a SMILE or LASIK may be preferred over PRK. All of these are not absolute contraindications for laser surgery, but it should be avoided if possible. The next most important part of our groundwork is the ocular examination. This will help us in the decision making. It looks a lot, but there is a pattern to this chaos. So we must remember first that our machines work on the numbers we feed in, and the numbers come from our cornea. So the accuracy is high when the corneal tear film is intact or undisturbed. So this is the chronology we follow. We want to assess the dry eye status of the patient right at the start. So a simple way to get that information is the OSDI questionnaire. We take their contact lens history because it tells us a lot. Because if a patient has suppose opted for LASIK because of contact lens intolerance, then you know right away that it may just be a dry eye or some allergy which needs to be treated first and then go for LASIK. The eye is then first tested with the topolizer machine. The aberrometry is done. Then the topography scan is performed. These scans are more precise when done first. After this, the rest of the tests are done, ending with a dilated retinal examination. The impact of contact lens is underestimated, especially in the high myopes who are mostly on contact lenses without a break, and this can cause a dramatic change on their corneal surface. Here is an example of a 31-year-old female who was on contact lenses for 10 years and had just discontinued them for a day. She had a refractive error of -6 with a -6 diopter cylinder and BCV of 612 in her right eye. Now, this case was an eye-opener because we had to wait for 2.5 years for her cornea to become stable. As you can see, the tangential map shows very many irregularities to begin with and then smoothened after 2 years. Similarly for her corneal thickness profile. So there was a scan done every 6 months to see her stability. And towards the end, her refraction was to the tune of -11 with just a 0.75 cylinder. So it is always better to wait. The cornea gives us a lot of information and its accuracy depends on the quality of the tear film and the epithelium. This is an example to show how dry eye can affect our measurements. This is the topo scan of the same eye showing two separate cylindrical errors as well as different axes just taken few days apart. And to avoid this confusion, it is always a good idea to look back at your raw data to see if there was a dry spot, if there was any missing data point, because the interesting part to note is that we will still get some readings from the abnormal scans too, even if the quality wasn't good. So when doing a topo-guided treatment like Contoura, maybe the quality of scan is very important and that can just change the way the treatment is done. We go to the visual acuity and refraction. A cycloplegic refraction unmasks any latent hyperopia, which may present to us as pseudomyopia due to the accommodation spasm. So it's a good idea to do that. And also a contrast sensitivity check. A good clinical examination is a must. A single drop of fluorescein can give us a lot of information. We must be on the lookout for some of these signs and then treat them before proceeding because they can cause immediate postoperative complications like DLK, infective keratitis, or persistent epithelial defects. In today's time, the dry eye tests have become very important and they need to be checked for every patient. The tests on the right side are kind of impractical in our current scenarios, but the tear biomarkers are something we have to look out for. Now, a normal tear film thickness contributes to around 43 diopters. If the tear film thickness decreases uniformly, the change in the power of the surface is minimal. But if this happens irregularly, like you can see down, then the change can be as high as 1.3 diopters. Now, this is the impact of the tear film. An unstable tear film will give us inconsistent readings. This will affect the refraction. It will cause a higher risk of postoperative dry eye, all of which leads to an unhappy patient. The dry eye test can classify the patient to have mild, moderate, or severe disease. And of late, a lot of importance has been given to the epithelium, and I think rightly so. Let's just see how this profile can change in dry eyes. You see from the left to the right side, these are scans of patients with no dry eye to severe dry eye on the right. There are epithelial irregularities with thickening and thinning in some areas. These changes in the epithelium have been found to be a sensitive tool to assess dry eye in several studies. The importance of epithelium in subclinical keratoconus patients has been studied too. This was a case of a 26-year-old female with low myopia and a Schirmer's of 15 and 10 interested in LASIK. Her topo scans looked normal, although her Bellin-Ambrosio display showed some abnormal elevations. Now, with those decisions or findings in mind, the decision of PRK was made. This is the Placido image of her left eye with the epithelial map on the right. Now, this thinning correlated with the asymmetry on her curvature map. Her surgery was deferred. There have been studies which have shown that subclinical keratoconus first presents as an abnormality in the topography, in the epithelium before the changes show up on topography or even vision. So it is always better to wait and observe for these changes on the topography than to operate. The topography helps us to understand the corneal curvature, its elevations and thickness. The axial map, the 4-quadrant map rather, gives us a lot of details about the astigmatism, the corneal thickness, and any abnormal elevations. I'm sure we'll know a lot more about this in the next lecture. I think a point to highlight is it's always a good idea to look at the tangential map than the sagittal, especially in cases of subclinical keratoconus or chronic contact lens wearers. It detects the localized abnormalities much better. Again, we will see this more in detail in the next lecture, the Bellin-Ambrosio scan. All of this gives us a better idea and helps us differentiate a normal thin cornea from one with an early ectatic disease. Aberrometry is a good tool to understand how an individual eye aberration is. Now, they are particularly important when we want to do a topo-guided treatment like maybe Contoura or a retreatment. As discussed before, they should be done right at the beginning because these aberrations can change due to accommodation or just an unstable tear film. A good pupillometry gives us an idea if the patient may experience glare or halos at night postoperatively, and this helps us to decide what optical zone we will treat. The specular microscopy is done in patients who may have thick cornea just to rule out flukes, and also in chronic contact lens users because they may show endothelial cell loss over time. Intraocular pressure should be recorded preoperatively just to get a baseline, and post-op, we must remember to put a correction factor. Although we are operating on the cornea, the rest of the parts can cause equal havoc if ignored. So post-op progressive myopia could just simply be a progression of a nuclear sclerosis which was missed preoperatively. Also, a lid pathology not treated before can cause disastrous postoperative complications. Finally, the retina is examined for any peripheral degenerations which can be barraged before laser. So the moral of the story is that the output can only be as good as the input. So look at the raw data carefully, scan the cornea well, and look for any dry eye or treat it before operating patiently. Consider other issues like vitamin deficiencies which may be present in the patient and treat them first. And lastly, talk to the patient, set a realistic goal. And if you do that, I'm sure nothing can stop you from having a good patient. Thank you so much.
Thank you, Tanvi. And can you stop screen share? Yeah. And we move on to the next speaker on understanding corneal topography. This will be a talk based on very basics, only the Placido disc corneal topography.
Good morning, Partha sir. Good morning, Maskati sir. Good morning, Keledar sir. Good morning, Malkan sir. Good morning, everybody. Wonderful, Tanvi.
Good morning, ma'am.
Good morning, ma'am.
Thank you so much.
Good morning, ma'am.
Good morning, Vardhaman. Hi, Vardhaman.
Hi, ma'am.
Good morning.
You're looking fresh and raring to go.
Thank you. Hi, Vaishali. Hi, Gopal
Hello,
Bhaiya.
ma'am.
Thank you.
Happy Mother's Day, Ragini ji.
Thank you. Thank you. Thank you, Bhaiya. Thank you so much. Thank you so much.
Can we go on?
Yes, sir. Sorry, sir.
Okay. I'm trying to get to slide 1 somehow. Yeah, I think I've got it. Okay, so I don't think I'm on slide 1. Doesn't matter. So corneal topography is not something very new. It was developed in 1984 as a result of marriage between what was then called video cartography and the advent of computers. So there was a computer analysis as well. The applications of corneal topography are not only in refractive surgery, but we are using it mainly for this, for LASIK and others, but also for fitting of contact lenses, orthokeratology, and post-refractive surgery if you want to evaluate the cornea, and of course for various types of research. Now, what are the measurements that are taken? Very, very basic. What are the measurements? Something called height. Now, how do we know what is height? Imagine a contact lens sitting on the patient's cornea, which has got a known curvature, which is spherical, not aspheric like the cornea is, but which has got a known curvature that is called a best fit sphere. So if you imagine that, then anything which is above that, more curved than that, is depicted in red. Anything which is less curved than that is depicted in blue. So it is a comparison between the difference in height from a sphere of known size called the best fit sphere. So this is, for example, this is the best fit sphere that you can see. And if I can show you, so this is the best fit sphere and this is the one. So since the patient's own cornea is below that, this part is depicted in blue. And over here, you can see the best fit sphere starts here. So the patient's own cornea is above that, so it's depicted in red. So this is what you would call a steep corneal appearance. Now we use certain scales. And for these scales, we use colors. Now, very, very basic. The warmer the colors, the reds, the oranges, the yellow represent the steeper axis. And the cooler the colors, the green, the blue in the rainbow, they represent the flatter axis. Now, there are various scales by which we use. Just to give you a theory, nobody uses this absolute or standard scale. That means it is divided in ranges from 9 to 100 diopters in 26 color-coded steps. The problem with this scale is that even in the keratoconus, everything will appear green because it's between, say, 29 and 55. Everything appears almost the same color, shades of green. So you don't get to know much from this absolute scale. That's why we devise what is called an adjustable scale. So these are steps of equal intervals which you can adjust. But you can have a different starting point and ending point. For example, if you choose 28 to 65, the diopters, then you would get the scale which is seen on the left, with a little bit of yellow below and most of it green. But if you further narrowed the scale, saying that I want to see only 37 to 49 diopters, then you would see the beginning of keratoconus, the red in area over here, and more of yellows. So it depends on what scale you have and how narrow your scale is. So this is the adjustable scale. Again, choosing only 10 diopters, 33.5 to 44.5. And this is a typical, see the flatness in the center and the warmer colors around. This could be somebody who's had a LASIK done already. So I told you about height. I told you about scales, colors. Now, basically, topography is all about curvature. And as Tanvi correctly said, there are two types of curvature maps. One is called the global, where the measurements are made relative to the visual axis. This is not so useful. It's less accurate in the corneal periphery and for irregular surfaces. So like Tanvi suggested, we prefer to look at the local maps, or also called the tangential or instantaneous maps. Why do we do so? Because here, the curvature at each point is calculated with respect to its neighbors. So we don't want to compare India to America. We compare India to Bhutan and India to Pakistan. So the neighbors, there's a small difference between you and your neighbor. It could be a large difference between you and the periphery. So this makes a more accurate measurement. And then there is differential map. So you've done a LASIK or you've done some Intacs or some procedure. So you have the pre and the post, and then you have the differential map between the two, showing how much of a difference you made. So you can see here the differential map, that this is what you've done, a major flattening which you got over here from the previous K-conus which was here. And then for those who don't like to understand colors and things, there is the idiot-proof method in topography which gives you the indices. So there are corneal indices with 3-letter words. The 4-letter words are bad, so 3-letter words which are given to assess corneal health, like the SIPK and the SCP and the PSI, nothing to do with any Sindhi community, the surface asymmetry index, and so on. So the computer calculates all these and tells you whether these are abnormal or normal. And if it's abnormal, then you shouldn't be doing a refractive surgery. We won't go into details of all these indices because of lack of time. Corneal asphericity is another thing which is measured. We know that our corneas are not spherical. If you imagine an egg, then you're looking at an egg-shaped cornea where there is peripheral flattening, a mild peripheral flattening. We have what is called a prolate cornea. Prolate means there is peripheral flattening, and there is a while if you imagine a patient who's had an arcade and a radial keratotomy, there is peripheral steepening over there, oblate corneas. So this is a normal cornea. Many of them are round. That means the colors are equally distributed, about quarter of them, and some of them could be oval curvature-wise, and you could have astigmatism, symmetrical bow ties, as you can see over here, in about 1/5 of the patients, and it could be an asymmetrical bow tie, which is also quite common. So these are asymmetrical. These are all normal. And you could get bizarre maps like this in 7% of normal patients. It could be an irregular cornea which you can't really classify. What is meant by with the rule and against the rule as seen in topography? So with the rule is if you have a plus number or just 2.5 at 90, for example, you can see the bow tie will be vertical. So the bow tie, you can see the warmer colors in the middle, which shows that this is plus. So it's 2.5 diopters at 90 degrees. This is a typical with the rule astigmatism. While without the against the rule astigmatism, ATR will be at the same bow tie but at 180 degrees. So this is against the rule astigmatism, or a minus cylinder at 90. This is asymmetrical astigmatism, steep superiorly, as you can see. Now, there are some artifacts, and we hinted at that. That is very important to repeat the topo if you're in doubt, or if you see that the Myers are not looking proper. So if there's pooling of tears in the lower meniscus, you'll get a focal steepening. You see this focal steepening over here. This is because there is tears over here. This black area is all tears which is there. So it makes it look artificially as if it's steep here. And the trick is, as Tanvi said, is to look at the raw data and see the distortion of the Myers. And this is how a typical keratoconus would look. Thank you so much for your attention. Vardhaman?
Yes, sir. Thank you, sir. And thank you, Dr. Tanvi, for a wonderful brief about the patient workup and also the corneal topography now. I would like to invite Dr. Vaishali Vasavda, who is a very good friend and a prolific cataract and refractive surgeon. She's going to speak to us about customizing refractive solutions in cataract surgery. What do you, Vaishali?
Thank you so much, BOA. Thank you, Vardhaman. Thank you, Lahane sir, Ragini madam. And it's both a privilege and honor to be presenting after Maskati sir. Such a precise presentation and all the, I mean, I really refresh a lot of my concepts. So it seems like, can you see the slides on screen?
Not yet.
It seems like there is some problem with my sharing screen. Vardhaman, can I request the next presenter to present and I can go next if that's okay with you?
Yeah, sure, no problem. So I think, yeah. So the next in line is me only actually. So I will be giving my talk. But let me just go to my presentation.
Terrible how panelists are made to self-present without introductions.
Dr. Maskati, you can do the honors.
Hi, Dr. Rishi Bhaiya. How are you?
I'm fine, ma'am. How are you?
I'm good. I'm good.
Yeah. I hope it is visible. My screen. Just go to the full screen.
Excellent color choice, Vardhaman.
Right. Thank you, sir. So to begin with, thanks to Dr. Lahane sir and Dr. Ragini ma'am for the kind invite and for this wonderful start to the BOA MOS Symposium. What I've been asked to speak about is one of the procedures in my armamentarium, which is called as the Contoura vision, whether it's a reality or it's hype. So over the next 7 or 8 minutes, I hope to give some clarity on following points. What is Contoura vision? How it evolved over time? What are the real world results? What is the current evidence? How to differentiate between the hype and the reality of this procedure? Is it so revolutionary that it is going to replace all the other present procedures, or it is going to find its place in the current armamentarium? So friends, it was in 1990 when Professor Palikaris performed the world's first LASIK surgery, which completely revolutionized the laser refractive surgery world over and became extremely and globally accepted refractive procedure. It had, of course, many advantages over its pre-sedator before the surface ablations, including very accurate results for, especially for high myopia, lack of haze, lack of pain, and more stable outcomes. But the refractive examer lasers of those times were broadbeam. So especially for higher corrections, there was induction of corneal higher order aberrations, especially the spherical aberrations. And in those times, there was a very high incidence of development of nighttime glare, halos, starburst, and reduced contrast sensitivity because of that induction of higher order aberrations. So now there was a two-pronged approach as we move forward. The first one was how to minimize the induction of higher order aberrations with this laser. So this was done with a new platform called as a wavefront optimized platform. This wavefront optimized platform, as we can see here, has more pulses which are fired in the periphery. Therefore, the prolateness of the cornea is maintained in much better way. And this maintains the corneal aberrations and does not induce much. The second thing which was done to basically safeguard the corneal aberrations was also to create the flaps with the femtosecond laser. Femtosecond laser flaps, as we know, don't induce much corneal aberrations because they are planar flaps. Now coming to the second part, when we have maintained the corneal aberrations, now the next thing was, can we reduce pre-existing corneal aberrations? So this was first attempted with the wavefront guided treatment. As we know, the wavefront guided treatment analyzes the total wavefront of the eye. And with the help of customized laser ablation, we are able to treat not only the refractive errors, but also any aberrations of the entire eye. However, there were certain drawbacks of this technology. The maps were not consistent, basically because, as we all know, the wavefront depends and varies a lot according to the pupillary size, age of the patient, internal astigmatism, especially the lens opacities. So what was seen was that majority of these aberrations are actually coming from the cornea. And the second advantage that was seen was that when you use a topography as a guided tool, the topography is more stable, it is more reproducible, more repeatable as compared to the wavefront, and it also does not get influenced by variables such as pupillary size, age of the patient, internal aberrations such as lens opacities. So the first such tool was used in the form of TCAT, and it was introduced in 2003. And in those times, it was first brought in to correct the pre-existing high aberrations such as central islands, small optical zones, irregular astigmatisms, either primarily because of keratoconus or after post-LASIK ectasia. So when these things were going on, there were a lot of publications which actually demonstrated that TCAT was able to improve the visual acuity of this patient and regularizing the anterior refractive surface. So I think this story of genesis of Contoura is very, very interesting because when Alcon is the one who holds the patent for Contoura, when they wanted to FDA approve the TCAT software for high irregular astigmatism, they approached FDA. And FDA told Alcon that we would first want to ascertain the safety of the TCAT platform, not on highly aberrated eyes, but on normal virgin eyes. And once you show that this is safe for such eyes, then only we will go ahead and we will do the next study for the highly aberrated eyes. So Alcon with its team did a study called as a TCAT study, which was done in about 9 sites all over the US, including one of my parent institutes, Bascom Palomar Institute. And about 249 eyes were included in the study with a myopia up to -9 and astigmatism up to -6 diopters, in which a topography guided treatment was performed on virgin primary eyes. So what exactly is done in this? So you have a topolyzer, which is basically the topography that we have excellently understood from Dr. Maskati sir. So you have to get reproducible and repeatable maps, ideally at least 4, but up to 8. And then this is fed to the TCAT software. This TCAT software is going to give you all the information about the higher order aberrations at the corneal level. Then it is fed to the EX500 laser. And the EX500 laser is going to create a pattern of the ablation, which involves your manifest refraction as well as correction of higher order aberrations onto the cornea. This is how the ablation pattern would look. So for example, if you're looking at a spherical patient who requires a spherical ablation, this is how the ablation will look like in the first picture. When you actually incorporate the data of higher order aberrations of the cornea, this is how the ablation map will look. And when you combine both of them, this is the treatment plan, which is called as a final treatment plan. It is very important for the TCAT to work well and reproducibly that the manifest refraction treatment plan and the final treatment plan should closely match with each other, and then only you will get much more and better results. So when this study was done by FDA, they were actually quite surprised, and all the investigations were surprised that the results were so good. More than 90% people actually gained 20/20 or better vision. More than 30% people got 20/12 or better vision. But what was remarkable was almost 1/3 of these patients, 31% people, have 1 or more line of improvement of uncorrected visual acuity beyond the preoperative best corrected visual acuity. Not only the quantity of vision, but also the quality of vision had showed improvement. There was a statistically significant drop in glare, halos, nighttime visual difficulties of these patients compared to the pre-op. And this was the birth of Contoura vision. So when this was realized that this works well for first-time users, such as in virgin eyes, then this was reintroduced as the TCAT software for virgin eyes. And now this is what is called as Contoura. So what is Contoura is it treats the major corneal higher order aberrations of the cornea along with refractive error. It does not induce the spherical aberrations, but it also, because it also maintains the wavefront optimized platform and also has something called as a C4 C12 compensation that we have to actively do. The centration of Contoura is corneal on the corneal apex, which is more physiological because you negate the possibility of angle kappa issues. And also it basically has a pupil centroid shift compensation. When we started to perform Contoura, which is about 3 or 4 years now, we were actually very happy because in the beginning, we selected patients according to the inclusion criteria of FEM. And we also saw that about 28 or 29% eyes had improved on 1 or more line of UDVA over the preoperative CDVA. But as we expanded our scope of inclusion of all the normal patients, then we realized that actually the results of Contoura not necessarily were significantly better than the wavefront optimized platform we were already using. And this was also shown by multiple publications also in India by Dr. Ramurthy as well as by Dr. Rohit Shetty, where they have done randomized study of Contoura in one eye and the different optimized in the other eye in normal patients. And they have shown that the results were almost similar. This was also seen in some of the international patients and studies in which the FDA outcomes could not be replicated in other studies. So why the difference? The difference was because FDA study carefully had selected patients which were having excellent marriage or correlation between the manifest cylinder of the patient and the topographic cylinder of the patient. So in which the cylindrical difference in terms of its magnitude is not more than 0.75 diameters, and the axis between the manifest refraction as well as the topography is not more than 5 or 10 degrees of difference. But in reality, only 10 or 20% patients actually meet the FDA criteria. So this is why, as you can see, this is the red, which is what is called as a manifest contoura, which is on to the axis of manifest refraction. However, in many patients, it was seen that the topography actually shows an angle which is quite different. Therefore, a new concept in Contoura was introduced by contourologists, and this was called as the TMR Contoura, which is called as a topography modified refraction contour, in which what he suggested was you actually fit in the spherical equivalent from the refraction, manifest refraction of the patient, but you actually take the topographic data for astigmatism correction of the patient. Although contourologists demonstrated in his study that the results were mildly improved over the wavefront optimized platform, but they still did not match the FDA outcomes. Therefore, the introduction of a new concept in Contoura was done, which is called as a hybrid Contoura. So what is a hybrid Contoura? Is basically when you look at the TMR Contoura, you are only taking into account the topography, which is the anterior corneal astigmatism. But in reality, the corneal aberrations, they come from anterior cornea, posterior cornea, the lens, as well as the vitreous theory, and also the retinal structures. So in hybrid correction, all these factors are taken into account, not only the corneal topography. And one of the examples of hybrid are ray tracing techniques and what is called as foresights. So the foresights is currently the best form of Contoura, which is now compared with the traditional manifest Contoura. When you take into account all these factors together, it was shown by this study by Lebanov et al. That the outcomes were almost matched with the FDA results. That means compared to the different optimized platforms, the outcomes would be now much more better in all the patients. Now, what about the other platforms? Apart from Alcon, the Zeiss, Nightingale, Swind also has topometric treatments, and how are the outcomes with them? All the other platforms also do have topometric treatments, and the outcomes are fairly similar to what you would see with Contoura. So what is my current indication of introducing this technology in my clinic is basically I use the Contoura system for people who have consistent myopic astigmatism in which there is a good correlation between manifest cylinders and the topographic cylinders. For sure, for hyperopics, this is the best technology on earth because you are actually treating them on the corneal vertex. So the angle contact issues don't happen. And of course, I use it for almost all my keratoconic patients to improve on the irregularities along with cross-linking. However, for all my patients who have a very regular cornea, mainly spherical errors, SMILE is still my best choice. We have to also know that Contoura still requires a flap, so there can be flap-associated complications, and the dry eye is also an evident thing which can happen. So to conclude on the factors that we discussed on the first slide, is it a revolutionary procedure which will replace all others? Probably not, but it is definitely a great addition to the armamentarium, especially if you have a patient with myopic astigmatisms and patients with hyperopia. For patients who are run-of-the-mill patients with normal spherical errors, even if you choose your different optimized technologies such as surface ablation, femto-LASIK, or SMILE, will give you equally good results. Thank you very much for your kind attention. Thank you. So I'll just stop sharing my slide. Vaishali, I hope your thing is sorted. Yes.
Yeah.
Right.
Can you hear me?
Yes.
Am I audible?
Yes, Vaishali.
Okay. And I'm sorry for that lag, and I won't waste more time. I have no financial interest. But a little offbeat from the refractive corneal surgery that we are discussing. Well, we cataract surgeons have always tried to be at least a little bit behind the refractive surgeons. And now it's time we all catch up, because now patients think very differently even when they come for a cataract surgery. We all have talked about refractive cataract surgery, but I think now it's time we talk about enhancing their lifestyle by giving the refractive performance that they want from their surgery. And these are results from a survey that was done by a company, no financial interest, where 400 people on the streets in India were interviewed regarding what they think from cataract surgery. So people above 60 and who have a cataract, their primary concern with surgery was that they do not want to have any vision impairment for any activity, and that they don't want to lose quality of vision as well as their independence. What also came out as a very interesting finding in this random street survey is that majority of patients above 60 wanted that their near activity should improve after cataract surgery. And what we have learned from literature and from our personal experience is that when there's a gap between what the patient wants and what we can provide, that's when the value-added practice addition goes down. So I think when we talk of refractive surgery, refractive cataract surgery, an optimum pre-op evaluation is very important. Like Tanvi and Maskati sir both stressed very beautifully, so I won't dwell on it too much. An unstable ocular surface has many problems, but very important for us, even a regular cataract surgeon, is unreliable biometry. As you can see here, on the left is the screen showing broken Myers, and on the right, the same patient, same eye after instilling lubricants. So, well, yes, obviously it will affect your refractive corneal surgery by affecting your topography. But what is very simple and we often miss out is that the keratometry readings, even on your any kind of keratometry, auto-K or your lens star or your IOL master, are going to change. And therefore, from the right, the emetropic power from 21, a regular monofocal power, changed to 20. So even the spherical IOL power is going to change if your readings are not well calibrated or not well taken into account. Like Tanvi said, look at the raw data. The other thing that is very, very important in giving good visual and refractive outcomes is doing a routine posterior segment OCT if you have access to it. And subtle things like these epiretinal membranes or tractions, which could be a cause for loss in quality of vision. And especially when you do these so-called higher technologies of LRIs or toric lenses or trifocals or whatever. And I think the most important thing is looking at the type and the degree of corneal astigmatism. I'll move on to 3 quick cases to end my presentation. Here's a 42-year-old lady, high myope, operated for radial keratotomy and has a cataract. Now, these eyes in the past were just done to remove the cataract, and whatever glasses you get is your own fate. But now is not the time. You can see here on her biometry that she has very flat corneas, 31 and 32, 33. So there is an astigmatism, but when you do a topography, the mesopic pupil shows that within the pupil diameter, the black circle, like Maskati sir was showing in the topography, this black circle, the pupil size, becomes very important to look at. And here is her abrometry and topography put together. So this black circle, which is her 2.9 mm pupil, we pigmented races are blessed because we have smaller pupils. And in this zone, she has a regular astigmatism. So we used the right formulae, the right calculators, and we went ahead with a toric lens, monofocal toric lens, because she had a regular astigmatism in her mesopic pupil size. And this is what she was post-operatively, and to our and the patient's good luck, she's 6 parts plano. So the message in this case is that even when you think of refractive customizing solutions, we have to think a little ahead and do a lot of workup like you do in a LASIK, and then give the right solution for the right patient. And this is the same patient's post-operative abrometry. The blue astigmatism on the cornea almost completely neutralized at the IOL plane, and the cornea still looks very regular. Another case of a 53-year-old, very young active male, and has been myopic and wants to have good near vision because he's a stockbroker. So he also has astigmatism. So we discussed with him that you could still have a toric lens monofocal and be myopic for your, be left myopic so that you can continue doing your near work. And we targeted an IOL power using the Barrett formula with a target of -2.34. Long story short, with bilateral toric lens implantation, monofocal, and a deliberate target, which we could achieve thanks to the good formulae, he's very happy and can do all his near and computer work unaided. The last thing we all understand, the holy grail of presbyopia correction. And for me, at least, trifocal lenses, whatever the brand, they have really made it's so much easy. There's not so much of patient selection and thinking and counseling. Yes, there is some acceptable level of dysphotopsias, but on the whole, in at least 80 to 90% eligible candidates, it is very, very rewarding. So here you can see, this is with the patient's full consent that I'm showing you her picture. She manages one of the largest crockery brands in India, and she's diabetic, she's young and a very socially active person, has always used astigmatic glasses and does not want to use them, obviously, now that she has cataracts. With her advice, she went for bilateral trifocal toric IOLs. And as you can see here, she's very happy with her vision.
Put on the brightness.
And this is, I just want to show you how we did with the brightness acuity testing, the real life testing of
brightness maybe aapko comfortably dikh raha hai?
Yes.
You know, because these are focus lights, like a headlight simulation.
Yeah. I can HZ.
So this is reading that she's
And
able
are
to
you seeing
perform
any
with
rings
the
around the light?
bat on, brightness acuity tester.
How disabling is it in terms of, if you look at the top
Again,
of the
this is
disablement,
with her
how
consent
disabling
that
is
we
it?
are doing this.
Yeah, if you're going to ask me to drive in this, I can drive in.
You can drive in this.
Yes.
All right. All right.
Now this is a very crude version, but just to show the continuous range of near vision that she has across.
प्रतिवर्ष आंखों की परीक्षा को हाथ धोकर डालना चाहिए. पुरानी
दोबारा पढ़ लेंगे last time, madam?
Yes. आंखों बंद मोमबत्ती या धीमे प्रकाश के चारों ओर.
So I think the point here is that everybody can and should raise a bar. Just talk to the patient more and more. And can you hear me?
Yeah, now we can.
Yeah, sorry. So that was all from me. Thank you so much.
Thank you. Vardhaman.
Thank you so much, Vaishali. So now we move on to the next presentation, which is by Dr. Pooja Khamar from Narayan Nethralaya, and she will talk to us about new dimension in imaging of cornea. Very exciting topic.
Thank you, Dr. Quresh, sir, Dr. Vardhaman, BO and MOS for giving me this opportunity. So I'm going to be talking about how we are moving towards the era where we will need newer dimensions when it comes to imaging to just choose our refractive surgery patients. At the outset, I have no financial interest in whatever I'm going to be talking about. So we all know when refractive surgery started, it started with we used to evaluate our patient's topography with a Placido-based topographer. Then came the slit scan topography and the shine plug based topography. So that showed how posterior elevation, bad D and everything is important. And that gave us a lot of relief because that helped us in picking up the right cases for refractive surgery. But however, still we had a dilemma, and we landed up in having dilemmas whether this is actually a true elevation or not, whether your bad D is telling you correct information or not. Then to supplement it, in the late 2000s came the biomechanics, and then it came the newer indices like the CBI and TBI. So when the biomechanics was supplemented with the shine plug based topographers and other things, it said that, when you use your CBI, TBI values or any biomechanics value, and you have a cutoff for your suspect ectasia, it helps you, the sensitivity and specificity is so strong that it helps you in identifying even the early suspicious cases who are who might be a probable ectasia cases in future, and that it will help you in avoiding doing, even if the topography looks normal but your CBI, TBI are abnormal, then it helps you that we should not do surgery for this patient. So when this indices came in, we were at a lot of relief. So these are your cases which you see, first your scenario one where normal topography and biomechanics are there. These are your 50% cases, you go ahead and do a surgery. Then there are suspicious bad D, normal biomechanics, normal topography but abnormal biomechanics and abnormal TBI. So these are the clear-cut cases where you probably would not do a surgery, or that you should keep them under observation or choose a surgery for them which will not have an impact on the complications like ectasia. But then, we know that this is happening, like this thing. But then there are these two scenarios, like, there are a lot of patients who come to you with these two scenarios where there is a suspicious, you can see this is a suspicious topography. There is an inferior steepening, but the CBI, TBI, and BAD-D, all your three indices are absolutely normal. What do you do with this case? And here your topography is absolutely normal. You don't see any steepening, inferior steepening, no post elevation, nothing. But here your CBI is abnormal, suspicious biomechanics. What do you do with these cases? And these are the cases which form 25% of your patients walking into your clinic. So are you justified in telling, like, not doing a refractive surgery for them? Or should you be doing any particular refractive surgery for them? What do you do? How do you solve this dilemma? Like, so what we did was, like, whenever you're dealing with, whenever you do a refractive surgery, you're changing your stromal structure, which has a lot of collagen in it. So whenever there is a normal eye, the collagen fibers are nicely populated and, they're very uniformly arranged, tightly added to each other. But when you come to keratoconus, the collagen bundles start thinning out and they're very dispersed. They're not very uniformly attached. But how do we study this? Right now, we have confocal microscopy, which helps us in studying deeper layers of your cornea. But that doesn't give you information about the collagen structure, how your collagen structure is, how the orientation is, how densely they are populated, or what it is. They don't give you any information. What do we do? So we have this imaging on collagen where we build a polarization sensitive OCT. What it does is it's a type of OCT, non-invasive. It throws a polarized light on your cornea. The best part is the stroma doesn't take up this polarized light, and we take advantage of it. And that's when how you can study the collagen orientation and the structure. And this is how theoretically your collagens are supposed to be in your eye, the left and right eye. And this is how what representation you get it. So I'm going to be discussing few cases like this. You just have to remember, the more densely or tighter the collagens are structured, it will be seen in darker blue or violet color. And the less densely populated they are, it will be towards your green, yellow, orange, or red. So whenever there's a normal topography, normal biomechanics, this is how your corneal structure or collagen structure will be. So now let's look at these three cases, your normal topography biomechanics. There is a good orientation of collagen fibers. But whenever there's a suspicious BAD-D, like, your biomechanics is normal. The important part is here, your biomechanics is normal, but the BAD-D is suspicious. Your curvature is suspicious, but you see here the collagen is still nicely arranged. When your biomechanics starts reducing, when your biomechanics starts getting affected, your collagen structure starts loosening out. There is partial loss of this collagen orientation and like how they are placed, and there is a partial loss of this checker arrangement. You can see this green, yellow, and red have started coming towards the periphery, and even the center is not as densely populated as it should be. And same here, if your biomechanics is normal, your collagen orientation is normal. So actually your PSOCT helps in knowing that whether your what the indices are telling you is the truth or not, and whether you should go ahead with a surgery or not. But is it the real picture? What we did was we did some studies where we correlated the PSOCT findings with the molecular findings. I'll just quickly go into this, and with your clinical findings also. We do preserve the lenticules and epithelium which are collected during our surgeries. We don't throw them, and we did gene expression analysis for them. So now let's look at two cases. One case, normal topography, normal biomechanics. Other case, topography is normal, your BAD-D is normal, but your CBI, TBI is suspicious. So what we did was, just to be on the safer side, we did a trans-PRK because the topography was normal. There was not a clear indication of not doing a surgery. And we did, during trans-PRK, we collected the epithelium. Before surgery, this was what their PSOCT was. The patient who had normal topography has normal orientation of collagen, but the patient who had weak biomechanics, if you see the PSOCT is also showing loss of collagen, the orientation is not very good. And these are how the gene expression analysis was. The patient with normal topography had normal levels of LOX and collagen in the cornea as well, telling us, and the patient who had a weak biomechanics, weak collagen on PSOCT, had a weaker collagen in and LOX and the gene expression analysis as well. So this tells us that what we are seeing on PSOCT is giving us the true picture. So whenever you are in doubt about your CBI, TBI, or your BAD-D indices, or your topography, curvature and all, the PSOCT is going to be the next way of imaging where it will tell you how the collagen orientation is, and it definitely like a lot matches your molecular level. So you are at ease and you know that yes, it is telling you the truth. Just to understand, in keratoconus also, a lot of times we see different biomechanical indices. The same correlates with the PSOCT finding. The keratoconic eyes with like a stronger biomechanics have a better collagen, and as the biomechanics starts dropping, the collagen orientation is also started reducing, and they are very scarcely populated in the cornea. Now let's see these two cases. One patient, similar grades, one like, in fact, the first patient is grade 2. It has not progressed. It is stable at 6 months. But the patient who was in stage 1 kept on observation, progressed over 6 months. So why the patient with the higher grade of keratoconus did not progress, and the patient who had a lower grade of keratoconus, like a grade 1, which with minimal risk of progression, progressed? The answer lied in the collagen structure. The patient who did not progress had a good collagen, like the collagen structure and orientation in the stroma was better compared to that of the patient who progressed. And that's why the collagen which was there in the cornea held the cornea in place and didn't let the slippage of collagen happen, and that's why they were stable and the other one progressed. So this will like, the PSOCT in future will help us in screening for refractive surgery patients, like those 25% patients whom we are going to refuse surgery. It will help us in identifying the correct ones, whether to do it or not. It helps us in identifying the FROst cases. It will help us in monitoring KC progression, when to do a cross-linking, when not to do a cross-linking. It also helps, like additional applications are, it helps us in post-graft imaging, like the corneal transplant imaging, what the outcomes are going to be. And it also has applications in a lot of retinal disorders. Thank you.
Thank you so much, Dr. Pooja. I think it was a wonderful talk. And now we go on to the next one by Dr. Nitin Dedia, sir. As we all know, he's a prolific refractive surgeon of Ojas Eye Center in Mumbai, and he's going to speak to us about refractive surgery in thin corneas.
Thank you, Vardhaman, and thank you, Dr. Maskati and Dr. Ragini. So my talk for today is on thin corneas.
Good morning, Dr. Nitin bhai.
Good morning. So my talk for today is on thin corneas and how they pose a refractive challenge, because there are so many cases we come across where there is a dilemma what to do, whether we should do a corneal refractive procedure or whether we should do a lens-based procedure. So when we first started LASIK, the initial thoughts were that the LASIK cannot be performed in corneas which were less than 500 microns. And the thickness of the residual stromal bed, if it is less than 250 microns, then it was a primary factor for the development of Ectasia, which still holds true. So what we have realized that a thorough workup is very essential, a routine workup, and along with that, now we also have the Pentacam HR and we have the Corvis ST, which helps us to take the right decision.
Dr. Dedia, sir, excuse me, your screen is not visible. We are not able to see it.
Okay, you can't see the screen?
No, sir. Dr. Maskati, can you see the screen?
Screen is not visible.
Not visible.
Okay, 1 second.
Yeah. Visible now.
Okay. Yeah, so we have the Ectasia score, which we also look at. And some of the parameters which are important is the topography pattern, the residual stromal bed thickness, the age of the patient, the corneal thickness, and the mean refractive spherical equivalent. And based on this, we decide, depending upon the score, whether you want to do a refractive procedure like a LASIK or whether you want to do a surface ablation procedure. So based on the scores being less than 2 or up to 2, a score of 3 and a score of 4 points, we decide on the procedure. So we have a lot of treatment options, like we have either you can go in for a LASIK procedure where we can also have other modalities of treatments where we can change the ablation zone, we can change the corneal flap thickness, and we always keep the percentage thickness ablation to within the safe limits. Besides LASIK, we also have the modified PRK, or what we call as the trans-PRK now, the sub-Bowman's keratomelusis, the femto-LASIK, the SMILE procedure, and the phakic IOL. So all these are good options for a thin cornea, and wherever you need to change or wherever you feel which one is best for the patient, we would opt for that. Now, if you look at the femtosecond laser flap, it has minimum variability in the central thickness across the different flaps. You have minimum variability regionally within the flap, and it confirms earlier studies performed with regional subtraction pachymetry and histology. So you have a more or less a planar flap, which makes it more safer. And most of the studies on the thin corneas less than 470 microns have shown that femtolaser is very safe as compared to the LASIK procedure due to the microkeratome. So one important parameter which we all need to understand is the percentage thickness ablation, which is the flap thickness along with the ablation depth divided by the central corneal thickness. And if it is more than 40% ablation, then it is associated with significantly greater risk of ectasia. So this is a good parameter which you can look at before deciding on whether you want to do a flap-based procedure or you want to do a surface procedure or you want to do a lens-based procedure. The pentacam now, besides topography, gives us more additional information by way of the corneal thickness spatial profile. It also gives us a good anterior elevation and the axial map along with the sagittal map and the keratoconus indices. And this makes us more decisive in what procedure to go for. Here again, we have the Bellin-Ambrosio software, which gives us a parameter in the form of a green or a yellow or in the red zone. And this makes us alert, and it helps us to once again decide whether the BAD-D is more than 1.6, in which case we would like to refrain from going in for LASIK or a procedure based on the cornea. Similarly, it also helps us in patients where you have very steep corneas, but with a relatively good corneal pachymetry. And here you see again that this curvature map and this back difference is showing that everything looks quite normal. But once again, you have to be careful in these patients. And for these patients, it's very important if you can also judge the biomechanics of the cornea by way of the Corvus ST. So the Corvus ST has now become an important tool, especially in such type of cases. And in cases like thin corneas where the parameters of CBI and TBI, it helps us to make a correct decision. So this procedure, technology of corneal visualization with sign flux technology has been available since 2011, and it is based on the non-contact air puff tonometer combined with the ultra high speed shine flux camera. So it deforms the inward and outward corneal curvature while passing through two applanation moments, and it is fixed with a maximum peak pressure for air puff in every examination. So some of the measurements it produces and some of the names you need to understand is the deformation amplitude, the applanation length, and the corneal velocity. The Vincigora screening report gives us a summary of the whole examination, and it is very fast and comprehensive, and it combines the biomechanical information with the pachymetric progression to calculate the Corvus biomechanical index. Here we have certain other understanding of ARTH with corneal deformation parameters, and it's based on 5 dynamic corneal response parameters, which gives us a score from 0 to 1, where 0 is a low ectasia risk and 1 is the high ectasia risk. And the cutoff value for CBI is 0.5. And it is known that it correctly identifies 98% of keratoconic cases among the normal with 100% specificity. Here you can see that this is how the Vinciguerra screening report looks like. And now we also have the TBI, which combines the tomographic as well as the biomechanical data to enhance ectasia detection. And the cutoff here is 0.79 with 100% specificity, and it helps to detect clinical ectasia. For eyes with a normal topographic pattern, the cutoff is 0.29 with 90% sensitivity and 96% specificity. This is how the maps look like. Here on one side we have the biomechanical assessment, and on the other side we have the pentacam tomographic assessment, and both are combined to give us the TBI values. The other important parameter also, which is now becoming popular, is the stress strain index, which gives us the elastic property of the cornea. And this helps especially when we are doing the corneal cross-linking before and after a refractive procedure, or even in cases of keratoconus, because we need to understand how effective the C3R procedure is. And here again we have if it is too soft, then the SSI is less than 1, the curve shifts to the right. And if it is too stiff, the curve shifts to the left with a stress strain index of more than 1. This is how the image looks like of the SSI. And this helps us once again to follow up our patients who have undergone the C3R procedure. The other procedure which also would be considered, which is the LASIK extra, especially in certain cases where you want to combine it with the cross-linking, especially in these thin corneas, where you have a borderline topography between LASIK and PRK, or in cases where you want to do an enhancement in LASIK, or when you get an unexpected thick flap and you are not sure how the cornea is going to behave. So in this, you can do a LASIK extra where you combine the LASIK procedure with the corneal cross-linking in the flap. The relax smile is again a flapless procedure, small incision, 4 millimeter, where lesser nerves are transected, and here it's more precise, and it's again a single step procedure and is minimally invasive. But here, once again, the Corvus ST has shown, and it has compared the corneal biomechanical stability after the smile procedure as compared to the LASIK, femto-LASIK procedure. Although it appears that it is theoretically a stronger cornea post-smile, but it is known that this cap cannot contribute significantly to the corneal strength, and therefore there is still some real risk of ectasia in both the procedures. So there is no clinical evidence of a better biomechanical behavior in smile procedure versus the femto-LASIK. But last in our armamentarium, we have the phakic IOLs for these thin corneas, where you have even the slightest of the doubt of having a corneal problem with a refractive procedure on the cornea. We can fall back to the phakic lens procedure, which is more cornea saving. It is reversible. It preserves the accommodation, and you can treat even the higher refractive errors where you have a slightest of the doubt, and even more than 8 diopters, and with corneal thicknesses of less than 480 or even 450, where the cornea seems to be unstable. So the decision tree would go if you have a thin cornea with a normal topography, and if it's a high myopia, think of a phakic IOL. If it is a low myopia, you could do a femto-LASIK, smile, or a PRK procedure. However, if it's an atypical topography with a high sphere, you can do Intacs with cross-linking, or if it's a low sphere, then you could still do a surface ablation, femto-LASIK, or a smile procedure. You could even combine it with a LASIK extra. So in conclusion, careful evaluation of all topography of all the eyes with thin corneas, with use of the Corvisty if it's available and the Pentacam, and an abnormal topography still remains a concern in thin corneas. So Corvis ST has a significant role in demarcating physiologically thin corneas from weak thin corneas, and by taking all possible and acceptable parameters into consideration, if the stromal, residual stromal thickness achieved is more than 300 microns, then one can go ahead with a surface or with a LASIK procedure. And phakic IOL still rests to be an effective alternative for high myopes. Thank you very much.
Thank you, sir. Thank you very much. And I think because of the time, we will directly go on to the next presentation. I would like to invite Dr. Milind Pilekar, sir, who has been the past president of March Ophthalmological Society. He is going to speak to us about a peculiar issue which may happen sometimes after LASIK, which is the epithelial lymph growth.
Yeah, may I, thank you very much. May I ask Dr. Nikia? So I'll start sharing the screen.
We can't see your screen. Yeah. Yeah, fine.
Thank you very much. And I would like to share my thoughts about LASIK, post-LASIK rare complication. It's a relatively uncommon complication in LASIK. Incidence is very low, 1% in primary cases, whereas 2% in enhancement cases, especially in microkeratome-assisted flap creation. It is less with femtosecond assisted flap creation, and it is usually asymptomatic and may lead to decreased vision due to irregular astigmatism and direct intrusion of cells into visual axis. In my small practice, 5,500 cases done so far, I have come across only 2 cases where it required an intervention. That is, it was crossing the visual axis. So it can be staged into 3 grades. The grade 1 is very thin ingrowth, very limited to peripheral cornea, that is within 1 to 2 millimeters of the flap edge. It requires no treatment. Grade 2 is thicker ingrowth. It has discrete cells evident within the nest, and it is at least more than 2 millimeters from the flap edge. And individual cells are translucent, but can be easily seen on the slit lamp. There is no urgent treatment required, and it can be treated within 2 to 3 weeks. But the stage 3, which is a pronounced ingrowth, a severe cell thickness, it is greater than 2 millimeters from the flap edge, and obvious on a slit lamp, wide geographic areas of necrotic epithelial cells can be seen. Corneal flap margins rolled up and thick whitish gray appearance is seen. It progresses in large areas of flap melting from the collagenase release, which is from the necrotic epithelium. And it gives confluent haze, which is the peripheral, and the flap pulls away. So it requires urgent treatment, and close follow-up is required for the frequent recurrences. So these are some of the examples which you can see, which are crossing the pupil. Rest of them which are not crossing, they are non-dangerous and can be left alone. So I share my case, which was 23 years male, underwent LASIK uneventfully 1 year back. He complained of pain and gradual diminution of vision, we thought it as corneal infiltrate, and scrape treated as a bacterial infection. There was no response. So we re-evaluated on OCT and thought that it is some case of infiltrate. So we lifted the flap, and as you can see, there are multiple layers of epithelium. You can see that I am lifting up one particular layer with the
Vardhaman, can you mute everyone and then unmute Milind?
Mr. Sai, can you please mute everybody?
Here you can see the epithelial layer, which is come up. one more epithelial layer sticking to the undersurface of the flap. That also I'm trying to remove. Because unless you remove all the layers, regrowth chances are more. So now you can see that the cornea is relatively clear. I'm removing the tags from periphery also. See, now you can see that the cornea is clear, and you can see a small defect in between from where the scraping was done, thinking that it was a bacterial infection initially. Bandage contact lens was put at the end of the procedure, and pre-treatment visual acuity was 6/18, and post-treatment after about 6 weeks, the visual acuity rise to 6/9 uncorrected. So this was the day 1 post-op. Thank you very much.
Thank you, sir. Very interesting case, and I think you must publish it. It's very unique.
Yeah.
Thank you very much. And I think we will move on to next exciting presentation by a very good friend, Dr. Rishi Swaroop from Hyderabad. He's going to talk to us about the resurrection of surface ablation, that is PRK or trans-PRK. Over to you, Rishi.
Thank you, Vardhaman. And I'd like to take this opportunity to thank BOA and MOS for this wonderful opportunity and much welcome distraction in these troubled times. I hope my screen is visible.
Yes, sir.
I've taken the liberty of slightly modifying the topic. So what I thought was more appropriate, trans-epithelial surface ablation, which is basically, I feel, a resurrection of the first corneal refractive procedure, which is PRK. And that's what my topic is going to be. So I had done a few years back, a kind of analysis of the refractive surgeries that I a few months back, analysis of refractive surgeries that I'm doing in my clinic. And as you can see, almost 2/3 of all my refractive procedures are surface ablation. And this is certainly the most predominant procedure in my practice. And I'll try and make a case for this in my subsequent slides. Recently, there was also a survey conducted by the IRSI and Corneal Society of India. And they also found a similar kind of reflection that surface ablation is, of course, the most common procedure performed, but it is increasingly becoming the procedure of choice over other procedures in people who have access to other technologies as well. So what is the difference between PRK and trans-PRK? So we must understand that both are surface ablation. The traditional PRK, we used to remove the epithelium either by mechanically debriding it or loosening the epithelium with alcohol and then removing it and then ablating the cornea. What we do in trans-epithelial PRK, trans-PRK is one of the brands used by one of the companies, but we have Translite from another company also. Essentially, all these technologies, what they are doing is they are using the laser to remove the epithelium instead of removing it mechanically. And the procedure is done as one step. There's no delay between the removal of epithelium and the performance of the ablation for the refractive correction. So because it is one step, it is faster and the epithelial defect size is slightly smaller. What you should notice in the video is when you're ablating the epithelium, the laser spots are visible in a different color, and when you start reaching the stroma, they change to red. So epithelium appears blue and the stroma appears red. So that's how you know that you have transitioned from the epithelium to the stroma. So this is just an animation showing you the same thing. As you can see on the cartoon on the left side, in traditional PRK, you would have to do first a PTK. If you were to do a true trans-epithelial PRK, but using a machine which didn't have that technology of one-step trans-epithelial PRK, you would first do a PTK and then you would have to do a PRK. So what you would end up doing is you would make a larger epithelial ablation, and most of those older machines would just give you one flat 50, 60 micron correction, which is same at the periphery as well as the center. Whereas the newer machines now are able to give you like a customized epithelial removal, which may be different in the center and the periphery, and the epithelial defect will match exactly the size of your ablation zone. So smart surface is one of the technologies which is present in the Schwind, which is the machine which I use. So it uses a patented technology called Smart Pulse, which gives you a very smooth bed after the surface ablation using some sort of software interventions. So why should one be doing a single step transepithelial ablation? It's a shorter procedure, smaller epithelial defect, faster epithelial healing. It's effective, gives you very comparable results with other refractive procedure, and avoids the need for epithelial scraping and alcohol usage. So it significantly hastens the procedure, and also has lesser complications because you're not using any mechanical debridement of the epithelium. So chances of recurrent erosions, etc., is much lesser. And one must remember that epithelium is the best masking agent. So if you have some irregularities on the surface, the epithelium is actually smoothing it out. When you remove the epithelium to perform an ablation, you're losing that advantage of epithelial smoothing. So it's always best to remove the epithelium with a laser. And of course, we all know the problems that other procedures have. And because you have no flap or interface, you are certainly avoiding all of these. This was an interesting study, showed the epithelial healing and clinical outcomes with different types of surface ablation. And you can see that the trans-epithelial PRK certainly gave you a faster healing, and that thereby reducing the postoperative discomfort for the patient. So I told you about this two-step versus single step. Main advantages being the shorter duration, so lesser chance of desiccation also, because there is lesser chance of corneal desiccation. Your refractive outcome will be better. You will have lesser hyperopic shift. And because it's a smaller epithelial defect size, your healing will be faster. Patient will be more comfortable postoperatively. Epithelial thickness maps also are very useful now, which are available. So once you have the epithelial thickness map, you can actually custom plan your epithelial ablation in the newer platforms like the Schwind Amaris. So that is very useful because not every patient has a similar thickness of epithelium. Some may have about 40 microns, some might have 60 microns. So you can actually customize it, which really helps you to make your outcomes much better. Now, tissue wastage can occur if you end up removing too much. If you plan to remove 50 microns of epithelium, but actually the epithelium is only 40 microns thick. So that is something which you can certainly avoid if you have a epithelial thickness measurement using the OCT, which is now widely available. Optic zone planning is very critical when you're doing trans-epithelial PRK, especially if you have a small refractive error. It is recommended to go for a slightly larger refractive error, otherwise you'll end up with undercorrections. Surgical pearls, it's important. Main thing in trans-epithelial PRK is that the surface should be just the right amount of dry. It should not be too wet, otherwise you'll have undercorrections. If it's too dry, overcorrections, and if you have too dry, it can be overcorrected. If it's too wet, it will be undercorrected. Topography guided ablations are certainly useful in specific indications, and I'll just touch upon them later. And Smart Pulse technology is one of the new software developments in Schwind, which actually gives you very good immediate postoperative visual improvement. So immediately on the first day, the surface is so smooth that the patient can even read 20/20 unaided. And that gives you the wow factor which you were earlier missing in surface ablation. So this is just a video to show how the laser color changes when you pass from epithelium to stroma, and of course mitomycin, etc. The rest of the steps remain the same. It also helps to reduce pain significantly. Many of these patients are much more comfortable than our traditional PRK patients were. And other measures one can use are chilled BSS and use of NSAIDs. I'm sure Dr. Gaurav will cover these in the next talk. This was an interesting study which showed that the trans-epithelial PRK performed much better on dryness, severity, soreness, sharp pains, stickiness. All these were much better off in the trans-epithelial versus the alcohol-assisted PRK. There are some studies from Europe which showed that even the haze is much lesser, and of course, mitomycin C helps to stretch the limits, and people are even performing up to 10 diopters with surface ablation now without much haze using because of the use of mitomycin C. So in addition to traditional indications, specific indications where trans-epithelial PRK I feel has a role is when you have an irregular cornea, be it from scar or a post-keratoplasty, post-refractive surgery, or even when you're doing a combined procedure like cross-linking in a patient with keratoconus. So I'll just quickly show you some cases. So this was one patient post-LASIK, had a small refractive error, and instead of relifting the flap and disturbing the interface, simple thing to do in most of the post-LASIK cases is to just do a surface ablation. Of course, you have to use mitomycin C whenever you're doing surface ablation on top of a LASIK flap. Unlike traditional thinking where it was banned to do surface ablation, now many people are doing these with very good outcomes, and I think mitomycin C has made the difference. So this is just to show that patient had wonderful clear cornea. You can't even make out that anything has been done. Again, post-keratoplasty, fabulous results. You can see the topography changes beautifully. Main advantages with topography guided ablations, you can regularize the cornea, improve not just reduce the refractive error, but also improve the uncorrected and best corrected vision. And I have a long series of post-keratoplasty surface ablation, and all of them are doing so well. This is another patient who had a post-RK. You can see the refractive outcome is very good. And here we have actually managed to correct about 5.5 diopters. And you can see the change in the power difference map. This was just another interesting case I done recently. This was a patient who had a FALC for granular dystrophy, superficial granular dystrophy. You can see the best corrected vision after the FALC was very bad. Patient is 618, very unhappy with the distortions. And you can see the topography is so irregular. So we did a topography guided ablation in this patient and a custom ablation, as you can see. And patient did really well. You can see that the cornea topography has become very regular. The vision improved to 6/6 with a small refractive error. This is just another patient with a keratoconus. You can see bilateral keratoconus, typical epithelial thinning in the area of the cone, and you can see the decentered cone. And you can see after a combined cross-linking with topography guided ablation, patient actually got a fantastic result of 6/6 and N6 unaided in both eyes, which I wasn't planning for because I had undercorrected. But patient is extremely happy. And you can see even the epithelial thickness map shows a very uniform kind of surface, even though of course the pachymetric map shows the inferior thinning. So trans-epithelial PRK is here to stay. It is the actual true blade-free laser because you're not even touching the cornea. It's an all laser procedure. I think it has certainly helped in the resurrection of PRK. Thank you.
Thank you very much, Rishi. I think it was an excellent presentation, and certainly the surface ablation is making its waves back. But one thing which doesn't help the procedure, of course, is the pain, and that's why we have the next talk, which is going to be by Dr. Gaurav Luthra, the German ARC of IRSI and the past scientific committee member of AIOS. And he's going to speak to us about the pain-free PRK. Is it a myth or it is a reality? Over to you, Dr. Gaurav.
Thank you, Dr. Vardhaman, and thank you, BOA and MOS, for inviting me, and very interesting program today. So this is something which has been close to my heart last few years, working on making PRK painless. So, and Rishi has done a great job of telling us about the trans-PRK, which has been one of the major things for making painless PRK possible, among other things. So we've seen how refractive surgery has evolved. So we've now reached a situation where we have several options available to us, and patient has a choice, surgeon has a choice, and no one thing fits all. So PRK procedures, we've gone from alcohol-assisted PRK to LASIK to epi-LASIK and then trans-PRK, and now there is renewed interest because PRK seems to be superior in biomechanical stability and refractive stability as well compared to many other procedures, and from the point of view of safety. So the advantages we all know. I will not go into them because Rishi has already covered these different situations where PRK may be much better. And Ectasia is extremely rare. I think that's one thing which really stands out for PRK compared to even SMILE and LASIK. But there are limitations, and discomfort is one of them. Longer period for visual recovery was thought to be one of the important things. We've tackled that quite a bit now. and haze, which has been really well managed with the use of mitomycin over the last 15-20 years, as Majmudar and Randy Epstein's work on that. And again, initial concerns on regression, which have now been taken care of with modern lasers. So the current status of PRK is that haze is extremely rarely seen now, and refractive stability has become excellent. But then what holds us back from doing more PRK? So pain, I think, is the thing, and most surgeons that I know who don't do PRK end up telling that patient discomfort is something which drives them away from PRK, and I thought I will address that. So pain can be of three types: inflammatory, nociceptive, or neuropathic. And there's been a lot of ways that we can manage pain in such situations. We've tried pharmacological interventions like opiates, comfort drops like topical anesthetics, which are very popular in the US, but in India, we tend to shy away from them. Topical NSAIDs have been used after refractive surgery, oral analgesics, oral bolus steroids, and then, of course, something which worked wonders for pain management when it came about for the first time, till the time that people used to be bandaged for first few days in both eyes, is the bandage contact lens, which happened almost 20 years back, but has been a remarkable improvement in PRK management. And then, of course, corneal cooling with chilled BSS, and even some people use ice packs. So ice packs have been used quite popularly in the US as well, and some people in India use them. But some studies say that there was almost no difference between using ice packs in post-PRK pain. So we started using BCL soaked in AccuVale or ketorolac 0.4% almost about 3 years back after the initial studies. This has been tried before, but was enthusiastically taken up by Narayan Nitrale under Rohit Shetty's team. And I happened to visit for one of the meetings 3-4 years back and noticed this and came back and tried it, and it immediately worked wonders for us. And this was a publication from their group on pain management after PRK, where they evaluated the role of 0.45% ketorolac soaked contact lens. And they concluded that it can work as a nice depot, which can reduce pain after trans-epithelial PRK or any kind of PRK for that matter. So our experience has been good, and we now use, because AccuVale became out of the market almost a year and a half back. So there was this new alternative which was available. I have no financial interest, but I did trials for this drug about 6 months back. Seems to work as well as AccuVale, which was from Allergan, and this is from I think yes, Endot, and it's worked quite well for us. It works almost similarly to AccuVale. We have about 50 odd patients tested on AccuSaid now, and we empty out the fluid from the blister pack of the contact lens, and then put in these few drops of AccuSaid, and then soak it for about 5 minutes. In Rohit Shetty's study, they had done it for almost 30 minutes, but we find that doing it even for 5 minutes is good enough and effective. And then once we have completed the ablation and done the mitomycin application and irrigation, we just put in this contact lens. It works wonders for the patients. And some of the other important steps which Rishi already mentioned, chilled BSS right after ablation, we use mitomycin. Now this has no relation to pain control, but I think mitomycin has really worked wonders for making PRK more reliable and effective and minimizing risk of haze. And then of course the bandage contact lens. I'm sorry. So we also, for those of us who don't have trans PRK on their machines, this is another great option. In fact, alcohol used to cause a lot of pain and discomfort and reaction to patients' eyes. We use the Amoil's brush a bit, and I've been using it for about 10 years. I stopped using alcohol almost 10 years back. It's quite remarkable. And it takes off the epithelium very effortlessly, and the amount of reaction and pain and discomfort is much, much less compared to alcohol. There's a huge difference. And then to the next level, if you want to go to the trans PRK, that it goes to the next step. And we are using a lot of trans PRK now with almost about 130 eyes of trans PRK. So, however, as Rishi emphasized, trans PRK requires epithelium thickness mapping to be done to customize your surgery properly. And the post-op pain and healing is much faster, pain is much less, and patient's visual rehabilitation is much better. So this is again another step towards making painless PRK possible. Some patients, I'll be finishing in less than 30 seconds now. वगैरह कितनी हुई आँख से? खास वाटरिंग नहीं हुई, पेन कितना हुआ? अब क्लोज एंड शो द फेस आल्सो नियरबाय. अब क्लोज एंड शो द फेस बिकॉज़ आईज के आसपास कोई स्वेलिंग वगैरह कुछ नहीं है ना. एंड मॉर्निंग में उठ के आपको ठीक लग रहा था? आईज आराम से खुल गई थी सुबह उठ के? और लगातार ऐसा तो नहीं हुआ कि आईज के पास सामने? Okay. Second last thing. So vision is almost 6 unaided or 6-9 day one. You cannot make out comparing to your smile or LASIK patients if which of them went PRK. Otherwise, you would have eyes lid edema and reaction and swelling. So they do quite well. This is the other post-op regime. We start topical steroids right after the surgery. Tell the patient to start it few hours after the surgery, and vitamin C and strict UV protection. I think this is the key for preventing haze. And topical steroids are the key for 6 to 8 weeks. So there are cautions when you use NSAIDs. You should be careful about possibility of SPK, and there've been reports of corneal melts, but not so much with ketorolac, and it may lead to delayed epithelial healing sometimes, which is very rare. So I think Rishi has covered epithelial mapping, so I will not delve on that, but I really trust epithelial mapping for all my refractive surgery, and we do follow-ups. So PRK, for many surgeons, it's just 5 to 10% of refractive procedures, and many surgeons don't perform PRK at all. But I think if pain is looked after, as we've shown, many surgeons will start doing PRK, more often. And Rishi has reached that level of 60-70%. For me, it is a little less, but I still do about 20% of my practice as PRK, and I think Smile occupies a little bigger volume than that. And LASIK has really become a very, very small part of my practice. So I think with that, I'd like to stop.
Thank you very much. I think Dr. It was a brilliant talk, and certainly both Ocastel and Octi said both have really transformed the surface ablation practices for many of us. I would agree with all your points. Thank you again. And because of the lack of time, very quickly, I would like to request Dr. Partha sir, Dr. Maskati sir, and Dr. Nitin sir for very quick concluding remarks, and then we'll conclude the session. Thank you.
Thank you very much, Vardhaman. I think we have covered a very large number of topics in a very short while, and each of the topics had very good take-home points. And I think all of us have benefited rebrushing our strategies, as well as thinking about the newer strategies, the new equipment, which would add to the practice of refractive surgery. Thank you very much for having me in this program of yours. Thank you.
Thank you, Partha. And since Vardhaman, we are really running short of time, if we unfair to the next session, Nitin and I will not speak any further, and we'll straight away hand over to the next. Ragini, over to you.
Thank you, sir. Thank you so much, sir. Thank you, sir. Thank you, Partha, sir. Thank you, Maskati, sir. Thank you, everyone. Be safe, be careful, and we pray for everybody. Thank you so much. Dr. Mahipal Sachdev, sir, is the chairman of the next session with Dr. Lahane, sir.
Yes, yes. Good morning, everybody. Thank you very much.
Good morning, sir. Good morning.
Good morning, good morning. Thank you, everybody.
Well, good morning, Dr. Lahane. It's a pleasure to see you in the TPL for VP 2021 conference.
Sir, thank you, sir. Good day, sir. Thank you, sir.
Total practical learning for value addition to practice 2021.
Thank you.
Brilliant, Quresh, brilliant.
Amar, there is no other. I mean, it is a value added. The whole thing it just fits in.
I agree 100%. Don't worry. What an apt coincidence.
What an apt coincidence. It's just complete coincidence.
But only Quresh could have thought of some brilliant ideas.
Amar, coincidence by Quresh.
I know. Imagine, superb.
Please proceed, sir. The session is yours. I'm signing out.
Why you are signing out? You can stay back, na?
I can stay. Okay, okay.
Yeah.
Good morning, everybody, and welcome to this session. Good morning, Dr. Lahane. Good morning, Amar, Dr. Kulkarni, Aditya, and Preetham, and all other participants. We go on to the second session on refractive, and we have a large good speakers, I think, from all over India. And I think congratulations to BOA, Maharashtra Ophthalmic Society, Dr. Lahane, Ragini, and everybody else for putting this program together. I'm sure this session is going to be a wonderful session with all the good speakers. So without any further delay, I'll just request the first speaker, that is Dr. Partha Biswas, whom we all know as the chairman of the Scientific Committee of All India Ophthalmological Society. A great individual, I would say, a great human being, and above all, somebody who has dedicated himself to the field of cataract and refractive surgery. So he's going to talk about LASIK surgery in the current COVID scenario, the dynamics of practice. Dr. Partha, all yours.
Thank you very much, sir. Are my slides visible, sir?
Yes, yes, we can see you, sir.
Thank
Yeah,
you.
slides are seen and even you're audible.
We'll start right away. I think we've exceeded the time from the previous session. So,
Yes.
Will, can you hear me? I seem to have lost the screen.
Yes.
Yes, sir. I can hear you. Can you hear me? Can everyone hear me?
I think there's a lot of sound disturbance.
Someone, if he has logged in, it would be appropriate.
Can I request the others to mute their mics, please?
Yeah, there is somebody from the admin whose voice is echoing.
Okay.
Yeah.
I think it's fine now, sir.
Yeah, perfect.
Yes.
Perfect.
So thank you very much, BOA, MOS, Lahane sir, Ragini madam, for having me in this program. It's been a wonderful first session, and now we come to the second session of refractive surgery, which again brings us to the next scenario. So in the current COVID scenario, LASIK surgery and the dynamics of practice, what is it? How is it different? In the first wave of the COVID, we had a large number of risks which we dealt with, and a lot of thought processes went in. And it was predicted that the COVID would take a very bad toll on the refractive surgery practice. But did that really happen? Well, most of us came back to our refractive surgery practice quite early than what was predicted. And this was the scenario. Today, with the COVID update, number of active cases with over 37 lakhs, and India's the second wave of pandemic is a catastrophic wave. So with these things in mind, do we still have the refractive surgery, and how do we practice it? So the AIOS came up with the preferred practice patterns of the refractive surgery during the COVID pandemic, and we had a lot of learning from this. Today, the most important question is it safe to do refractive surgery? Is it safe to do LASIK? And how do we keep afloat in the LASIK practice? Again, should it be performed during the pandemic, and what precautions do we take? So this was included as a non-urgent category of ophthalmic procedures per guidelines published by the IGO, and most surgeons were reluctant to perform during the lockdown. We witnessed there was a normalcy over the last 6 months, no new guidelines for the second wave we have as yet. But there has been a lot of learning from the first wave and what we have done, performed, and the values that we could edit in the LASIK practices. So is it safe to continue with elective procedures? What risk does the refractive surgery hold today in the second wave? And is LASIK an aerosol generating procedure capable of transmitting COVID? Can it transmit live virus? The answer is in the 1997 study. And this was a study in which it so said that the excimer laser ablation plume does not appear capable of transmitting live virus, and this was done on the HIV virus. So the virus attaches itself to the ACE2 receptors and the corneal epithelium, the cornea, conjunctiva, and are the possible sources of infection for the SARS-CoV-2 virus. It may be present in the tear film and in the aqueous humor. So what do we take as the general measures? So let's go on to the points. The staggered appointments, very important. History of any symptoms of COVID, temperature by non-contact, social distancing norms to be strictly followed in the areas of reception, pharmacy, waiting areas. Let us remember once again that this is a procedure that might be aerosol generating, and the transmission of COVID today is mostly through the transmission through the particles in the air. So all patients and attendees and the staff to fill in the COVID declaration form, doors and windows to be kept open in the waiting room as much as possible, surfaces to be cleaned periodically. The pre-operative guidelines. So the examiner should wear gloves, protective glasses, protective gowns, change of gloves between each patient while performing refraction, avoiding touching of the forehead, the trial frame, the pinhole occluder, and all lenses to be cleaned between patients. Breath shields for slit lamps as barriers for the patient and the examiner to be used all the time. Measurement of IOP using the Goldman applanation, and the prism to be wiped with alcohol between the cases. Corneal topography is a quick, non-aerosol generating procedure and non-contact. So the intraoperative guidelines let us adhere to. We might have slacked down on these guidelines in between the first wave and the second wave. Let us reinstate. The use of N95 mask, the triple layered mask, or the surgical scrubs, caps, the sterile gloves, and protective goggles are important along with the disposable gown, both for the surgeon and the assistant. The COVID-19 consent form for the surgery to be duly signed. And here we see the flow of the patient as the patient comes in, both the patient and the attendant, who have to be in particular social distancing, and they have to have the firm protocols very much in place. So the patient comes in, the taping of the nose is important, and the patient should be wearing the disposable gowns, as well as the attendants should be wearing disposable gowns. The ocular surface wash with 0.25% povidone iodine 10 minutes prior to the surgery. And let us remember, this povidone iodine has to be removed with well-amounted irrigation before the LASIK procedure. The patient well draped under aseptic preparation. The eye drape pouch. The eye drape pouch is important and has to have the 10 ml of 5% povidone iodine solution, which ensures the sterilization of the solution used to wash the stromal bed for any secretions from the ocular surface which might get washed into the pouch. Also, it protects the healthcare workers and involved in the disposal of drapes, minimal instruments to be used on the surgical trolley, and the drying of the ocular surface thoroughly by sterile dry swab before starting the surgical procedure to avoid any pooling of the secretion. And this could be a potential source of aerosol and should be avoided at all instances. The monitor for the visualization of the flap creation instead of looking through the microscope, and use of the monitor while the excimer laser is firing to avoid exposure to aerosols. And while washing the bed, the practice of simultaneous drying of the ocular surface with other hand using a sterile Mercel swab to avoid pooling of the solution. So this is the flow that we have. And immediately post-usage, immerse the instruments and disinfect them in solutions of lysoform and other solutions. At the conclusion of the surgery, using of sanitizers to disinfect the gloves. Descrub after every case. If a disposable gown is being used, should be discarded after every case. Ensure change of sheets and cleaning of the patient while disinfecting of a holding time of 15 minutes. The surrounding floor also should be wiped and allowed to dry. Microkeratome assisted flap creation has a little more aerosol dispersion as compared to the femtosecond laser, and this is also important and has to be taken care of. Post-operative guidelines, these are routine instructions and medications that can be given. Early tapering of steroids if they are used, the IOP measurement if needed using the Goldman stonometer, and consider keeping the post-operative follow-up visits minimal. And here is the importance of video consultation for any post-surgical problems, which may be minor, but of course to be seen if the patient has major complaints. So to conclude, the pandemic is here to stay. Refractive surgery, let's just continue. Till date, no evidence of spread following refractive surgery, but diligence and all precautions to be taken. Thank you very much for your patient hearing.
Thank you very much, Dr. Partha. Any comments from any of the co-chairman, convener? Well, the studies that have been done essentially, as Dr. Partha has said, there has not been any significant report of transmission specifically after laser vision correction. And the povidone iodine, which is being, which Dr. Partha has rightly said that if at all there are any virus particles in the tear film, it really takes care of that. But one of the observations that at least we are seeing that the number of patients with conjunctivitis in the second wave is much more than what we had in the first wave. I don't know whether it's seen by other people or not, but there are a lot of patients who are COVID positive. Actually, there are 2 patients who first came with conjunctivitis, and I told them to get the COVID test done, and they turned out to be COVID positive. So the number of cases with conjunctivitis with COVID are at least maybe the numbers overall are more or what, but at least I am seeing, or we are seeing, more cases of conjunctivitis. I don't know if anybody has any similar observations.
So quite true, sir. Quite true. Yes, yes.
I think this is quite true. And also we've seen 2 cases of post-COVID vaccination conjunctivitis. So I don't know how many people have seen that, but it is quite true that conjunctivitis has increased more in the second wave than as compared to the first one.
So I think that is obviously it is the povidone iodine is something very good, and then there is no aerosol generation in such specific procedures. For example, in the SMILE procedure, there is no aerosol generation which is there. So I think that also is something that one needs to take care of. But whatever Partha has shown as the precautions, they are pretty apt, and if taken, I don't think there will be any great chances of transmission. Dr. Lahane or anybody wants to say anything? Dr.
Yes, Maipal sir, what you are saying about the conjunctivitis is true. But in Maharashtra or in Gujarat, if you can say, we are also getting the mucar mycosis in a big number. So that is there, and even in such situations, exenteration is also burden in few cases. So I think the ophthalmological involvement is more in the second wave.
Yes, sir. That obviously is because of the immunosuppression that is there, that the cases of mucor, orbital mucor, etc. have significantly gone off. And we have also reported from Delhi 6 cases of late post-operative fungal endophthalmitis, endogenous fungal endophthalmitis. So overall, those are the things which definitely are there because of the use of the steroids and the toxicum. That is all are immunosuppressants. So there's these cases, the black fungus as it is called, is definitely on the increase. As also endophthalmitis in 6 cases we have reported. I don't know whether anybody else has seen or not, but recalcitrant inflammation which is there in the posterior segment, I think we need to rule out, and in those cases we have been able to find the fungal endophthalmitis. I don't know, Preetham is here, maybe.
No, we have seen endogenous endophthalmitis on at least about 5 to 6 cases, and these have been typically cases which have had hospitalization, hospital stay for more than a week or 10 days. So these are inpatients probably which have been kept on steroids, and been given to even some immunosuppressives. These are the ones probably who are developing these sequelae.
Yes. In case there is no other comment, then we can go on to the next speaker. I think Amar, everybody knows he is somebody who's always done India proud and has come out with, I think he's one of the sharpest minds in ophthalmology, and he thinks through a lot of things and comes out with every other year or every year with something new which puts a mark in world ophthalmology, and rightly so. He has always been recognized in the top ophthalmologist, the power list of 100 in the world. So Amar will be talking about his Kapadia can, yeah, thanks. So he'll be talking about his new love, I would say, his new passion, which he is doing great wonders, and that is on pinhole pupilloplasty. So over to you, Amar.
Thank you very much, Mahipal. I'll just start sharing the screen first. And let me know if the video is coming on. What happened to my video? One second.
Good morning. Till Amar sir is starting, I want to just inform everybody that we have around more than 3,000 logins as of today morning for the program.
Madam, and our registrations are about to reach 5,000.
Great. Yeah, Amar,
are you seeing the video now?
Yeah, we are.
Yes,
You can
okay.
start now.
So let
Make
me
it
just
full
see.
screen.
I'm wondering why is it not going? Yeah, now it's gone full screen. Now you're seeing it?
You can play it now.
Okay, fine. Thank you.
Thank you.
So basically, first of all, before I start, my idea is to first of all congratulate Ragini and Lahane, Professor Lahane, and the entire team there, Preetam, Quresh, for doing such a great job. Now let's move on to this topic for BOA and MOA, which I've done, is pinhole pupilloplasty. The question is, when we started pinhole pupilloplasty, we were making everybody at 1.5 to 2 millimeters. And I first spoke this a little bit in Namrata's conference. Now I've taken it to a slightly next thing to make it more accurate. This particular patient, let's understand, came to us from Singapore. Now the patient had a cataract done, PK done, and if you notice, we had done a pinhole pupil with the cataract surgery. But notice carefully here, post-operatively, the Purkinje image was not centered. The patient has a 13-diopter astigmatism, but with that, if you notice now in this picture here, look at the Purkinje image. It is not centered. It should have been centered, whereas here the pupil is absolutely decentered. Basic mistake is mine. So the first thing to make pinhole pupilloplasty more accurate, remember one thing: when you make the pupil, please focus on the Purkinje image P1, because your pupil has to be on it. Now, once we have done that, in this case, there was a refractive surprise also. So now the problem which we had was to correct the pupil correction. On top of that, to do an IOL exchange through the pinhole pupil. Now we can see we are cutting off the sutures there. Once I'm cutting off the sutures there, from the side, somebody is holding with an endo illuminator so that I can see better. Now the next step is to take this IOL out. Now, I was not sure whether we can get a PCR or not in this case. So just to be on the safe side, we also prepared scleral flaps, though we didn't make it enter into it, but just kept it ready so that if there is a rupture or a rent, we can always do a glued IOL. But luckily for us, it did not happen. So now we have removed the IOL. Look, the capsule is intact. Now we put the correct IOL in place. Now, once we put the correct IOL in place, again, we have to redo the pinhole pupil. So now you can see the IOL gone inside. Now I have to make the pupil correct. Now remember, this technique is the single pass 4-throw pupilloplasty. It's a very simple procedure which anyone can do. The idea is again simple, making the pupil smaller and smaller till the Purkinje image becomes centered on the pupil. And you can see if you have made it too small, you can put fluid into the eye, chew it up with a vitrectomy so that the pupil comes bang on track. Now look at the Purkinje image. Compared to the previous image, the patient is absolutely correct. There's a small mistake, and another mistake which I did here is the pupil is a bit large. It's 3.5 millimeters. The patient, from counting fingers in the first surgery, improved to 660. But look, Purkinje image is centered, but pupil is large. Now, what I'm going to show you is how do you make your patients happy to create that extreme wow factor. So what I did was, I knew when we started pinhole pupilloplasty, we will be in trouble because my optics unit to be really solid in. So I contacted a person whom we worked with, is Jack Holliday. And we designed this instrument, which is the Holliday pinhole device. Now, what we do in this is, pre-operatively, whenever you have a patient, there are many holes, as you can see in this pinhole device. All you do is put it in front of the patient's eye, ask him to rotate or her to rotate. See which one she's happy with. Previously, I used to think that everybody will be happy with a 2 millimeters or a 1.5 millimeters. It is not so. Some patients might be happy with a 1 millimeter pupil. So in this particular case, when I did this pre-operatively, I found the patient very happy with a 1 millimeter pupil. So now I knew from 3.5, I have to make my pupil 1 millimeter. Now, take the patient inside. Now, question comes, how do you check intraoperatively the patient will have a 1 millimeter pupil? Remember one thing, whatever pupil you are checking outside is on the corneal level. That will be slightly lesser than the one on the internal level, which is internal will be a slightly lesser, smaller. So this is the apparent pupil. You can use the same pinhole device, and we're trying to make it better soon. Perhaps the next conference I'll make it better even for you. This is an autoclavable device, by the way. You can use this to check whether the pupil size is correct or not. Now take it even better. You have these Zeiss microscopes. These eyepieces can be removed. Once you remove them, you can put another one which has got a reticule inside. These reticule comes with the markers like this. And the simple thing is, if you keep your magnification at 1 millimeter in the microscope of, say, Zeiss, that circle which you are seeing is 5 millimeters. And this reticule, you can see the marks there. You will notice each small mark and big mark is there. The small mark and big mark together will become 0.5 millimeters. In other words, I can go up to accuracy of 0.25 millimeters. Now that you have understood this, what we are doing basically now is, I'm going to make this pupil from 3.5 to smaller. And then I want to know, because I've already checked pre-operatively, this patient needs a 1 millimeter pupil. Now, intraoperatively, I want to know how am I going to be bang on track is using either the Holliday device or using the reticule. Now, to do the single pass photoreoplasty, see what you're doing. Everybody now knows this technique by now. Simple way is passing the suture from one end to the other, tying it down like this. Remember, you need a paracentesis only on one side. You don't need on both sides, because the loop is going to come out only on one side. From the other side, you just go through the clear cornea. Now you can see 4 passes being passed into the eye there. Once the 4 things are done, the pupil is becoming smaller and smaller. Now, once you have made it absolutely small, it might become too small, as you are seeing right now. In this case, you will need a vitrectomy probe. So keep it in mind, keep a vitrectomy probe so that you can enlarge the pupil a little bit depending on your size. So when I said you want to make your pinhole pupil accurate, one is the Purkinje image. Look at the Purkinje image, it's bang on center. Second is you are going to check pre-operatively what pupil the patient wants and likes. And third, intraoperatively, either you use the reticule. It's a bit tough because the reticule we will see only through one eye, so you can use it at the end, or you can use the same pinhole device, autoclave, so that the same thing can be used in your OT and check whether you are bang on track to 1 millimeter pupil. And you can see now I'm bang on track there. And if you go around that Purkinje image, you will get approximately 1 millimeter pupil. So this is the way you can improve your surgical results in pinhole pupiloplasty. Now let's see how this patient behaved. Remember, this patient came to me from Singapore. This is post-operative day 3. And imagine how many times I've operated on him. I should be really a glutton for punishment. But if you see the picture on the left, this is the first thing which you saw. Patient has got a decentered pupil. My Purkinje image was messed up. Patient came to 1 meter counting fingers. We took out the IOL exchange because the patient needed an IOL exchange. Bang centered the pupil on the Purkinje image, but the pupil was too large, 3.5, vision improved to 660. Check the patient on the pinhole device and you look at the picture on the right, which is the end picture. Patient's vision improved to 612 and we made the patient very good with a 1 millimeter pupil. So basically what I thought today to cover with you people is on how I can make this particular pinhole pupiloplasty more accurate, and we thought this is the simple way to do that. Now, I'll just thing is to show you is we have also brought this out in various books of ours, as you can see here, which is Mastering Iris Repair, which we have published by SLAC, which not only covers pinhole pupillasty, covers fourth-row pupillasty, but covers many topics for iris repair, because today iris repair can also be a refractive iris repair. So I'd like to once again thank Professor Ragini, Lahane, Maipal, Partha, and all of you for asking me to come into this session of BOA. Thank you very much.
Amar, it is not asking you to come in BOA. You are part and parcel of BOA and MOS.
Thank you, sir.
Thank you, Amar. Thank you. Yes, Michael, go ahead.
Thank you very much, Amar. Any comments, Dr. Kulkarni or Kelkar or Preetham?
No, basically, you are always amazed at whatever he continues to think and show it to us. So it's really nice to have Amar showing us something new every time. Thanks a lot for that. No other comments.
Well, Amar, basically, I just want to ask you a couple of things. So what you have actually highlighted is the centration and pre-operative evaluation as to what the patient likes. How good is the pinhole that you put before the patient in the OPD? Like, does it actually translate in reality to that particular thing?
From what I've started with, before I used to make everybody at 1.5 to 2 millimeters approximately. And I tell you what, frankly, the patients were happy. But then, you know, they're very happy. There's no doubt about it. But then when I started seeing, can I take this game to the next level? And then I found that with this, I am definitely making them much better off. The question is to get that pinhole correct. So one is the pre-operative is very easy. The question is intraoperative to get it exactly correct. I feel reticule is the answer, but I'm trying to make it more simple with the pinhole device, so that you can just put it on the cornea and you'll be on track.
Okay. And as you have shown for the audience who is listening, you have shown several cases where irregular astigmatism, this could be possibly the treatment of choice, right?
Yes. Because I tell you what, Maipal, the point here is this. When you do corneal surgery, remember, it is complicated. Here, when you take a case like this, it's like your IOL surgery. Same day by evening, if I'm doing a case like this, you know, the people will just jump because they'll see immediately clearly. It's like an IOL surgery because you're not touching the cornea. Cornea surgery, whatever said and done, you know, it has its own problems when you have high astigmatism of this crazy levels like. Whereas when you're talking on the pupil or iris level, it's easy. And look at the cost. One more thing I want to tell everyone, it's just a suture. If you take a pinhole IOL against versus a pinhole pupillasty, remember one more thing. A pinhole IOL, I'm realizing more and more, is got a fixed diameter. One, it's not available, doesn't have FDA approval, that's one problem. But it's got a fixed diameter of 1.5 to 2 millimeters. Another problem in a pinhole IOL is when you put it inside, if the patient has a Uret Zavalia or something like that with a closed angle glaucoma, that cannot get solved. Whereas in a pinhole pupillasty, all these other problems also get solved because you brought the pupil down, so the angles which are closed becomes open angle.
Any thoughts on a corneal approach? If you can put a pinhole, an internal like the AcuFocus, etc., that was being put earlier into a stromal bed?
It's a very good question. And, you know, to be honest to you, Maipal, the first inlay, I'm not told officially, but was done by me when they flew down from America. And the patients were very good, the first two cases which we did. But I said, I'll not do that because I tell you again, the problem with these corneal inlays are once you're going into the cornea, the whole game changes. When you work at the pupillary level, you're very safe. What is the surgical skill required for a pinhole pupillasty? Let's give an example. If you know how to do fourth-row pupillasty, the whole game changes because it's so simple. All you need is a Prolene suture 90-10-0, and it's very simple. With Maipal's technique of using the scaffold technique for phakic eyes, I make them pseudo-phakic, but with that scaffold technique of Maipal's, you might be able to do it even in phakic eyes, because that's one bugbear in pinhole pupillasties. You are going to make the patients pseudo-phakic. But the other side is, if a patient is -10, let's say in high keratoconus or something like that, even that is neutralized by making them pseudo-phakic.
Okay. In case there are no questions.
One thing I would like to just add, Maipal, before we move to the next topic is, people who are doing penetrating keratoplasties in pseudo-phakic eyes, at least in Agarwal, I tell my team here, please do a pinhole pupillasty, because however good a surgeon is, you do not know whether these guys are going to go in for astigmatism or not. And you will see that wow factor immediately when the patient has a post-PK done, because the astigmatism is anyway gone.
Okay, great. Shall I, Dr. Lahane?
Go ahead, sir. Go ahead.
Okay. Well, thank you very much again. Once again, I've, as Dr. Lahane said, it's always a pleasure, and I feel that I am part of.
1 minute, 1 minute, 1 minute. I have not introduced you.
That's what I said.
Sorry. I invite Dr. Mahipal Sajeev, my best friend, and really doing a wonderful work. I think Center of Sight is also doing wonderful work, and excellent president for the All India Ophthalmic Society, doing excellent refractive and cataract surgery. So I now request Mahipal to present his topic, management of complications of refractive surgery. Dr. Mahipal.
Thank you very much, Dr. Lahane.
Another thing is he's honored Padma Shri also, that I have forgotten. Mahipal, go ahead.
Thank you very much, Dr. Lahane. Always a pleasure and a fantastic job as always, Dr. Lahane, Ragini, Preetham, everybody else in BOA. I'll be talking about complications of laser refractive surgery. As was discussed in the earlier session, there are the laser vision correction, and there is the PRK, etc. that is being done, and then there is the smile procedure that is being done. So we are looking at the complications which could be refractive, which I'm not going to be talking in detail because I'm making this more of a video based, and refractive could be under overcorrection. There could be central islands which are very rare, or induced astigmatism. There could be decentration. Nowadays with tracking and with the iris registration, this problem has been taken care of. There could be in the flap, that is what I'm going to talk. So these are a couple of things that can happen with the flap. So I'll just show a couple of videos. Now, when we are looking at the first thing, which is PRK, which is the excimer laser ablation, this is what was being done in PRK. Obviously, what Gaurav in the previous session talked about is post-operative pain, and that non-steroidal anti-inflammatories, etc. are being done. Epithelialization could be a problem, and there have been cases of corneal infection, etc. that have been reported when contact lenses are being put in some individuals. However, in our practice, we do put contact lenses post-surface ablation in all cases. Also, there was a problem which is the haze problem, which is correlating with the ablation depth, the ablation zone if it is very small, use of oral contraceptives, viral infections which have been there, and ocular surface disorders, and MMC has really come, that is there. Now let us come to certain complications. These are few videos which have been collected over the years, and apologize because some of them will be pretty old. These are the complications that are there related to the flap in LASIK surgery. Now you can see in this particular case, it is a normal cornea. We are marking the cornea. I'm not using ink, but still there is a mark that is there. And this is a new keratome that had come to me, and you can see that it goes pretty well. But just watch here, there is something which is wrong in this particular thing. So you have to be very careful when you are taking out the keratome, because if you do it with a jerk, you could actually have a problem of missing the lenticule, the flap. So in this case, this is a full free flap that has happened, and you can see that this is something that can happen without any reason. The cornea was of normal keratometry. There was no specific reason as to why one should have had this. And what you have to do is that you have to see that the flap does not get displaced or thrown away. That has happened pretty often. And what you have to do is to just put the flap back from where it is and try to match the areas where we had put the mark. Ideally, you can see this, the mark is coming into play here, and we are trying to have this, but as we dry up the flap, there is something odd that is happening. And what is happening is that you can see a granularity onto the surface. And what this means is that you have actually put the flap upside down, the free cap actually that has happened. And therefore we have to reverse this. And now once we have reversed this particular thing, we will try to map the areas where there is the depression that we had. So you can see that the depression, and then you wash it. The only thing in these particular cases is that if it is a clear flap that has happened. There is no ragged edges, there is no thinness problem at different places, and it is not the thickness of the flap is pretty good. So you can actually go ahead and put the flap for paucity of time. I'll just see this mark here, and we are matching the mark. We will wait for 2 minutes in this particular case. I'm just aligning it, and then at the end of the procedure, we can put in a contact lens. As you can see that we are putting in a contact lens, and the patient will do pretty well. But you have to be very sure that the flap sticks back, and make the patient move the eye couple of times and see that there is no movement. Make the patient sit out for about an hour, and then you can have the patient go, and you can see that post-operatively there is hardly anything that is there, because it's only the hinge that has gone, and you will get a good adhesion in this particular case. But if the flap is very ragged, if it is what I'll just show you in the next case, you can see in this particular case there is a flap which patient which came to me was referred to me by another surgeon, that the similar thing that I have shown you was attempted by this surgeon. But in this case, when I went ahead and you can see that I'm lifting the contact lens, the flap is obviously not adherent. And what is the reason? You can see that the flap is actually a biplanar flap. You can see that this depth is different from this depth. And when we place this back, you can see that this is at a different depth and this is at a different depth. So basically what has possibly happened is that the keratome was being moved and the keratome got stuck or stopped or for whatever reason, and the surgeon took back the keratome and then again tried to cut at that particular point again. So therefore, there are two depths at which the keratome has moved, and you got a biplanar flap. So in this particular case, we are trying to have removed the extra part of the stroma which was there. And we can just show you that we are trying in this case, because the flap was of different thickness. So we are trying to put sutures and keep the flap in position, because this flap is not going to remain in position. The patient came to me 72 hours after the first surgery, and there is obviously swelling. So at the end of it, we feel that the process is good and the flap should stick, and this is what it is. But when you see, there is a stromal melt that happens, and at 3 weeks the flap melted. So we just went ahead, and cornea being very, very forgiving, the flap was sacrificed. And the patient is actually, this is few years old, the patient is doing pretty well. The cornea being very forgiving, and the patient has gone to US and is doing reasonably well at a 6/9 vision. So all that I'm trying to say is that not all free flaps can be put back. At times you will just be doing good by putting a contact lens if the flap is regular. If the flap is irregular, you might try to put sutures. And despite sutures, you may not be able to have the flap retained. And if you do not have the flap retained, there is no harm in sacrificing the flap. Now, there are two things that can also happen as regards the complications. There is two things. One is a CTK and a DLK. So DLK is a diffuse lamellar keratitis and CTK is a central toxic keratopathy. Both of them can look similar, but the CTK comes normally 3 to 9 days, and it is central and involves the deep stroma. It is non-inflammatory and thought to be basically residue. Sometimes if people are using formalin chambers or things like that, which is, and it can be preceded by DLK, and both of them, because of the stromal melt, have a hyperopic shift. So whenever you have a DLK or a CTK, at times it may be very difficult. The simple thing is that whenever you have this severity, you have to lift up the flap. As you can see, it's very easy to lift up the flap, and this entire area, wherever there is the inflammatory products which are there and whatever is causing this toxic reaction, very often one does not know what is the reason why you get CTK or DLK. You will have to wash it very well, and you could use an antibiotic within that particular thing and wash pretty well, which is there. So this is something very, very important, that the undersurface as also the stromal bed needs to be washed, and this is the earlier it is done, the better it is. And you can see this is the undersurface, which is very, very important for you to remove the entire toxic debris, and then you can put back the flap. And once the flap is back, you can see, and you will have to give steroids over a long-term period. And the hyperopic shift takes a pretty long time for it to actually go back. But it does tend to go back. What is very, very important is that the earlier you intervene, the better it is. Now, let me come to 2-3 complications which can be seen with the femtosecond. So in this particular case, you can see that we are running with the, this is the intralase which we used to use a couple of years ago. And you can see that the intralase is going pretty well. But just watch here, you can see this breakthrough. So it's a vertical breakthrough that has happened. There is a corneal opacity which is there, and that is why the cut has not been coming very well. So in case the plane is not good, you can see, can you see this tongue-shaped issue there, where there was a breakthrough? And since it is in the periphery, I'm going very cautiously and lifting up the flap to the extent which one can. But there will be, as you can see, let me just go fast forward. You can see here, this is the tongue-shaped non-cut area, which is there where you saw the burp, but then this is outside the visual axis. So we can go ahead and do the laser vision correction. And we'll just we'll put back the whole thing. It will be stable. The only thing is post-operatively, you have to look for any epithelial ingrowth, because this may not be cut. This has not been cut very well, and you would prefer to see that the whole thing is good, and you can put a contact lens, as you can see in this particular case, and get a good post-operative result. Now, whenever there are any interface debris which are there, you can see in this particular case, the cilia of a patient has come. And sorry, I'll just, you can see that the cilia is there. And when you are making a flap or a femtosecond pass, the cilia is going to obstruct, and you are not going to get, it will be a cold area, it will be an uncut area. And as you will see here, there will be problems and difficulty in separating the flap at this particular time. So whenever there are these, any interface debris which are there, which are of significance, please see this. So there is an uncut area, and you are getting a problem in the flap. But with careful dissection, one is able to lift the flap. You can see that this is a small hole or a defect which is there in the flap, but this is where the lash was, and you can go ahead and complete the procedure. Sometimes you can see from the collaterals, you can see that when you are doing a femtolaser procedure, especially in hyperopic eyes which are there, or if you are making, that means that the eye is small, plus you are making a larger flap, then under those circumstances, you can have air entering into the anterior chamber. Just to show you, this happens infrequently, but it does happen. And it really does not, you can see this, it really does not. So you will have to put the tracker off, or you will have to wait for some time. It takes a couple of hours for the air to go, or maybe you can call the patient next day and then do the laser. But just by simply putting the tracker off, because tracking will be a problem with this air, and you can go ahead and complete the procedure. This is a case which has been neglected, which is a case of epithelial ingrowth. You can see that there is a track here. You should never wait for the epithelial ingrowth to increase this much, because this causes the stromal melt, and you will have to relift the flap, as you can see in this particular case. And once you have relifted the flap, you will have to remove the epithelium from all the surface below and on the undersurface. You can use alcohol also to kind of kill. Fluorescein stain can be used to see as to where exactly the epithelium is, and you have to be very, you can see that there is a stromal melt here. The epithelium has to be taken care, and you can see that if there is a railroading in from where the epithelium is growing, you can put one suture there. You must put, you can put glue at the edges, because the epithelium will tend to regrow, and put a bandage contact lens. This is, you can see that we have removed the epithelium and also put alcohol in this case, and then have something good, some good outcome. Now, this is a patient, I think this will be my last video. I think Dr. Chitra or Namrata may cover the smile. I do have videos in case they are, that's fine. This is a patient, 35-year-old female, LASIK done in June 2009 elsewhere. So this is 12 years old, developed flap folds. Flap reposition was done in August 2009. And then patient came to us in October complaining still of poor vision, photophobia and glare, etc. BCVA was this. So whenever you have flap folds or stria, the best thing is to dilate the pupil and look on retroillumination. because that is the only time when you will be able to make out as to how debilitating these tria are. And you can see in this particular case, so we are doing it in the microscope, which is the OT microscope, and not here. And the important thing here is because this is reasonably very old. You can see that this patient came to us 4-5 months after the procedure, and look at the macro folds that are there. You have to remove the anchorage of the epithelium. Till you remove the anchorage of the epithelium, there is going to be a problem because you have to then swell up the cornea with distilled water or hypotonic saline, and you have to keep on using two sponges perpendicularly. You can see this, and try to flatten it out. You can also use heat to the extent of about 45-50 degrees to try to iron out these. But the important thing is that till such time that you have not removed the epithelium, you have not been very patient to swell the cornea, these folds will never disappear on the table. So don't worry, they will not. But if you have swollen up the cornea, you have done enough the ironing that you need to do, and the epithelium is gone. The next day results after the epithelium heals. This is after 4, 5, 6 days or 1 week, whatever. The patient regained good vision, and all the problems of the patient have gone. The other important thing is that whenever you are using a microkeratome or a femto, it is much easier to relift a flap. Whenever you are relifting a flap, please be careful of epithelial ingrowth. A fresh cut always gives you less ingrowth than a relift. But the problem in a fresh cut is that you can have a lamellar cut, and that could be a problem. You can see in femto, the adhesion is slightly more, but you can still go ahead and relift the flap. But I'm telling you, what is very, very important is that the incidence of epithelial ingrowth is significantly higher. You could also do a surface ablation on these particular cases if you want. I think I will just not show these because of paucity of time, but you can have suction loss, etc. in SMILE, which you can have. You can have fragmentation, you can have side cut extension, you can have with SMILE. You can very rarely have epithelial ingrowth, which you can see can be taken care of. We have also reported ectasia, which is something very, very important. You can have post-LASIK, but unilateral corneal ectasia with the small incision lenticule extraction with normal topography has also been reported. And this is reported out of eye foundation, which is the inflammatory response which you can get post-SMILE, which resolved on steroid therapy for a long time. So friends, all that I'll wish to say that infective keratitis, this is also from our center where we had a case of fungal keratitis after small incision lenticule extraction. And this patient, the infection, we did the wash in the interface, because you have to go ahead and go into the interface, and the patient did resolve. Post-operative glare could be there, which you have to go back and treat. So finally, what I will say is that when you are doing laser vision correction or laser refractive surgery, what is very, very important is that you have to really, really try to be as gentle on the eye and not cause complications, because normally these patients are normal-eyed, they are having just a refractive error. And whenever you are looking for a surgery, which is a surgery which has the refractive effect only, it is not a therapeutic surgery which is there. We have to look at perfection, and we have to chase perfection. Then only we can have excellence. That is something which is very, very important, so that the patient only goes back happy. The satisfaction rate of the patient needs to be very, very good, and we have to be careful of what complications can happen. But above all, you should be able to handle these complications if they happen. And normally, if you are able to handle them well, the outcomes are pretty good. Thank you very much for your kind attention.
Excellent.
Thank you, Michael. Thank you very much. I think always like excellent presentation and really useful, Michael. Anyone want to ask any question?
So a quick small comment, excellent set of presentations, sir. Wonderful cases over so many years, and so much of learning for every one of us, the youngsters as well as us as also. One comment that I would like to make on the CTK, sir, you very aptly said the CTK and the DLK, they need to be understood in as separate entities, but again with merging significance of symptoms. However, the symptoms, if it is a mild DLK, we might wait a little, and there is usually a regression, and especially if the visual axis in DLK is not the one that is affected. Therefore, the patient is not too aggrieved and is still seeing well while the DLK is receding. However, in the CTK, it's quite mandatory to do a wash quite early so that it resolves soon, because the patient's hyperopic symptoms are quite disconcerting and the patient would be very, very unhappy. And CTK takes much longer to resolve in its normal course than the DLK.
You are absolutely right. Whenever you are having a DLK, it's also called as hands of Sahara, and it depends on the grading. So if you are having grade 1, grade 2, you can actually pump up these steroids and the things will settle down. And normally they tend to settle down. And if they are fine discrete spots, you really don't mind leaving them and they will go. But as they are coalescing in the center, that's what I tried. In CTK, it's basically mostly central. And when in DLK, it goes to grade 3, grade 4, and it is coalescing to the center, that's the time when the stromal melt happens. So you do not want to have the stromal melt happen. If it is grade 1, grade 2, you are absolutely right that the steroids have to be pumped up and the thing will settle down over time, and the patient does not even actually complain much. There is some granularity in the vision that the patient does complain. The second important thing is that you have to differentiate it from an infective because you could have some sort of a diffuse picture that you can get rarely that you can get an infection. Actually, if you have something like a pseudomonas, that can also mimic and the steroids will worsen it. So that is there the eye will be angry. Typically, when you are looking at a DLK, the eye is not angry. That is something very, very important, and the vision is not this thing. So you have to differentiate infective, DLK and CTK, and depending upon the stage where it is, you will have to intervene accordingly. A very pertinent point that you have raised up.
Thank you, Maipal sir. I think now we will go to the next speaker, none other than our secretary, my sister Namrata Sharma, who is a secretary of the AIOS, the most powerful woman of India, my world, and doing the keratorefractive surgery. In 100 women, in 100, I'm telling in 100 women, she is the most powerful. And I now invite Namrata to speak on management of LASIK complications. Dr. Namrata.
So thank you so much, sir, for that kind introduction. And I have changed the topic, the talk slightly, because I thought there might be some overlap. And I would like to congratulate Dr. T.P. Lane, Dr. Ragini, Dr. Preetam Samant, and everybody on the BOA and MOS for making this program so good and so successful. And of course, my young colleague, Dr. Karishma Wadia, for making me a part of this session. I would be talking to you about complications of LASIK surgery. Much has been talked about it. So I will just try to skip the parts which have already been talked about. Suffice it to say that the flap-related problems due to microkeratome are very few, less than 1% now with the current type of microkeratomes. And the videos, like Dr. Maipal said, are going to be old because this is what we used before 2003. But it is important to know if you're using one, what happens, so that you don't have to make that mistake and learn from it, but you learn from others' mistakes. So buttonhole flaps could be superficial or deep, such as seen here. And this may occur because of steep corneas, flat corneas, deep orbit, lack of synchronization between the translational keratome and oscillatory blade movement, and damaged blade. So whenever you have a thin, irregular or buttonhole flap, it is important that you defer surgery with the microkeratome, recut after 3 months, and some people like to do it early because they don't want subepithelial fibrosis to happen. Perhaps you can do it early if the refractive error allows you to do it. Now, this is a case of buttonhole flap, and ideally all such buttonhole flaps should be laid back onto their sides, and these marks which are present in the periphery do help a lot because they help you to align at the submicroscopic level. Again, there's a buttonhole flap in the center, and this is a post-penetrating keratoplasty with a Z-shaped buttonhole flap because of a very steep cornea and a bleeding because of the presence of sutures. So they are best left aside, and then you plan a recut at a later date. Sometimes you can have epithelial ingrowth with the buttonhole flap, and in those cases you may, if the refractive error allows you, again just do a PRK, and so both the things are simultaneously taken care of. Then incomplete flap may occur because of microkeratome jamming, and there are various causes for it. So whenever you have an incomplete flap, it is important to know where the tear is. If it is in the periphery, then you can still go ahead with it. If it is in the mid-peripheral area or in the central area, reposit the flap back and recut at a larger diameter and at a greater depth for a microkeratome. So if it is 160, then 180 and 8.5, then 9.5. Of course, if it is 120, then 140. Now, just to give you one example, this is a torn hinge which is present at the periphery. So you can still go ahead with the laser. And in the post-operative period, one has to take care that from the area where the tear is present, there is no epithelial ingrowth, and such cases are more prone to DLK. So one has to keep a watch for that. And then you can have a dislodged flap, very beautifully shown by Dr. Mahipal sir also how to manage them. And these have to be addressed immediately. Then you can have eccentric cut like this. Again, you have to see where is your optic zone, whether your optic zone is less than the area where the cut is made. And if your optic zone allows, you can still go ahead with the laser. But if it does not, then you may have to plan a recut. Then you can have flat corneas and free caps, again, very nicely shown. If it is lost, then one allows central epithelialization. But if it is retrievable and it is greater than the optic zone, laser, reposit and go ahead. But if it is less than the optic zone, then again defer surgery. So this is just to show one case where free flap occurred and it is there in the microkeratome, and then you laser. An important thing is that because you've made these peripheral markings, you can realign the free cap, which was there after retrieving it from the microkeratome, into the place where it should be. And so it is very important to put these peripheral marks. Then these are our publications on outcomes of LASIK after flap complications. And then in RK cases, you can have the splitting of the RK wedges such as this. And again, one has to be careful so that you get the whole thing up without splitting them or losing the wedges, and then subsequently laser. Flap folds have already been dealt with, so I will not go into the details. They can be macro or micro folds. And only when they are visually debilitating do you manage them after reflotation of the flap, which can be done with hypotonic saline or with deionized water. And then, of course, you can have post-LASIK ectasia, which is a difficult problem to manage, but is managed with contact lenses, Intacs, CXL, and very severe cases, you may require a corneal transplant. Then you can have meibomian glands like this, fiber such as this, or epithelial defect. These are taken care of in the post-op period. What happens to the fiber that is there in the interface? This is just to show, and we published this over 1 year, it becomes a caricature of itself and actually just disappears away. Then you can have DLK, which can be there because of the meibomian secretions, blepharitis, epithelial defect, or debris or bacteria from the lids. And again, if you give topical steroids and topical antibiotics frequently, it does resolve. And sometimes it can be akin to a toxic keratopathy, which was also talked about. So you have to refloat. At times you can have an infection like this. Then you have to amputate this flap because the antibiotics won't go in. And of course, you need to scrape. And this is what happens after you have scraped and healing is occurred with a visual acuity of 660. And another case where the infection was so much that a corneal transplantation had to be done. Epithelial ingrowth again has been covered, so I will not skip the video just to show that if you do address it, it becomes absolutely clear after post-op 1 year, there is no recurrence at all. As far as the femtosecond laser is concerned, you can have an opaque bubble layer like this, and you can also have air bubbles there. And when you have air bubbles in the anterior chamber, then you have to put the tracker off and go ahead with the laser ablation after putting the flap back. Then subsequently, there can also be vertical gas breakthrough, such as this. As soon as it occurs in the initial part, it is best not to continue with this and plan the surgery at a later date. Then there can be a suction break like this. So here the femtosecond is initiated, suction break is there. So actually, ideally, you should not have, one should not have continued this. But if one does continue, then you have to replan the surgery at a later date. And if you look at the surface, it may appear to be a little corrugated because a previous cut has already occurred there. And although in this case, it did not make much of a difference, but this can affect your postoperative outcomes. And this is followed by placing of the bandage contact lens. This is just to show in the same case how you can have a peripheral spindle from the previous cut and the new cut. And this one video about complications of smile. In this, there can be various problems such as shown here. So the anterior part is being tackled with, the posterior part is being tackled with, and this is a false passage, in fact, which is being made. And when you have such a thing, then you have to abandon the procedure and plan the surgery at a later date. Then this is yet another case, and these are dark spots which are present in between, which again, there may be adhesions, micro adhesions or macro adhesions present if you have not dissected it properly. And with the help of the forceps, then this is being dissected. Then apart from this, again, this docking is not extremely good. And there may be either the lenticule can get stuck to the bed or it can get stuck to the roof. And then you have to decipher which plane you have entered. And sometimes you may have to take instrument of the help of the special instruments. This lenticule has got stuck to the back of the to your cap actually, and then you have to, with the help of the lamellar dissector, keep pulling it, and then subsequently the lenticule, it is ensured that the lenticule is completely out. We did do, with the help of the intraop OCT, rescue a lenticule which was very much there, and we couldn't make out where it is. So we took the patient on the IOCT to find out where it has got stuck, and we rescued, and we did publish this. And we again published this new technique of MIOCT guided smile. So to conclude, like, complications do occur with all kinds of refractive surgeries, including microkeratome, LASIK, and smile. But important thing is that you diagnose them timely, and you know how to manage them if and when you do happen to have them. Thank you very much for your kind attention.
Thank you, Namrata. I think Mahipal is not seen. So now I will request Anil Kulkarni sir is there.
Yes, sir is there.
Sir.
Yes, sir.
Any comment, sir?
And the problem is sometimes you get afraid of seeing the complications. But let's hope that, as said by Madam, that they are so rare that we really can proceed with the procedures. The point is, in a smaller setup like us, it's very difficult to manage because the expertise in managing the complications become less due to the paucity of complications. So this is a nice way of realizing that all these can be treated without any problem with the patient. Thank you, madam.
Namrata madam, one small question, Dr. Kudlu here.
Yeah, Kudlu.
Now, see, most of the center doesn't have this IOCT whenever you will have a very small retained lenticule. In such cases, can we stain the lenticule and still can we able to find out that lenticule where exactly it is adhering and can able to remove?
So I think people have described trypan blue staining, then Dr. Mahipal's search group has described staining with the triamicelon, you can pick it up with that also. So I think it is doable, and at the same time, if you don't have intraop OCT and if you do have an anterior segment OCT, you can take the patient from the table to see where it is at the AS OCT and then get the patient back and redo it.
Okay, ma'am. Thank you.
So actually a slit lamp examination, it doesn't matter that if you are not able to isolate even the slit, as you can see that you see on these eyes, that is very good. And triamcinolone also gives you something very, very this thing, and even at times just a hydration of the area will swell up the retained matter and you can see that. So there are enough and more ways to see that. And what Amrita has said is very, very right, that a plain simple lenticular segment OCT done in the OPD setting will also give you as to whether there is a retained lenticule, what is the thickness and what is the extent. So, and then you can go back to the OR and remove that lenticule once you have either stained it or picked it up on the OCT. Okay. Any other questions or anything, or we can move on to the next speaker? Thank you, Namrata, for an excellent presentation. Is Dr. Ramamurthy there?
So Dr. Ramamurthy sir,
So Dr. Ramamurthy excuse himself because of the lockdown. Tomorrow he has some commitments and he needs to do them. So he has excused himself, sir.
Okay. So next we have, I think, Dr. Chitra.
Yeah.
Yes.
So Dr. Chitra, as you all know, is doing excellent work as chairman ARC, and she's the director at Eye Foundation and a great refractive surgery, and she'll be talking about what's new in laser vision correction. Dr. Chitra Ramamurthy.
Very good morning to one and all of you here. My very special thanks to Dr. Lahane and Dr. Ragdi to ensure that I was part of this very interesting program. And I'm amazed about the extraordinary potential of this team work which Ragini has with the help of her team, that within a week's time, she seems to have put together a great program for this weekend. So going on to my talk, what's new in laser vision correction? We all know that as far as refractive surgery is concerned, we've been always trying to reach out to the horizon, resetting different, what's happening? Sorry. Not able to.
It's not moving.
Yeah, I'll just stop, play it again and see.
Good morning, Dr. Keki, sir.
Good morning. How are you?
So then when we look at how the trend followed, there were different populations. Can you all see?
No, we cannot.
No, we are not seeing your slides.
How's that?
Share the screen.
I'll share again.
Yeah.
Very sorry. Can you see my slides now?
Madam, you will have to stop your screen.
Yes, ma'am, we can see the folder. We'll once you open it, we'll be.
Are you able to see now?
No, you'll have to stop your share screen and again share it, madam.
We can see the folder.
I don't know.
No.
That's never happened.
Have it on the desktop and
Yeah,
then.
I have it.
Good morning, Ravindra sir. Good morning, Mahipal sir. Good morning, Partha sir. Once again, I have already said hi to Kudlu sir. Kulkarni sir, namaskar.
Namaste. So in 15 minutes, we will say good afternoon.
That's why I finished saying good morning before I start saying good afternoon.
Are you all able to see my slides?
No, you will have to open it, minimize, then stop share, and then open, minimize, and then do share again.
First open, put it on the desktop actually.
No, it's already there.
Good morning, Ravindra sir.
Yeah, yes.
Yeah. Good. Now just do full screen.
Can you see it now?
Yes.
Perfect.
Yes, ma'am, it's beautiful.
So these were the different ablation profiles which evolved over the time, we know, right from the plano scan days to the whole sequence of events which happened till where we stand today. I still clearly remember those days in 1997, wherein I would rely on an ultrasound biometry to get the thickness and look at the Tommy's topographer to look at the surface irregularity index or the surface asymmetry and the potential visual acuity, and look at the anterior surface float and go on with my treatment and feel happy. Then came in a way to do an aberrometry and measure the entire abrasions of the eye and then treat it on the corneal plane. However, although we could minimize the preoperative abrasions, we were not in a position to correct the abrasions which are being created during the treatment. And more importantly, it was not addressing the asphericity of the cornea. So then it sort of came to a point where you wonder that no matter how good you get, you always could get better, were the famous words of Tiger Woods. So then there was a new concept, a greater evolving understanding of refractive surgery, wherein it was realized that the spherical aberrations which are created during LASIK flare,
which increases with a higher refractive error, if this could be addressed by giving in some additional pulse shots in the periphery, you're able to preserve the asphericity of the cornea, but then again, you have not been able to correct the pre-existent abrasions. Then in 2003, evolved the topo-guided treatment, which was a repair tool to treat all those disasters which were created in the process of learning flap creation. So how you could see on this particular map, how a steep area of the cornea is being regularized on a topographic mode, and thus the visual acuity is restored. But at that point, we seemed to needed to understand how was wavefront guided differing from a topo-guided treatment. In a wavefront guided treatment, in the process to create a planar wavefront, we found that you're needing to remove a lot more tissues. Whereas in a topo-guided treatment, you are actually shaving off those peaks of irregularity, and the flatter areas are being steepened by ablating around them, thus creating a more optimal corneal curvature, which is in fact a bimodal way of correcting a myopic and a hyperopic treatment. It seemed to make sense because when most of the aberrations seem to be on the corneal surface, on a topolyzer, you are able to take measurements which are static, which are not changing as the wavefront guided abrasions would change with time. And so it became more reproducible, consistent, and you could collect a lot more peripheral data. So with this understanding, we also came to know that we are able to ensure that the asphericity of the cornea is retained. The treatment is centered on the corneal vertex, which seemed to be a better way to go than being centered on the pupil center. And the cyclotorsion compensation and the pupil centroid shift were all incorporated in the topo-guided treatment. So then, when you're doing so well with the irregular corneas, Alcon went to FDA to find out why could you not do the same treatment on a normal cornea. So before we plan on a treatment strategy, we needed to analyze the results, and this is what was done in myopia and myopic astigmatism. What was interesting to find was that at the end of 1 year, 90% of these patients had a 20/20 vision or better. More interestingly, 70% had 20/16 or better, and 30% had even 20/12 or better. And what was even more interesting was, because you're removing those minuscule abrasions on the cornea, you are able to greatly address, and there was a significant reduction in glare halos, and then thus topo-guided treatment showed a very promising potential. Then it needed to compare this FDA treatment with the proponents of that time, Kanellopoulos and Lobanov, who were doing a huge numbers of topo-guided treatment. And what was seen in this map was, till 20/20, they were nearly doing well. But when it came to 20/15, FDA seemed to be doing far better than what the other two proponents were doing. The reason was that in the FDA trial, they were being very selective, that they were choosing eyes which had minimal topographic abnormalities, where the manifest refraction or the clinical refraction and that measured by the topography were nearly same. In fact, the cylinders had to be less than 0.5 and the axis difference should be less than 10. So all these in reality is only met in 10 to 20% of the normal eyes. So Kanellopoulos thought that after all, the aberrations are largely created on the cornea. So if you do need to do a topo-guided treatment, you need to correct the entire cylinder, both in magnitude and axis, and ignore the clinical refraction, which is done. So, but then there were situations where the clinical refraction and that measured on the topography were very different. So would that justify that you treat more aberrations on the cornea, and would that be a safe way to go? So he went ahead, got the best of repeatable maps, looked at how the topography would look without the refraction being corrected, just the higher order aberrations alone being corrected, and then pull down the full cylinder, and then once the full cylinder and the axis are corrected, you need to compensate for the spherical equivalent which is created. So that is ensured that happens. That is, the difference in the cylinder is half, and that gets added to the sphere, and thus an ablation profile was planned. So then again, you needed to compare, and when you compared, it was seen that they were doing pretty well up to 20/20 with the FDA treated eyes in near normal eyes, but at 20/15, they were flummoxed. So then it seemed reasonable to understand that You can't just do the entire cylinder on the corneal topography. You might have a perfect anterior cornea, but the posterior cornea would have its own cylinder astigmatism, which is contributing to it. We did our own study and found that 70% of our patients had an uncorrected vision of 20/20, 20% gained one line of vision, and there was 6% of them who had more than 0.5 diopter of residual astigmatism. So then we thought, why not we try that halfway mark, that is, use half the difference between the clinical refraction and the topographic refraction, and use the topographic axis and ensure that you look at the higher order aberration and adjust the treatment of the cylinder, and also compensate for the myopic or the hyperopic shift which could get induced. So if you look at this example, the topographic cylinder shows 1.63. and that which was clinically measured was 0.75. So you subtract it and the difference is 0.88. So you take half of this 0.88, that is 0.44, and add it to the clinical refraction, which becomes 1.19. So that is the cylinder with the same axis as 165 being corrected. But we need to deduct that amount from the sphere. So half of 0.44 is deducted, and then the treatment was planned. So essentially what we understood, that there was a lot of analysis and mathematical approach which was mandated, and you could not predict what was the contribution of changing the topographic features. And there were contributions of the posterior cornea and lens, and that is what which explained the difference between the clinical refraction and the topographic axis. And this is where Lobanov came out with his concept that if you are doing a resurfacing or regularizing of the topography, you need to keep in view the refraction on the anterior surface of the cornea, the astigmatism, the posterior surface of the cornea, the lenticular astigmatism, and the amount of deformity which is created by the abrasions on the corneal surface, and then plan, analyze the treatment based on lens theory and optical physics, and then come to the final correction. Now here you can see there were two areas of ptosis or difference in heights on the topography, which was so different, which could explain why there was so much difference in the clinical and the measured refraction. And if we needed to incorporate this higher order aberrations and go ahead and do a vector analysis and find out what is that final component of astigmatism and the sphere adjustment which has to be corrected. So based on this, like in this particular case, he just converted all to 0 and just looked at how much is the aberrations being corrected on the corneal surface, and then went ahead and decided that this kind of correcting a hyperopic ablation in the mid-periphery, what would be the spherical impact of this, and incorporating this and doing a vector analysis on an analytical software, which would decide the final correction. So after all this mathematical jargon which I discussed, what was found in this 34 eyes, that in 60% of the cases, the forceps did better. 30% of the cases did as well as the wavefront optimized or the Contoura vision, whereas in 10%, the wavefront optimized did better. It also mandated that you compare it with the FDA results. And what was most amazing was, if you can see that the forceps did as well as the FDA. Remember, FDA was being done only for near normal eyes. So we went ahead in our center and analyzed 60 eyes of 30 patients with a significant amount of sphere and cylinder, and then saw them over a period of 3 months. The analytical software in the machine did the vector analysis, and we found that at every aspect measured, the uncorrected vision, the best corrected vision, the total induced astigmatism, and all the aberrations, forceps results compared with the Contoura. So keeping in mind that this is the way to go, I wouldn't say that we're still at the end of the road. What is most important, that we continue to analyze our results, continue to ensure that we do not compromise on the uncorrected vision, do not end up with losing lines. But tell me, friends, we've had LASIK doing so well, we've had PRK doing extremely well, the topo-guided treatment and SMILE. So the ship is already in the harbor, it's quite safe. But then we also need to understand that's not what the ships were actually built for. So we need to be on this excursion of constantly improving ourselves. Thank you.
I think thank you very much, Chitra. It was I think it was a too good presentation, and what you said about the shift is true. Thank you very much. As you know, the Chitra is a ARC chairman and very powerful woman in India in AIOS, and my sister. Thank you, Chitra. Thank you very much. So now.
I think
we are.
Hanji, Dr. Lahane, go ahead. Continue.
Yeah. You can. Yeah. No, you can now invite another speaker, sir.
Okay. Thank you very much, Dr. Chitra. We'll go on to the next speaker. I think it is Kudlu.
Yes. Yes, sir.
Yeah. So Dr. Kudlu, as we all know, is such a nice individual and has done excellent work in refractive, one of the pioneers in smile surgery also. And he's doing great work in Karnataka, and also doing a lot of camps and charity work also. So over to Dr. Kudlu, who will be talking about presbyopia, still unconquered territory. This is his forte, and he's doing a lot of cases with presbyon. So over to Dr. Kudlu, please.
Thank you so much,
thank
sir.
You. Thank you, Maipal. Thank you, Keki. Kudlu is my best friend, and I think he is really doing a very good charity work. And I think I must salute him for his charity work. Kudlu, go ahead.
Thank you, Maipal sir. Thank you, Lahane sir. Thank you, Ragini madam, and also Preetham for this wonderful meeting. Also, I always feel very happy to be always part of BOA. So my talk today, I'll be talking about presbyopia. I've been doing since last 8 years. This is my financial disclosure. I'm consultant to Carl Zeiss India. So presbyopia is a physiological progressive loss of accommodation affecting individual in their middle age, regardless of any underlying refractive error, causing difficulty in sharply focusing for the near vision. So these are different principles to correct presbyopia. You can either go for monovision by correcting one eye for distance and other eye for near, or you can even opt for multifocality either with the lens options or even in the laser platform, or you can even think about increased depth of focus, what we do it in inlays. So these are the few options. Those who are really wondering what is this pharmacological option, one of my friends from Colombia, he has done in around 1,000 plus patients using something called FOETS with some parasympathetic mimetic drugs that will help in for near vision. Of course, spectacle being the most popular, I think everybody uses. Even some of my friends even uses contact lens for presbyopia treatment. My mainstay for today talk is surgical treatment. So these are the options. If you coming to the lens procedure, multifocal intraocular lens, a lot of us been doing now trifocal IOLs also in the market with even EDOF lenses. Coming to the corneal procedure, 3 of the procedures are very popular: Presby-LASIK, Presby-Max, Presby-Bond, and even few of my friends also doing this supracore. Oh, and other procedures like scleroscleral modification, like by implanting sclerospacing device, or even you can opt for laser procedure. So coming to the multifocal IOLs, I think most of us know the most popular one is a diffractive multifocal IOL. Now patients with the astigmatism, you have got options of going with the toric multifocal intraocular lens. Now, I think last couple of years, most of us has been shifting towards trifocal intraocular lens because of the advantage of intermediate vision. Even some percentage of our friends still using extended range of vision IOL just because of the less glare and halos during the night time. Accommodating IOLs almost vanished from the market because of its price and in difficulty in implanting. And just 1 or 2 words about this phakic intraocular lens with multifocality. One of the Indian lens has come out with this. Some people are getting better results with this. Even patient already underwent pseudophakic, both the pseudophakic. You have got an option even thinking about putting a circtoplex pseudophakic lenses. So coming to the cornea inlays, I was very happy to hear from Dr. Amar that he was telling that he's the first person to implant this camera inlays. Normally what we do, we implant this camera inlays in the non-dominant eye, which increases the depth of focus similar to the pinhole. Like you have to do the, like how you do the LASIK flap, it has to be inserted under the stromal pocket. These are the other couple of inlays, Presbya and revision optics, which is not so popular, not also FDA approved. These are the problems with cornea inlays. Definitely there will be reduction in the distance vision in the non-dominant eye, some amount of glare and halos with some reduction in the contrast sensitivity. Those who are really don't know about this scleral ciliary complex modification, I just want to tell you, this is something complicated procedure where we have to put 4 PMMA segment which is implanted under the sclera by making 4 incision in the sclera. And what they say that after implantation of these segments, sclera is supposed to be lifted to create more space between the ciliary muscle and the crystalline lens, thus have a presbyopic effect. One of my friends from Taiwan, he is very popular in especially this laser S procedure. What he does by applying a visual light erbium YAG laser that ablate around 600 micron laser spots in the sclera, which presume to free the ciliary muscle to contract normally. Normally they'll have a near vision effect of around 1.5 diopters. So coming to the laser procedure, I think Presbymax or Presby-LASIK, basically both the treatments are quite similar. Basically it's a multifocal LASIK treatment. By aspheric treatment, it induces spherical aberration for depth of field. But there are problems with Presby-LASIK. Few of my friends been doing that before. Now they stopped because of initial compromise in the distance vision, at least till 3 months. A lot of patients complaining of adaptation problem because of the multifocality. Even some patients complaining of night vision problem. And basically it's a pupil size dependent procedure. Coming to the supracore, a couple of my friends in India, they are doing this procedure. It's once again, it's a pupil dependent LASIK procedure done on the Technolas Bosch&Lamb platform. Unlike the monovision, what they do here, one eye is treated for the distance and other eye treated for a near. No, here the procedure, it treats both the eyes for distance and also for near. So the procedure in supracore is, it makes use of central near peripheral distance concept, wherein during the natural accommodation, when the eye focuses on the near objects, the pupil constrict and the eye looks through the near add addition. But when the eye is looking at distance, the pupil dilates and allows the peripheral rays to pass through the aspheric optimized what we have created in the periphery to improve the distance vision. But predominantly, it's once again, it's a hyperopic treatment. Hyperopic patients do really well, and it need to be, you require a refinement. Also, a lot of patients coming for retreatment. Let me come to the Presbyon. This treatment I've been doing last 8 years. Basically, whatever the refractive procedure, refraction is very important. Then as a doctor, I myself check the dominant eye testing. Then I myself test for micromonovision testing. This is very important. If you do this couple of tests yourself, then you are through with the procedure. Then remaining all same like what you have to do in the LASIK evaluation. The whole planning will be done with the help of CRS master, which is given by the company, and the treatment can be performed either with their MEL 80 or MEL 90 platform. This is the basic mechanism. One is monovision principle, depth of field to reduce anisometropia, spherical aberration control, vertex centration of spherical aberration, multifocality from epithelial lenticule, retinal image processing, neural summation, blur adaptation, and neural suppression. So what exactly we do? We make the dominant eye emmetropic and make the non-dominant eye myopic by 1.5 diopters. Along with, we also create a controlled spherical aberration in both the corneas. By doing that, we normally have something called blend zone, where the vision from the distance and the vision from the near, it joins and there is binocularity retains. So why we pick this micromonovision? Because you have seen in children with amblyopia, brain tend to suppress certain blur from the one eye to the other eye. So basically you have to treat, even though the both eye vision is 6/6, you have to treat both eyes. It's a bilateral approach. And the one more thing, these are my results from last 2 years. I have done, I think, more than 500 patients, but these are the 300 patients actually come for 2 years follow-up. What you can see here, none of the eyes lost more than half Snellen's line of vision when compared to the pre-op corrected distance visual acuity. This is very important for me. And the advantage of this treatment, it is not depend upon the pupil size. Even you can stretch. In my case, I have done for hypermetropia up to 5 diopters, myopia up to 8.5 diopters, depending upon the PACI value, even astigmatism up to 3 diopters. All my patients had a very good intermediate and near vision. in 97% of the patient, as Dan Reinston, my friend Dan Reinston say that 97% of the patient tolerate this treatment. Just I'll end half a minute. I will take a couple of case series. I just want for beginners for laser procedure. This is a patient with a 38 years IT professional with a normal topography with myopia, right eye around 3.25 and left eye around 2.5. Patient wanted a spectacle free vision because he's a known swimmer. Then in this, what we did, we explain him about that he has already started developing a near vision. We just gave 1.25. Then we gone into the Presbyopia with reducing from 1.5 to 1.25. Patient is doing really well. Coming to the second case, 46 years old female bank employee, hypermetropic, near acceptance is 1.5. Once again, we gone ahead with the patient wants to spectacle free vision, and we gone in this patient. One thing I want to tell you, all hypermetropic patients, do not forget to do a cycloplegic refraction. When you do the cycloplegic refraction, definitely there is a high amount of refractive error. Then you can give a near vision for 1.5 diopters and you can go ahead with the treatment. The case 3, very important, I have done in a patient with a jeweler. So simple myopia, 0.5 diopter, left eye 0.75. In the option 1, I just gave it a near vision 1.5, but patient cannot see even near small objects. Then I increased to 1.75, patient started doing well. I went ahead with the option 2. The last case, the Navy officer, right eye -2, left eye -3 diopters. Patient wants to be free from the distance vision, not aware of presbyopia symptom. In such cases also, you have to do the repeat refraction, make the patient to read fine prints with the distance vision, make him to aware of presbyopia, do a monovision trial with the 1.5, and we gone ahead with the presbyopia. So in the end, what is the best option? Okay, if you think about multifocal intraocular lens, corneal inlays, Presbymax, or supracore, presbyon. Okay, as far as the distance vision, intermediate vision, near vision, night driving problem, contrast sensitivity, if you think about adaptation safety wise, probably I think presbyon is definitely the best option till today available in the market. Once again, I thank Lahane sir. I wish him best of luck for his coming elections. And once again, I thank the whole BOA team for this wonderful opportunity. Thank you, one and all.
Thank you very much, Dr. Kudlu. Great talk. I think we are running behind schedule, so we'll go on to the next speaker. In case anybody has any quick comment, they can do that. But let's go on to Dr. M.S. Ravindra. Again, a very nice and a thorough gentleman, great practitioner of SICS and also refractive surgery, and my senior from RP Center. Over to you, Dr. Ravindra. You will be talking about hyperopia laser vision correction.
Thanks, Dr. Mahipal. Hope you can see my slide.
Yes.
Okay. I am always indebted to Dr. Ragini, Professor Lahane, and Dr. Preetham, Dr. Swapnesh, and all the office bearers of MOS and BOA for giving me this opportunity to be with the stars, luminaries of our country in the field of LASIK. I have no financial interest, but I do use all the gadgets that I mentioned. Hyperopes. Most of the LASIK surgeons are worried about hyperopes and worried about regression. This person is not going to be happy for some reason. But then let me share my experience and thoughts about how to be happy yourself and how to make the patients really happy with hyperopic refraction. In my opinion, hyperopes, especially when they are 30s and 40s, are much more happier than a myope because they would have gained not only distance vision but also near vision. As Dr. Kudlu said, cycloplegic refraction is a must, not only for hyperopes, for everybody. Routinely check the binocular vision, especially if it is hyperopic patient. Look at the amblyopia status. Look at the fovea. Is it a steady foveal fixation? Even if the vision is 6.6, the plus or minus, this is very important to check whether the foveal fixation is all right. And mesopic pupil size is important in all of them, especially in hyperopes, because you're going to have a larger optical zones. Angle kappa is extremely important again, and rest of it is similar to myopia. And we use this platform which gives us the ready-made software to treat +6 spherical, plus in addition to it you can treat as much as +6 cylinders. This is the platform we have. And we have treated up to +9. I'll show you a couple of cases. And I love ASA, and we have all these facilities. But to make those who are using alcohol, to make it absolutely painless, I would suggest these tiny flaps in the edge of it. If you excise all of them at the end of the surgery, at the end of your LASIK, remove them so that the epithelium that's left behind is tight and nice, just like you do a trans-epithelial or epitome removal. Patient will not have pain. It's not the alcohol that's causing pain, but these little flaps which move under contact lens are the cause for pain. And now we remove all these, trim them up, and there's no pain, even if you do it under this thing. What's the most important thing is the cyclotorsion, which can be avoided by encouraging the patient to open both the eyes. Of course, cyclotortion facilities are available, but then if you put a drape there and this eye is closed, drape is going to touch his lashes and he keeps on blinking and he tries to close the one eye. So that can be avoided by putting a shield and do the fixation of the eye. The face has to be parallel. All that has to be done before you drape, because once you drape, you don't know what's the position. And after doing that, do not move your movements. If there is a decentration, move the head and bring him back. So that way you are sure that the face is absolutely parallel to the face and in axis. Do not move the joystick after you have initially looked at it. This is one of the very important things to find out that you're doing the proper centration. We do a thin flap technique. This is especially important because often the flap size is 9.5 in hyperopes because they are larger. And how much of downward pressure, see, that's a microkeratomy, you apply downwards. And the classical teaching is you apply too much, that if you apply too much pressure, more of cornea prolapses into the ring here, and you're going to cut thick flaps. So you can have a uniplanar flaps even with this. The secret is just touch it 360 degrees, it touches the limbus and activate the vacuum, and then you will have a very little amount of cornea prolapsing into it, and you'll have a nice uniplanar flap even with a microkeratome. And the next thing that is a must in hyperopia, this is the most important thing. There are a lot of anatomical points on the cornea, and the laser can only see your pupil, whatever the size of it, and it can start ablating around the center of the pupil. But is the center of pupil is the place where you have to ablate? I'll tell you that's the typical hyperopic eye. All hyperopes, remember that they have pseudoexotropia. What does it mean? They're not using the pupil center, they're using a point nasal to pupil center to see the world. This is very important. If you're ablating, leaving all the statistics, all the criteria, all the nomograms to the machine, it will be treating eccentrically to the visual axis. This is something which you'll have to do to have excellent results in hyperopia, because hyperopia is not correct in the center. You're correct in the periphery, and you will have an indirect effect on the center. This is very important in hyperopes. And all of them have. Look at this eye. That is where the machine starts treating, but that's a visual axis depending upon Purkinje 1. The closest to visual axis is Purkinje 1 image, and you are supposed to ablate it around that and not this. About 95% of all the patients have visual axis elsewhere than the pupil. Very few people have it, and you can see this eye. Whatever calculations you make, you'll have to actually assess it. Ask the patient to open both the eyes. Look at the green blinking light. You can see here, it's no more here. That's a pupil size you have at that point of time. You'll have to shift to the right side. That's a plus x-axis by about 200 microns as you assess here. So this is the most important thing. That is the ablation. That's a cornea. That's a visual axis. That's a pupil. Left to machine, it is going to treat there. Now you'll have to shift it up there to the left side to have a perfect results. As you can see, I shift that to this. This can be done in every machine has got a different way of doing it. And see, the pentacam gives a rough estimate. This is the distance between pupil center and vertex, not the, this is not angle kappa, but this is nearest to angle kappa, 0.35, and minus and this is important, minus and plus. What does this minus and plus do? Yeah, this is how you see the right eye and left eye. I mean, when you are looking at it, forget about the patient is lying down, forget about which eye is it. Any movement from the center to the right side is an X plus. Any movement to the left side is an X minus. Any movement towards you, you are sitting here. is a y minus, any movement up towards the patient's leg is y, whether it's right eye and left eye. So minus 0.35 means it's on the x-axis. You'll have to shift the fixation, the visual axis pointer to the left side by 350 microns, and you'll have to shift y-axis downwards here by 190 microns. This is in millimeters. So this is a must in Hyperopes. And after doing that, this is again the patient has to blink and look at the green light all along. And you do the center test. The center test confirms that the center of ablation comes from the center of pupil and rests on this. So confirm it by doing the center test on the machine. And that's what you have to, this machine says x-axis plus 1.75, that you'll have to shift the centration to the right side. It's on the plus side, to the right side. And 150 microns is what I've taken. And then you start ablating. Then you'll have a perfect, very good results. And you know that the optical zone that we're going to keep in Hyperopes is larger. It's not 5.5 and 6. Generally, I keep 7 millimeters. And then there's a blending zone. So total ablation becomes about 9 millimeters. So you'll have to have routinely a 9.5 millimeter flap. And if you're going to treat that, this is a flap that you kept that. If you're going to treat this, hyperopic ablation is in the periphery, that's going to hit the corneal flap. So if you do not protect the corneal flap, there'll be an ablation here, there'll be an ablation here. Post-operatively, he'll have a gutter-like thing because there is a double ablation here. What you should do is you have to protect the flap on this side so that the laser doesn't hit on this side. What I do is routinely looking at the parameters, the flap making itself, I decenter towards the nasal side. I routinely do it about 0.5 millimeter or even 1 millimeter. So the flap itself is decentered towards the nasal side. So to protect the hinge, and you will have maximum ablation on this side. So imagine if you're going to protect with this hinge, that means this area, that area is not ablated at all. So shift the flap itself. I create a large and eccentric flap depending upon the size of the cornea, and that will serve a lot of, the flap itself is moved that side. So let me go fast. And again, the machine can say something. The pentacam can say there is a decentration of 0.51 in the right eye and in the right eye here from the pupil center, but actually you'll have to reassess the amount of decentration you'll have to do actually on the table. That can be done. Every machine has got the facilities. And the next one is you are going to tell the patient to look at the green light continuously throughout the surgery. Tracker is there, but if the patient is moving his eye left and right and up and down, and the centration will not be proper. So we, in the last 200 eyes, we did 188, we did the decentration like this. It can be small, y-axis 20 and 160. This is not dependent upon the pentacam results. This is dependent upon the actual measurements that you do on the table. Only 12 eyes did not need a decentration. And imagine you have patient with that kind of power. All the parameters are applicable. You have a 7.75, 2.5. How do we manage it? If other parameters are good enough, and look at how much will be the corneal steepness at the end of procedure, what we do is we correct +6 and full astigmatism in first go. And treatment 2 is also fed into the machine. And residual hyperopia, that's 1.75. I'll treat it again in the same sitting. K readings and PACI for the second treatment has to be modified, because after the first treatment, both the K reading and the PACI would have changed, and you'll have to refocus the corneal surface for the second. And presumed post first treatment values are entered in the second treatment. Optic zone, ablation zone, and same amount of decentration is done for the second treatment also. As you can see here, these are the parameters. Optical zone, I've kept it at 650. Decentration is 300 microns on to my left side, 100 microns towards me, the surgeon. So that's the second treatment parameters and first treatment parameters. And we have done many cases using these parameters with excellent results. And it is possible to treat more than what the machine offers us in some special situations. How much of K? It is not one diopter treating corrects one diopter of K reading. We have calculated that one diopter of correction of the the refractive error in the hyperopic zone corrects about 0.6 diopters. So when you modify the K reading for second treatment, that's the data you'll have to use. So that's the result of double LASIK treatment in the same sitting. Every person is not fit for it, but you'll have to have a flat cornea, you'll have to have a normal size, thickness. The hyperopia doesn't treat the center, it treats the periphery. So you're all right about central corneal thickness. The Presbyopia, Dr. Kudlu has covered it. I'll not cover much of it. I'll use the FCAT program that's in our this thing. Basically, what we're going to do is we're going to change the asphericity from pre-existing 0.31 to -1. -1 asphericity will give an extended depth of field. We use ASIS sphere adjustment nomogram to custom Q value. We can also do, this is what is the Q target. So the patients are extremely happy. We have done monovision treatment also. The dominant eye is done for distance, and the non-dominant eye, we have corrected the Presbyopia. They are also, we'll have to talk to the patient. Counseling is very important. See here, the right eye pre-LASIK, the patient had a Q value of 0.15 on the minus side. It became -1 post-operatively with very good near vision. And the other eye is optimized treatment where the Q value was not adjusted. He has very good distance vision in that. So we did about, I analyzed about 76 consecutive eyes, no intraoperative or postoperative or long-term complications. And this is the most important thing I would like to do. If you have done a cycloplegic refraction, if you have done the calculations well, and if you have kept the optic zone larger, the regression is almost nil. We had no regression in last 27 cases, and 41 hyperopes with presbyopia were treated by this technique out of so many eyes. That's average Q value preoperatively and postoperatively. And we use 58 microchromosomes, 13 femto, and 4 of them were ASA, and 1 was trans-epithelial treatment with ASA. So decentration was done in a large amount of patients. In hyperopia, every patient had decentrations. One of them had a decentration of 1,250 microns. That's 1.25 microns was the decentration needed in one of the eyes. And optic zone was 7 millimeters. Some of them are 6 millimeters. And vision after 4 years, there is no regression. 4 years follow-up was the longest follow-up. It was one of the patient. And this patient had 6/6 and 6 vision even after 4 years. That is surface ablation. Surface ablation is talked not much these days with the various facilities. So this is the person 4 years post-op, absolutely clear cornea, and vision is great. And even on densitometry on this haze evaluation, there's hardly any haze in these patients. So hyperopic LVC is extremely good. These are the points I would like to stress upon again. Do a good cycloplegic refraction. It does not matter even if you give some myopic correction in the immediate post-op, but do not undercorrect these people. Otherwise, they'll come back again. Large decentered flaps are important, and it corrects a lot of them. Thin flap technique is, I use it because then we have to have a large flaps. Optical zones have to be larger to minimize the aberrations. Angle kappa management is one of the most important thing that we have. Thank you.
Thank you very much, Dr. Ravindra. Any quick final comments, because I think we have overshot the time significantly. For me, it was a great session of learning and covered a lot of aspects of laser vision correction. Dr. Lahane or Kudlu, Ravindra, Dr. Chitra, Partha, Preetham, anybody, Aditya, Dr. Kulkarni, anybody wants to make any final comments?
I think, sir, the last session in which we covered the presbyopic part of the laser vision correction was a very, very important part because it's an unexplored part by most of the thoracic surgeons. And, as the nomograms, as the scientific advancements take place, I think we should have more elaborate sessions on this with clear-cut directions for those who are not using and how to get onto that, and the detailed workup which it entails.
Also, one important thing is the latent hyperopia, which is there in the hyperopic patients. As they come closer to 40, some of this latent hyperopia gets unraveled, and we need to understand that, and that is not the cause for regression.
So I'll just wish to put in my thought process, as was pointed out by Krishna Prasad. I think if I have to put my money on something, I feel it will be a lens-based procedure that will ultimately come out winner rather than a cornea-based procedure for correction of presbyopia. That's my hunch, because the speed at which the intraocular lens technology has improved over the last 5-7 years with the coming in of the trifocal and the combination with the EDOF, etc. And if the dysphotopsias go back, because the chances of regression or anything, etc., is not there in lens-based surgery. So my personal preference would be possibly on a lens-based surgery rather than a cornea-based surgery for patients with presbyopia, specifically patients with hyperopia with presbyopia. That's my take on it.
So we give the options, in my practice, all the options give. So in the end, whatever patient selects, of course, we also do a lot of multifocal, trifocal, or even EDOF combination. But younger patient, the patient is, if he is around 40 to 45, that patients normally I pick up them for laser-based procedures.
Yeah, I agree. And the other thing is that we are still not looking at dysfunctional lens syndrome, which these devices like iTrace picks it up very well, that there could be dysfunctional lens syndrome where the patient's quality of vision actually goes down and not the quantity. So anyway, these are presbyopia still remains a unconquered kind of thing, I think, where a lot of work is being done. Once we conquer presbyopia, I think that will be a large chunk of people that will be satisfying. Thank you very much, Dr. Lahane sir. Thank you very much, Dr. Ragini.
Thank you, Dr. Maipal. Thank you, Namrata. Thank you, everybody. Thank you, Gaurav. Thank you, Kudlu. Thank you, Chitra. Thank you.
Ravindra sir.
Yes, yes, Partha, Ravindra sir. Thank you very much. Thank you. Thank you. Thank you. Thank you.
Thank you, everybody. Partha sir, thank you for being there the whole morning. Sorry for the trouble. Thank you, Chitra Didi. Thank you, Maipal sir. Thank you.
Thank you.
Bhaiya. Thank you, everybody. Thank you so much.
Thank you. And now over to Dr. Keki.
Thank you.
Yeah.
Thank you, Preetam.
Thank you. Thank you, madam. Over to Dr. Keki Mehta, sir, who's chairing the next session. And Dr. Viral Shah, the moderator, please take over.
Good afternoon, everyone. So we'll be starting our session, third session now in the Parsons Hall of BOA MOS Summer Focus. That is refractive surgeries and smiling all the way. A very aptly put title of the talk. We have got our chairpersons, Dr. Keki Mehta sir, Dr. Rupal Shah madam, conveners Dr. Shashi Kapoor and Dr. Jeevan Ladi sir, and myself as a moderator. All our faculties, Dr. Rupal Shah, Dr. Keki Mehta, Dr. Sheetal Brar, Dr. Sri Ganesh, Dr. Jeevan Ladi, Dr. Cyrus Mehta, and Dr. Saurabh Patwardhan. All of them have joined. So we can start. We are already learning half an hour late, I think. So we should start immediately. I got one request from Dr. Rupal Shah madam that she has got 2 talks, and whether she can take both the talks simultaneously. If Dr. Keki Mehta sir allows, we can give her the privilege, provided that she finishes off in 18 minutes provided. Yes,
yeah,
madam.
Absolutely. Please continue.
Thank you. So smiling all the way is the hard work of Dr. Swapnesh Sawant.
Yeah.
Sessions by Nikhil Gokhale and the Swapnesh and Dr. Preetham's leadership. Dr. Sumit, Dr. Swapnesh, I think they did not sleep till late last night. And I think Swapnesh is really smiling all the way with such a successful program today.
Definitely. Definitely, madam. Also,
good morning, Dr. Rupal ma'am, Dr. Shashi Kapoor sir.
Yeah. Keki sir, you are not visible.
I'm not visible.
Okay, yeah. Right. So, Rupal Shah madam, you are the first opening batsman for today, ladies first. On a happy Mother's Day to all the beautiful ladies of Ophthalmology Society, Bombay and Maharashtra Ophthalm Society.
So should I?
Yeah, please, madam.
Rupal, carry on.
Yeah, Dr. Keki, thank you very much. So I will just start with my first talk. You are able to see my screen, right?
Yeah, madam.
Okay. So a happy Mother's Day to all the great mothers and also to the fathers who helped them to become great mothers. A very good morning. I still feel it's morning because we're going to be talking about smile. But before that, I would like to really thank everybody, especially Dr. Ragini, my dear friend, Professor Lane, and all the great organizers of BOS and Bombay Ophthalmic Society for this wonderful organization. I've been attending the last session and it's really been very, very informative and superb. So I would now jump to my topic because if I name everybody, then my 18 minutes will be over. So I don't want to do that. A switch from LASIK to SMILE. For any refractive surgeon who is serious in refractive surgery, a switch from LASIK to SMILE is a progress in their refractive career, where they are adding one more great corneal refractive technique in their armamentarium. So it's not necessarily a switch. So you are not really giving up LASIK, but you are adding SMILE. And as you know, smile and the world smiles with you. The advantage is it's a dream procedure. It's a bladeless, painless, flapless procedure, promises to have better biomechanics and a better dry eye profile, which has been bothering us since the time we've been doing LASIK. So the advantages are quite stark, but I know that people are concerned. I know that there have been questions about so many aspects. 12:30. And I thought that I should just answer those before everybody else starts talking about SMILE. So the first concern that I have seen and people ask is whether it's technically difficult. If you ask me today, with the better energy profile, with optimal spot and scanning pattern, with faster lasers, better instrumentation, more overall experience, and though there is a learning curve, there are lots of people who are also ready to teach you this new procedure. And you would find that the SMILE procedure can go as smoothly as you can see here. So it's really not that difficult. It's just a question of applying yourself and learning the correct way. And you would have your patient as well as yourself smiling all the way. So it is not technically difficult at all. With the newer parameters, it's becoming even simpler than doing a LASIK procedure with a microkeratoon. And you can see it here. This is an unedited video and it can get over in such a short time. It's a very thin lenticule and therefore you can see that grasping is also difficult. Whether it's expensive. It is expensive to acquire the laser, but you have to remember it's a single laser solution. So you have to acquire only one laser with only one laser's maintenance and disposables. It's a very fast laser, so the turnover of patients can be quite fast, especially if you are this high volume LASIK surgeon. There are less follow-up visits required and therefore there is less chair time. And you can sell it as a premium procedure due to the clear advantages, and patients are willing to pay a little more because of all the advantages that it can offer. Is there a limitation in treating high myopia? There is no limitation because, as you know, from the cornea, you don't really want to treat very, very high myopes more than 10 diopters. In fact, abroad, the limit is going down to almost 8 diopters. And you would find that with SMILE, you can treat up to -10 diopters of sphere and up to -5 diopters of cylinder. That's almost as high as you should be going on to the cornea, because otherwise the cornea that is left behind has too many aberrations, it's too flat, it's too unstable, and you would not really have good outcome if you treat on the cornea with any of the procedures. Similar is the case for treating hyperopia. Difficulty in treating low myopia. So people have concerns that if the lenticule becomes too thin, how would you be able to remove? You'll be having tears of the lenticule. And let me tell you, even in the beginning, in the first 500 cases that I've done, I've also treated a -0.5 with 0.25 cylinder without any problems. And this is at a time when the energy parameters and all were not really that good. We didn't even have good instrumentation. But there are certain ways to treat these low myopias and make it an easy treatment. If you increase the lenticule size, you would find that the thickness of the lenticule increases. You can add that neutral addition instead of 15 microns up to 25 microns. You can have your optimized energy profile, a thicker cap to avoid OBL, and a little bit of experience. And all this will make your low myopic treatment also as easy as any other treatment. How about pure cylindrical error treatment? I know that some people feel that you can't treat pure cylinders. You can easily treat them. And in fact, the cylindrical error treatments work really well with SMILE technique. You can treat up to -5 diopters. You do require in the newer profiles a little bit of spherical error to be added to the cylinder. So about 0.5 diopter, and usually most patients do have that. Hyperopic treatment, as you heard Dr. Maipal saying, that hyperopic treatments yield much better to lens-based methods rather than on the cornea. But it is still a work in progress, and I'm sure we would soon have hyperopic smiles, and you could use them for lower hyperopia. So initial treatments with hyperopia, we've also been a part of the study where we did 100 eyes with hyperopic treatment. It does work well with lower amounts of hyperopia, not so well with higher, but with the newer profile, maybe it would work even for high hyperopic treatments. There's this grouse that customization is not possible. You have to understand that the induced aberrations due to a SMILE lenticule removal is much less than what you would get because of the excimer laser working on the cornea. And therefore, it is offering you an optimized profile with much less induced higher order aberrations. And you don't require real customization in virgin eyes. That is going to be very, very few of your patients. And that too, it does not really work that well if they are high myopes or really having a great amount of aberrations. So if you compare it with modern LASIK procedures, it in fact does better. There is no eye tracker, but don't forget that the tracking is in your hand. So you can have an active tracker. You are holding that eye. So the eye is not moving while the procedure is going on. You don't really require an eye tracker. Retreatments are not possible or are difficult. Let me tell you that retreatment options, you need to use very, very little. And that too, there are several options available today. I would like to demonstrate one, which is the circle software, where you convert the cap into a flap and use your excimer laser to do the treatment. You are holding that eye. But this is the first circle software which was done in the world. And we got a chance to do that. Retreatments are not possible or are difficult. And you can see here that retreatment options was the first case. It was very, very little. And that too, there are several options available today. I would like to demonstrate one, which is the circle software, where you convert the cap into a flap and use your excimer laser to do the treatment. You are holding that eye. But you can see here that which was done in the world. Circle software works beautifully in the first patient that we treated. And you can see here.
Hello.
Okay.
Hello. Yeah.
There is an echo which is.
Just a minute. Partho sir, please mute yourself.
Yeah.
Dr. Partho, yeah. Please go ahead.
Other than the circle software, you could also use advanced surface ablation. If you made a thick cap, then you could make a flap in the cap and use your excimer laser. So don't throw away your excimer laser yet. But some people have also tried SMILE on SMILE. I have also done it in 2 cases. It seems to be working well, but it requires more refinement. And that could be the next way in which you would be able to do a retreatment. Many people feel it's a new technology. It still needs to be evolved. And believe me, it's been 15 years since we did the first case. So in 2006, the first cases were done in Germany. I myself had started doing it in 2008, and it's been a good 13 years since we've been seeing this technology. And my next lecture is going to be about the long-term results of SMILE. And therefore, I would say that it is no longer a new technology. It has matured enough to give you consistently good results. This lacking of wow effect is totally coming from history. And it is no longer today that you would lack the wow effect. In fact, I'm quite surprised if the patient does not read the best corrected vision or more right from the very next day. And if they don't read it, I would actually look into it to see if there is a steroid response or if there is edema or whatever, which is causing it not to see more than what they were seeing before with their own correction in place. So the wow effect, and I'm sure that all the speakers after me who have wonderful experiences with SMILE are going to vouch for this wow effect. So in short, if you ask me, SMILE is the best of both worlds. It combines the safety of PRK, but without the pain. And it also gives you the quick and the wow recovery of LASIK, but without a flap. So what more can you actually want from a refractive procedure of your choice? I thank you all for your attention. And I would now move on to my next talk, which is about long-term effect, whether SMILE has been able to stand the test of time. So SMILE a test of time. Can I go ahead, Dr. Keki? I'm going ahead.
Yes, madam, please go ahead, please.
Why is it important to study any procedure for a long period of time? So to stress that point, I wanted a personality which is known to almost all of us. I thought of putting my picture there, but then I saw that I've not changed over 10 years much. So I chose Barack Obama instead. And you can see that people change over a period of time. You also see that time heals hurts. This, I know, is very dear to all of us from Bombay here. This was something that hurt all of us, but time has helped us heal. And time also helps revive. So time changes. And it's been a long time since we've been doing SMILE. I'm very happy to share that I'm still a consultant for Carl Zeiss. And I had this opportunity to study this procedure in its infancy. And it has been a great 12, 13 years in the journey of SMILE. What has changed in 10 years? 10 years back, SMILE was just a possibility. The paradigm was flex. We had slower lasers, 200 kilohertz. Now we have 500. And maybe we will now in near future have an even faster laser. The scanning pattern was different, and therefore what we talked about, that wow effect was missing. And we had higher energy and lower spot and track spacing. So I would like to show you a small video of the pseudo SMILE with 200 kilohertz laser with the old scanning pattern. This is how we had done our first few cases. But we started as flex, where we would have, you can see the scanning pattern here, starting from the center, going to the periphery. This is the posterior part of the lenticule. This is again unedited. So you can see how long it takes. By this time, the new lasers can finish the job. The second pass would start from the periphery and come to the center. Once it reaches the center, it would be followed by a full length. So the entire flap incision, because we were opening a flap, peeling out the lenticule and putting the flap back. That was what was known as the flex procedure. Very soon into 1 month of doing flex, I shifted to doing pseudo smile. And this is one such pseudo smile patient that I'm showing you here. This video is from 2008. And you can see that at that time also, we could actually do quite a good job. Just go a little faster. So we could, instead of opening the entire flap, I'm trying to preserve the connection of the flap and not opening it completely. Initially, it was thought that we would require this as a stepping stone for actually reaching the smile. So initially, we did quite a few of these pseudo smiles also, where we would not open the flap completely, even though there was a possibility of opening a flap, and separate it through a small incision. If today, if you see this, you feel, oh, by this time I would finish 2-3 smile procedures. But at that time, we were very wary about this. This was the first pseudo smile that I did, and you can see how nicely it could get done. So it was possible, but it led to a scanning pattern which was giving a topography picture in the first few days like this, the A, which is to your left. And this was what was causing the vision to get delayed. We studied this, we tried several things, and then we suggested a change in the scanning pattern, which led to the topography picture right on the first day as B, which is to your right. And this is how the revolution in the correction and the wow effect came into being. Why do you need a long-term follow-up? Because we do it primarily for young individuals, and past experience. For example, in RK patients, we have seen that there is hyperopic shift which can occur even later on. And smile has to stand up to procedures like PRK and LASIK, which are now more than 30 years old. So it was important to study what happens after, say, 10 years in these patients. So we had treated 172 patients between November 2008 and July 2009. All underwent smile or pseudo smile for myopia or myopic astigmatism with spherical equivalent of less than -10 diopters. 42 patients of those came for a follow-up visits with a minimum interval of 10 years. And the profile was, as you would expect in any refractive surgery profile, the mean age being 25 years and the mean error treated to be about -3.98, and this spherical equivalent of 4.29. The lenticule diameter was kept constant at 5.75 to maximum 6 millimeters. We left behind a stromal bed of more than 250 microns. We stuck to less than 10.25 diopters of myopia, and the target refraction was 0, and in some cases we had even targeted a small myopia. Then the flap or cap thickness was 100 to 120 microns. All patients were treated with 200 kilohertz laser, with 60% treated with the old scanning pattern and 40 with the new scanning pattern. And you can see the stability over 10 years. The graph shows quite a straight line, not more than 0.5 diopters of regression, even over 10 years. And mind you, we'd also treated some high myopes in this. The change of uncorrected visual acuity as compared to pre-op was also quite remarkable, as was the change with best corrected visual acuity with time. So it is definitely a safe procedure. The topographies were the ones which were really, really very encouraging. As you can see a pure 6 millimeter zone where it was attempted, as compared to an excimer laser, where because of the peripheral losses influence, you don't see this pure 6 millimeter zone if you attempt it. And what was happening was also that the aberration induced were very low. And this was not only for the low myopic treatment. As you can see here, this is an example of a very high myopic treatment. There again, the induced higher order aberration was much less. or comparable to the LASIK treatment. When we ran the subjective satisfaction, 100% of all patients followed up reported satisfaction with the procedure. And they also said that they would recommend the procedure to their friends or relatives. In fact, the girl whom we treated first for our second study, she got 8 patients to be treated. 4 patients reported dryness or grittiness in their eye. 2 were reported also difficulty in driving at night, but there were no other subjective symptoms reported. We definitely had limitations to our study because the follow-up rate is only 24.4%. We've also not taken into account lenticular changes, pregnancy, and other changes in the patients over these years. And you cannot forget that most of these patients had been treated free of charge or at a considerably reduced rates, and therefore their expectation from the procedure may also be different. But if you ask me today, SMILE has come a long way over these years with better surgical technique, faster laser, better energy parameters, improved scanning patterns, and an experience of so many people gathered together. Today, you would find that SMILE can definitely stand as the most premium procedure. However, even the results in initial circumstances, to my experience, are good or even better than the competing refractive procedures, even after several years. So SMILE is definitely here to stay. And I would really want everybody to at least learn and incorporate it into your armamentarium. Thank you all.
Thank you so much, madam, for finishing both your talks in time as promised. And I think we should take up questions after all the speakers have given their talk. So our next speaker is none other than chairman for today's session, Dr. K.K. Mehta, sir. Everybody knows he is the pioneer of FICO and refractive surgeries in India. Dr. K.K. sir.
Thank you, Dr. Rupal, ma'am. You are a great teacher and you have trained so many people.
Thank you so much. Again, this is such an opportunity.
K.K. sir, you can start sharing your screen.
First time I'm seeing him mute.
Yeah. K.K. sir, you can unmute yourself.
It's only by his own volition that he can.
All right. I'm unmuted. You
Yes,
can
sir.
Respected Keki sir is, Lahane sir always calls him daddy. So he's the guru of Dr. Lahane sir, and he's a father and a mentor to everybody in Bombay Ophthalmic Association and in Maharashtra.
Okay,
He's a legend, and we are so honored to be his children.
Can you see my screen?
Yes, sir. Yes, sir, we can see.
Okay, then I'll start off.
Yes, sir. Please go ahead.
Go ahead. Okay, I'm going to, my topic today is the FEMTO-LASIK versus SMILE. After the magnificent video shown by my predecessor, who really the originator of SMILE, I mean, I feel a little unhappy. Let's put it this way, a little shy to show what my stuff. But let me tell you what essentially and why I feel that SMILE is my preferred choice. To really understand, let us first see what is involved in the procedure. The involvement is very simple, as has been very clearly shown. All that you are going to do is to use this instrument to do a flapless procedure. Quickly show you, she has shown you her method of doing it. Let me show you mine. I use a slightly different instrument, and this also is unedited. So you get a brief idea essentially that SMILE, irrespective of who does it, seems to work out pretty well. The procedure is pretty fast, it's pretty painless, and if you can dock your screen, dock your eye well, you get no patches left over. And I normally do it through a 4, or now I've gone down to a 3mm incision. But the procedure is fairly simple. You dissect out the first layer to make sure that you get it on properly, and then you open up the second layer so that you can get the entry into the area below the lenticle which you are designing. And simply sweep your repositor around. This is a little device which has been developed, which works extremely well. The advantage of using this device is that it's got rounded edges, so you can't really break a flap even if you're doing a very thin flap. And then subsequently, you can just ooze the thing and remove it outside. You don't have to even hold it with a forceps to do anything, which is my preferred method. Going on, Though SMILE and wavefront guided LASIK can achieve identical visual results, virtually identical. I'm not going to bore you with facts and figures because that is not the basis of my paper today. My basis of my paper is very simple, just to tell you why I prefer it. I simply turn on say it's a better procedure. It is a smaller incision.
Sorry for interrupting, but we cannot see your video. The slides are frozen.
Sorry?
The slides are frozen. We cannot really see your video or your slides.
Oh, it is frozen.
Yes, sir. It is not moving ahead. Your slide showing not moving ahead.
Is it moving now?
No, sir. You have to stop sharing and share again.
All right. Okay. Okay. Stop share and share again. All right.
Yes, sir.
Now it is fine.
Start the slideshow, sir.
Okay.
Slideshow.
Right.
The slideshow is not started, sir.
Moving?
No, sir.
All right.
No,
Okay.
sir.
No or yes?
No, no, no.
Not even now?
It's stuck.
Oh, God. Let's try it once again. This is very embarrassing. Stop screen share and try again. Okay.
Go with the first option you should see in the start sharing. Start sharing. First option, topmost option.
Okay. Share.
Slideshow.
Is it now sharing?
It is sharing, but you have to start the slideshow.
Can you see the slides moving at the side?
Yeah. We can see there.
Okay. Then to be on the safe side,
Okay.
let me run it this way itself.
Yes, sir. Please go
Okay, because you can manage comfortably. I'll just reduce this a little here so that will increase this.
Okay, sir.
Because I don't want to unnecessarily waste
That
time.
is fine, sir. That is fine. Please go ahead.
One of the advantages essentially is that you get a smaller incision with SMILE. There's no flap, better biochemical stability. But excimer laser has its problems. And one of the reasons of the fact that SMILE is now taken up so much is the problems with the excimer laser. The complications of LASIK are well aware to all of us. You get buttonholes, you get incomplete flaps running down, and you tend to get epithelial ingrowths, which are really ugly. The worst problem is handling them is really a big problem. You tend to get a displaced flap. It just needs nothing essentially. Somebody's a little child's elbow or a hand, or even a paper bag which explodes close to the face, and you can get this clearly seen displaced flap. You can also get post-traumatic flap tears. A laser flap can tear very easily, which is something which is a problem which can occur. If you have done enough cases, you will see all the complications one by one. And of course, flap wrinkles, you have to open the flap and then iron the wrinkles out and put it back. But despite whatever ironing you can do in the end, is never as good as it was originally. And of course, the cornea post-lens striae problems are there. If you notice on the surface, staining with the fluorescein dye. So in many ways, SMILE has better patient acceptability. The concept of no cut, no flap is more acceptable. It is virtually painless. And the big advantage is the fact that they can go take part in physical activities and make up virtually no restrictions. At present, thanks to our lockdown, they don't have to keep coming repeatedly to you. They only have to come once, and that usually is enough. So the advantage is essentially also the big advantage is no long-term dryness and the refractive predictability of SMILE. Now we have to understand, SMILE, at least in my hand, takes roughly a month to recover, unlike LASIK, which recovers the very next day. So though the wow factor is a little slower, after a month, it's almost the same. 3 months later, it's probably better than LASIK. And now if you see the advantages, the correction, it works out much better. It's easier to handle. And the advantages are on low myopia, no difference. In high myopia, SMILE essentially in my hands gives me a better result. Thus, the active lifestyle thus is the key as to why people tend to go in for SMILE. And the way I sell my SMILE essentially is to talk to them, not that whether one is a better procedure, one is not, one is a flapless, one is without, because patients really are not bothered about your surgical technique. They want to know what is going to happen afterwards. And those people who are habit of rubbing eyes, knuckling eyes can go away. So this is what essentially I turn around and tell them. You go to a beach, you want to enjoy water skiing, you want to enjoy skating, you want to go underwater, you want to enjoy things, life as it is, then you want to go with smile. If you are happy to remain on shore and not bother, you can manage. Here the activity is essentially a no bar. You can do whatever you wish. And the big advantage is that in gyms, for example, are the places people tend to get injured easily. Here there's no restriction whatsoever. And the most important thing of all is makeup. A lot of them do this procedure usually a month, 2 months before getting hitched up, either for men as well as ladies. And a lot of them tend to use makeup. So the makeup makes a lot of difference. They can do it comfortably utilizing the smile procedure. Hence, in advances, you can now, enhancement can also follow smile. There's really no hassle. You can do a circle enhancement, no difficulty. Once in a while, you do need to do it. It's essentially, you can even do smile on smile. So it works out pretty well. And now hyperopic modules are coming soon. So in summary, it is a better procedure. There's no flap, no risk of ectasia, no pain, no haze, which is one of the reasons why the armed forces has gone in for smile in a big way. Those who are mountaineers are much happier with smile because as you go up higher places, the vision tends to blur under a LASIK. It doesn't blur under a smile. In all, smile is a far better procedure. It's only a matter of time when LASIK, as one would be relegated to the dustbin. Thank you so much. And a final little reminder, double mask to save lives. Thank you so much.
Thank you so much, sir. Keki sir. That was a wonderful presentation. We have got Shashi Kapoor sir, Dr. Ragini madam, Dr. Jeevan Ladi sir. Shashi Kapoor sir.
Sir.
Yes, sir.
Yes, sir. Good morning.
Yeah.
Good morning.
Shashi is looking positively handsome today.
Sir.
So our next speaker is Dr. Sheetal Brar from Bangalore, and she will be sharing her tips for the top pulse to achieve 6/6 vision right from day one. So Dr. Sheetal, please go ahead. We can see your screen. Yeah. Please unmute yourself, Dr. Sheetal. Yeah, please go ahead.
So it's fine?
Yeah, it's perfect. Perfect.
Okay. So very good afternoon to everyone. And at the outset, I'm grateful to the Bombay Ophthalmic Society, Lahane sir, Ragini ma'am, Dr. Swapnesh and Dr. Karishma for this kind invitation. And I will be today discussing with you some of my top pearls to achieve 6/6 vision or even better, and good patient satisfaction, how you can achieve better than 6/6 vision and good patient satisfaction with smile. My previous speakers, Dr. Rupal and Keki sir, also said that there is a this notion in refractive surgeons' minds that smile cannot give you very good visual results on immediate day one, and the results are inferior compared to LASIK. So I'm just here to give you some of my tips and tricks which can actually vastly help you to achieve 6/6 vision and a great quality of vision right from first day itself. So we all know that docking, using a proper technique, energy optimization, all these things are extremely important for a smile procedure. But apart from that, there are some other newer and more practical concepts which can be used to enhance the visual recovery on first day. So the first concept I'll be talking about is cap ironing. So this is nothing but basically towards the end of the procedure, once you remove the lenticule, you can do a little bit of ironing on the cap. So you just need to use your dissector and give centrifugal strokes on the corneal surface from center towards periphery. So this maneuver helps in reducing Bowman's membrane distortions, which can occur due to the result of the volumetric loss of the tissue from the cornea. And these distortions have been shown to impede in the visual recovery of smile. So doing this maneuver just takes about half a minute or to 1 minute, but this can definitely improve the visual recovery. So we saw in a group where cap ironing was done versus a group where cap ironing was not done at the end of the procedure, the first day UDVA was significantly better, as well as the corneal MTF was also significantly better on first day, and it continued to remain significantly better at 2 weeks as well as 3 months. So this is a simple thing that can be done. Regarding energy optimization, we all know that for a particular, for a SMILE procedure or any femtolaser based procedure, energy levels should be optimized to prevent OBL and to obtain a uniform bubble pattern. So you want to have a pattern where there is no opaque bubble layer or black spots. So most of the Visumax lasers, you can achieve this using a fluence level of 22 to 32. Lower the energy level used, the better the outcomes. However, how do we know that our energy level is actually optimized? So we have described a sign known as the gas bubble escape sign. This is an intraoperative sign which can actually tell you if your energy level is optimized or not. So what you have to do is that after the laser delivery, you have to watch the escape of femto bubbles from the incision. So as you enter in the interface using your dissector, you will see an escape of bubbles, followed by which there will be a change in the quality of the interface. So watch here again. So just enter into the interface, you'll see a bubbles escaping, and immediately after that, you will see a change in the interface quality. That the interface which was more whitish and more opaque now looks more translucent. So this pretty much ensures that your energy level is now optimum, and you will actually experience a much smoother dissection in these eyes. So we compared the eyes where we saw this sign versus the eyes where we did not see the sign. And we found that the eyes which showed this sign had a significantly lower objective scatter index using the HD analyzer, which indirectly means that their visual quality is also better. So this is the clinical significance of this sign. When the energy level is optimized, the bubbles can escape freely because there is no hindrance to their escape. Whereas when you have opaque bubble layer or black spots, these areas can entrap the gas bubbles and prevent their free escape. And hence in these eyes, you can experience some amount of difficulty, or it may not be as smooth as when you see this sign. So this may indicate that you may further need to improve your energy. Differential spot spacing parameters. Again, this is a new concept, but it is an off-label indication. So conventionally, what we do is that we use the same spot distance for both the cap as well as the lenticule cut. So the lenticule cut is the deeper cut and the cap cut is the superficial cut. So generally, most surgeons use the same spot distance, which is about 4.5. Now, as we understand that our cornea is not, the architecture of the cornea is not the same throughout. That is, the deeper fibers are thicker and wider compared to the superficial, which are thinner and more compact. So it makes sense to use differential spot spacing parameters, which means that you can play around with your spot spacing and increase the energy of the deeper cut. Now we must understand here that we cannot use the same, we cannot use the different energy index or energy cut index parameters for the deeper and the superficial plane at the same time. This is because if you do that, then the laser is going to calibrate again after the deeper cut, and that is going to increase the suction time significantly, and you can have a risk of suction loss. So increasing the energy is not advisable. However, you can play around with the spot spacing in such a way that your deeper cut energy overall is increased. So what we do is that we use a spot spacing distance of 4.2 microns for the deeper cut, and for the superficial cut it is 4.5. So what happens is that with this slight modification, the deeper cut receives more pulses per square area, and thus it helps to achieve an overall higher energy for this plane, and thus improves in the dissection, the smoother dissection of the deeper cut, which again helps in the visual recovery. So we performed a contralateral eye study using conventional parameters in one eye, conventional meaning the same energy cut index and spot spacing for both the cap and the lenticule cut, and differential parameters for the contralateral eye. So what we found was that the eyes which had the differential parameters used had significantly better uncorrected distance vision and a lower OSI on day 1 and 2 weeks. So this is one small modification which can be done. Also, when we talk about selection of cone for the treatment, we generally depend upon the horizontal wide to wide diameter as a criteria, because any diameter which is more than 12, that is the larger corneal diameters, we use the medium cone, and for cornea smaller than 12 millimeters we use a small cone. This is what generally is used. But in our observation, whenever we dock using a small cone, we see a much smoother and uniform pattern compared to docking a medium cone. So here you can see the laser pattern with both the types of cones, and you can see in the medium cone there is a much thicker OBL in the mid-peripheral region. So more OBL, you can expect more difficulty in dissection and hence delayed visual recovery. So what we have now recommended, this is based upon the clinical study which we performed. We used in one eye small cone and in another eye medium cone, and both these of the same patient. So this was a continental eye study, and then we looked at the visual outcomes and the quality of vision. And what we found was that the uncorrected vision as well as the OSI was significantly better in eyes where small cone was used for docking rather than the medium cone. So why this is so? That because in SMILE we are not really the wide to wide diameter is not very critical, because you are using a maximum optical zone of 7 mm. So most of the surgeons use anywhere between 6 to 6.5. In low myope, sometimes you may have to use a larger zone. But even with that, because the transition zone is only 0.1, so the size of the lenticule and the overall cap will not exceed more than 8 millimeters. So usually our cap diameter is 1 millimeter more than the optical zone. So the laser is firing only in the area of about 8 millimeters, which is feasible using a small cone. So we really don't have to use a medium cone for large corneas. We can use a small cone and achieve very good results. And this is what our current recommendation also is. Small cones also ensure a better fit compared to the medium cones, and you get less OBL. We have also published this study recently in JRS. We also need to adjust our nomograms based upon our post-operative results. In our practice, we add 10% to the spherical correction and up to 15% for cylindrical correction, depending upon the type of cylinder treated. So for high cylinders, it is important to compensate for cyclotorsion, anything more than 1 diopters. And if the cylinder is with the rule, then we add 15%. If it is oblique, we add 10%. And if it is against the rule, then generally no adjustment is required. We should also use large optical zone, more than ideally 6.5 or more than that, because it also helps to reduce the induced abrasions. So this is how the cyclotorsion compensation is done. You simply have to very gently rotate the cone and align the corneal marks with the 0-180 degree of the reticule. And this cyclotorsion compensation can be done using either a marking method, an ink method, or an inkless method. So for the ink method, you can use the Viscot surgical skin marker. This is an infrared transmitting dye, which does not block the radiation. And this is what we were using earlier. But sometimes because of use of the dye can actually smudge and your visibility can be impaired. So now we have shifted to 3-point epithelial marker. This marker is available with Epsilon, and this is the inkless method. So this is a very convenient method to mark the eye. So this marker gives us 3 linear marks at 3, 6, and 9 o'clock position. And these marks are long enough to be seen during the laser delivery through the cone. And patients actually remain quite comfortable. It just leads to a very mild epithelial scratching, and there is no significant discomfort in the post-op period. So this is a very useful instrument in our practice for marking for high cylinders. So thank you so much. These were some of my tips to improve day one results with SMILE. I hope you all like them.
Thank you. Thank you so much, Dr. Sheetal. That was a wonderful presentation. We have got our next speaker lined up, Dr. Sri Ganesh from Bengaluru, Netradhama Eye Hospital. Dr. Sri Ganesh, sir, can you please start sharing?
Good morning.
Yeah.
Yeah, can you hear me? Yeah.
Yeah, we can hear you, sir.
Okay, let me just share my presentation. What's happening? Desktop. I'm having some problem sharing the.
Don't worry about it, it comes. The more senior you are, the more trouble it gets. If there is any consolation, I had fun and games before you.
Yes. Dr. Rakshit, please stop sharing screen. Dr. Rakshit.
Somebody else is sharing the screen, so.
Now it's okay. Sir, once more.
Just a minute.
She has so much experience, he'll be able to talk even without his slides.
No, for complications,
Sir, can you?
I'm getting also.
Can you log off and relog again? In the meanwhile, we can take a next speaker.
Okay. Okay. Okay.
Log off and log in again.
Probably you had no complications.
Yeah. So this is the complications of virtual meetings.
What is Dr. Jivan Ladi, sir, past president of MOS from Pune. Dr. Ladi, sir, are you ready with your presentation?
Hi, everybody. Yes, I'm ready with my presentation.
Please start sharing your screen then.
I think it's coming on now. Can
Yes.
I share? Can I start?
Yeah. Dr. Jivan, you
Yeah,
can
I think I was able to figure it out. I think it's.
Okay. So we will take
Yes,
Dr.
something.
Jivan Ladi, sir, next after you. So Dr. Shiganesh, please go ahead.
It says preparing slides. My slides are already prepared.
Good morning, Dr. Sri Ganesh, sir, Dr. Ladi, sir. Good afternoon.
Hi, ma'am. How are you? Thank you.
Good afternoon.
Good afternoon, Bhaiya.
Good afternoon.
I'm having some problem again. I mean, it said opening, but now it says preparing slides.
It is also gasping for oxygen.
I think the next speaker can go in, and I'll do this after that because the slides are there, but it's not opening.
You can stop sharing, sir, please.
Yeah, I'll stop sharing.
Dr. KK, sir, we go ahead with the next speaker.
Please carry on.
Dr. Jivan Ladi, sir, please.
Yeah, please.
Yes, sir, we can see this.
Hi, Dr. Sheetal. Good morning.
Hi, ma'am.
How are you? Congratulations for all the posts and the awards that you win. The new post of the associate editor, you are a star.
Thank you so much. I really wish we could meet personally. This year we were hoping.
Soon. Ye time bhi chala jayega. We'll be meeting soon.
Yes, ma'am.
Can you see my screen?
Yes, sir, we can see it. You can.
Okay, at the outset, I would like to thank Bombay Ophthalmic Association, Maharashtra Ophthalmic Society, Dr. Lahane sir, Dr. Ragini, and all the coordinators. Thanks a lot.
Request to all the other participants to please mute themselves. Yeah. Dr. Sri Ganesh sir, yeah, thank you. Ladi sir, we cannot hear you, sir.
Can you see?
Yeah, we can see now. Sir, there is no sound in the video. You have to speak. You have to speak for that.
Hello.
Yes, sir. There is no sound in the video coming, so you have to speak.
Can you hear now?
No, sir.
Just a minute, please, if you don't mind.
We can hear you, Dr. Ladi. Why don't you talk over the video? It'll be easy.
I will do that. I will do that. So idea is basically to have a technique by which you can remove the lenticule consistently in all cases by same way, taking same time, so that recovery is faster and visual outcome is better. So this is the sharing applied force succession of lenticule with a wow factor in refractive lens succession. Sometimes going reverse is better, in some cases. This is what we are trying to show now. So in femtolaser cut makes 4 cuts, as you can see here. In a profile, you see that posterior cut, which is made by, this is the second cut, which goes vertically up towards the lenticule. Third is anterior lenticular cut, which goes beyond the posterior cut, say around 2 millimeter. And incision we prefer to take at 110 degree for a better maneuverability. Now this is a profile picture which is showing the side cut. We take 2 millimeter side cut. Now this is a posterior cut, which is nothing but a series of air bubbles created by the femtolaser. Now this is where the visibility of the patient goes down, so you have to instruct the patient that keep on looking at the green light even if it becomes hazy. So in spite of seeing all the technology, this is what we found is easiest for anyone to do. So what you have to do, you have to use a technique by which you initially create a posterior pocket and anterior pocket. This is the anterior initial pocket, what you can see now. Then you go back and create a posterior pocket. So now this is anterior initial pocket. While going posteriorly, we press before lenticule, as you can see that, and it creates a small pocket. Now, once you do that, you enter into the anterior dissection, go into the pocket, go to the periphery and separate it. Then, as far as the posterior pocket is concerned, we don't break the lenticule initially. Central part we clear, then we separate 180 degree away from the incision, so the lenticle comes to you. And main important part of this technique is that this part of the quadrant is kept attached till the end, so it gives a control, and then you take this out by a reverse pull. So it comes out from periphery to the center. Now, this is the way we do that anterior and posterior separation. So in this technique, basically the stoma around is not manipulated much. As you can see that we use something what is called as a lenticular pressurized dissection, that we are pressing onto the lenticule for a separation. As you know that we can go into the end, separating that part, creating a track. Then we separate the left half. As you can see, incision is only 2 millimeter. Now you can dissect the right side of the incision. Now after this, we go back, and as I said, going back, we depress down, and we don't go to the periphery. We first, what you do, the central area, we try to create a quotation space here. And once that is done, then we break through the incision at periphery, Now you can see that we are going to separate only 180 degree. So that brings the lenticule towards the incision. Then this part is separated, but this part is kept attached. So this gives a control, so you will never lose lenticule in smile surgery. Now this is coming out in a reverse way, that is from periphery to the center by smile technology. Once you do that, inspect your lenticule properly, and you will see that you will not find any ragged ends by this technique. Now what you need is basically less inflammation and early visual recovery, comparable to or even better than a LASIK, and this is what we do, which is called as a lenticular pressurized dissection. As we said, that's whenever we are dissecting, we are pressing onto the lenticule for the dissection, so the surrounding stoma is not damaged or inflamed or manipulated much. As you can see here, this is the anterior lenticule pressurized dissection. After that, you give a stomal massage, milk out the fluid inside the interface outside. Preferably work under high magnification so that you can differentiate the tissue planes better, you can identify the lenticule better. And if you see that almost 95% of the patient on day 1 are better than 6/9 partial. Next day, you see the cornea is pristine, clear, just like comparable to your LASIK surgery, consistently in all patients, irrespective of the thickness of the lenticule or a degree of myopia. Now, we show you a case of opaque air bubble. So what we do, basically, we try to separate the tissue first surrounding the bubble, and at the end, we come to the bubble, and then we take this out by same technique of now this is missing energy that you can see here. In this case, what we have to do, basically try and separate the tissue around it, and the area where the missing energy is there is separated at the end so that it does not cut through the tissue. And you remove the lenticule by safe technique, that is shearing applied force extraction using a reverse technique. So in conclusion, use safe technology, lenticule pressurized dissection, use high magnification, stromal massage. Relax now you don't have to worry, you have to relax now, because this is a very simplified technique, because it gives a wow factor, and the results are very good, and you can smile and remove it reversely the way it is shown here. Because this is safe, that is shearing applied force extraction of lenticule by reverse flow with a wow factor. Thanks a lot, and these are the references and the participants. Thanks a lot.
Thank you so much, Jeevan sir, for a wonderful demonstration of your technique. So we have got our next speaker, Dr. Sri Ganesh sir. Yes, sir. Sri sir.
Yeah, let me try sharing. Again.
Ragini madam want to put in a comment till the Ragini madam.
Yes, sir.
Yeah. Yeah. Dr. Sri Ganesh loads his presentation. Any comments you want to put in?
Oh, it's a wonderful program. I really thank Dr. Nikhil for making this program. My teachers, Padma Shri, Dr. K.K. Mehta sir, Dr. Shashi Kapoor sir, and all the stalwarts, Dr. Rupal, Dr. Sheetal, our brightest star, Dr. Sri Ganesh, my brother, everybody who is here today on a virtual platform in spite of the COVID to share their science, and it is science which has kept us alive so far, and let us pray that we all live together happily. Thank you.
Thank you, madam.
Thank you, ma'am.
Again, I'm having some.
Dr. Jeevan.
Yes, please.
Yeah, wonderful technique. Congratulations.
Thank you.
I just had a question. So essentially the last part of the lenticule,
yes,
you are pulling.
Correct.
Right?
Yes,
maybe for about 3 clock hours?
correct, absolutely.
From 9 to 12.
Yes, ma'am.
Yeah. So have you faced any difficulty in lower myopes?
No,
while
that's
doing this maneuver?
No, it is same. Only thing in very low myopia, say less than 1.5, we keep the thickness of the lenticule by say 10 micron more, so that removal is more easier. I think Dr. Sri Ganesh is online, I suppose.
So I request all the participants to please mute themselves.
Good afternoon, everybody. And I would like to thank Dr. Lahane and Dr. Ragini and everybody else from BOA for giving me this opportunity. And it's very nice to see all virtually. And SMILE, like any other procedure, has its share of complications. And today I'll be talking about the complications, though the complication rates are very low in SMILE, and these complications can be easily managed. So for people who are beginning or wanting to start SMILE, this is not to put you off, but to show you how to manage the complications. I am a consultant to Carl Zeiss Meditech. So we look at the intraop complications. The first thing is black spots, which can occur during the laser delivery. And these are areas where the laser did not fire properly. It's basically because of obstruction to the laser beam. It can be because of meibomian secretions in the tear film, dirt or fibers on the contact glass, or ink used for marking the cornea, or even because of dryness. Dry eye is a common cause for this, especially if you use excessive topical anesthesia drops. The problems with black spots are it's very difficult to dissect and separate the tissue. You can damage the stromal bed, and this can give rise to delayed visual recovery. So these are this is a video showing the black spots here. The black spots is more in the periphery and not in the center. If it's in the center on the visual axis, it's better to abandon. Here you can see that the dissection is difficult, and you have to use a lot of pressure to separate the tissue planes, and this can cause tearing. And you can see if you have meibomian secretions, then even before firing the laser, you can just lift the gantry and then wipe it off, or you can change the cone. So these are simple things that you can do. The other aspect is suction loss, and this can be caused because of sudden movement or squeezing of the eye, because of Bell's phenomenon, excess fluid around the cone, or improper cone selection, or sometimes you have loose conjunctiva, which can just prolapse into the interface between the cone and the cornea. When you have a suction loss, the Visumax has a wizard which automatically goes into a specific mode based on the stage of the procedure. So you can have suction loss during the lenticule cut, where if you can see here, the progress is less than 10%, and then you have a suction loss. In these cases, you can actually redock and then continue with SMILE. You can see this is the second case where you have more than 10% progression, and then there is a suction loss. In these cases, the machine gives you a warning to convert to femtosecond laser, and then you will have to actually convert into femtosecond laser, and you proceed with making a flap, and then you will have to shift the patient onto the excimer, lift the flap, and do the excimer ablation. So this is the flap which is created. And you can have suction loss during the side cut. And you can see that the lenticule cut is completed here. And then during the side cut creation, you have a suction loss. In this case also, you can redock and then continue with SMILE. So the machine automatically gives you the options. And the other situation is where you have a cap cut. When you're making a cap cut, then you have a suction loss, and then you can actually continue with the SMILE, but you will have to ensure that you have a proper centration. So the only situation where you have to convert it into a flap and then go in for a femtosecond laser is if the lenticule cut progression is more than 10%. You can avoid suction loss. The incidence of suction loss is less than 0.2%, and it can be very low once you're an experienced surgeon. So there is nothing to worry about it. You can avoid suction loss by proper head positioning, prevent the nose from touching the cone. If there's pressure on the cone, then you can have a higher incidence of suction loss. Preoperative instructions to the patients are very important. You'll have to tell them about the fixation light. You'll have to tell them clearly to concentrate on the fixation light, and then inform them that the green light will disappear and they should not search for it. They should just hold very still. And I tell them that it'll take about 30 seconds. So during that time, they should keep still. I give them a countdown of the time. It's very easy. You can tell them that we'll play statue, no moving your eye. And the other problem you can have is stuck lenticule. So here, inadvertently, you enter into the deeper plane. Here you can see that we entered into the deeper plane. Once you enter the deeper plane and dissect the deeper plane, then you think you have dissected the superficial plane. But when you try to go into the deeper plane, you will again enter only into the deeper plane. So you'll have to realize that, because you can see the edge of the lenticule, you see the silvery reflex there. You turn over the Reinstein dissector and then use the short end to just find the superficial plane. You go in sidewards, and just with a little upward pressure, you can find the superficial plane. Then you can dissect the superficial plane and then remove the lenticule easily. So this is a common problem, and you should be aware of this. The other aspect problem that you can get is a lenticule tear. Here it's a low myopia and a thin lenticule, and you saw that there was a lot of peripheral OBL. When you have a peripheral OBL, it's difficult to dissect. And if you try to force it and then remove the lenticule, sometimes you can have a peripheral lenticule tear. If the peripheral lenticule tear is very small, then it does not affect the visual acuity. But here you can see that that's the area of the lenticule tear. You can have the jagged edge there. So you can always go in and then find the lenticule. You can, here I'm using the slit lamp, and air bubble kind of defines the edge, and I'm able to see it by using the slit lamp on the Visimax. You can also use staining with Samsonite, and you can also use an OCT if you have an online OCT. That's the small fragment which is removed. You can match it to the lenticule and see that you have removed it completely. A lenticule tear, the causes are a thin lenticule, if you have OBL like in this case, or if you have black spots, and if you leave behind a large piece, then it can give rise to irregular astigmatism and loss of best corrected vision. Cap tear can occur in a very small incision, usually a 2 millimeter incision. So for beginners, it's better to use a 4 millimeter incision. If you have an improper dissection technique and excessive side-to-side movements, then you can have a tear. So here you can see that there's a tear there. Again, excessive side-to-side movements, there's a tear there. You can see that. Here what has happened is, again, while you're using your microforceps, sometimes the hinge can catch the edge of the incision. So this is what has happened in this case, and you have a tear there. So these tears near the lenticule are not really a big problem. They don't give rise to a loss of visual acuity, but you may have to put a bandage contact lens, and then it heals well. Retained lenticule is a problem that can happen. Sometimes the surgeon is not able to find the lenticule, or is not able to remove the complete lenticule, and then you can have this problem of a retained lenticule post-operatively. And if there is a retained lenticule, then you get a very irregular topography, and you can see that the epithelial map is distorted. Sometimes you can see the edge of the lenticule on a slit lamp or in retroillumination, and definitely on OCT it can be seen. So when you have a retained lenticule, the patient is very unhappy because the vision is not good. So if you can't find the lenticule when you're doing SMILE, then you should not go on trying to meddle in the cornea. If it's more than 10 minutes, ideally you postpone the procedure and reassess after 2 to 4 weeks when the edema has come down. You can do a dilated examination under slit lamp on retroillumination, and sometimes you can see the edge of the lenticule. You can do a topography and it will show you irregular topography with ASOCT or a regular topography. ASOCT can show the retained lenticule. These are the investigations you do. And suppose you have an irregular topography and ASOCT showing the retained lenticule, then the first choice is to do a exploration. Exploration can be through the same incision, or you can do an open exploration where you can convert the cap into a flap using the circle software. And we have a publication on that in JRS also. Suppose you have a regular OCT. That means you have dissected the lenticule, but you have not been able to dissect it completely. The lenticule is as it is. It is not folded over and it's not distorting the topography. Then you can do a femto-LASIK if it's with a thin flap and then correct, or if you can also do a smile at a different depth. Again, if Topolink PRK in a case of irregular topography can be done, but I don't prefer it. I prefer to remove the lenticule because with Topolink PRK, you may not get optimal results. Let me just show an example of a case. This was a 24-year-old male who had primary smile. The lenticule could not be found, and then the surgeon referred him to me. He had an uncorrected vision of 612 and best corrected vision. Again, he had some mixed astigmatism, again improving only to 612. We took him up for resurgery after 7 days, and the final visual acuity improved to 6/6 uncorrected with hardly any residual power. Let me just show you the this was the OCT, ASOCT. You can see the retained lenticule here, pre-op and post-op after removal. And this was the topography, pre-op topography. You can see the irregular astigmatism, very irregular astigmatism. And post-op, the astigmatism, the topo improved. I'll just show you the video. This is just 2 minutes and we'll finish. You can see I opened up the incision. This is a 4 millimeter incision. Then I go in and then dissect. I'm dissecting the deeper plane first, and you can see that this is part of the lenticule. Then the superficial plane is dissected. You release the lenticule completely from the stromal bed. Of course, you can use triamcinolone acetate for staining, or you can use an air bubble. You can also dilate the pupil and do this under coaxial illumination under an operating microscope, or if you have an intraop OCT, you can use the intraop OCT to define and delineate the lenticule. So once the lenticule is dissected, then you can see here I've removed this. This was, I think, my first case of retained lenticule, which I managed. I think this was in 2012 or so, almost nearly 9 years ago. So once you remove the lenticule, you'll have to spread it out. And here you can see that the whole lenticule was intact. So the surgeon had pushed down the lenticule and then he was not able to grasp it because it had gone deep down in the pocket. So entire lenticule was removed. So I've removed lenticules even after 1 year, retained lenticules. So you can go in later on also and then remove it, exploratory surgery, and then the patient does well. So those were a few of the complications of smile, and I hope it was informative. Thank you very much. And I would like to again thank Dr. Lahane and then wish him all the best for his elections. Thank you all.
Thank you, Sri Ganesh Bhai. Thank you so much. Your wishes mean a lot, and thank you for the support always. Thank you so much.
Thank you. Thank you.
I think Dr. Lahane sir is there with us. Lahane sir. I think we'll. So moving on to the next speaker.
I'm there.
Yes, he's there.
Yes.
Dr. Lahane, thank you very much for the opportunity, and I wish you all the best for your elections.
Sri Ganesh, you all are with me, so it is best luck only. And thank you very much, Sri. Thank you.
Thank you, sir.
Thank you very much. Thank you.
Thank you, sir. Thank you.
Thank you.
So I think Dr. Sriganesh can stop sharing his screen. Yeah. So our next speaker is Dr. Cyrus Mehta from Bombay. And yeah, Dr. Cyrus, please go ahead.
Can you all see it?
Yeah, request to all participants to mute themselves. Dr. Rupal Madam, Dr. KK Mehta sir.
Yeah. Will I start then?
Yeah, Rupal Madam, please mute yourself. Yes, sir.
So
We can.
thank you.
Please go.
Thank you BOA and thank you MOS. Thank you Lane sir and best of luck for elections. And also thank you very much Ragini for having me here. Thanks Rakshit for WhatsApping me and Swapnesh. So it's my great pleasure to be here. Can you all hear me?
Cyrus, you are my brother, and it's great to have you here. You are a star, and you have to next time share your journey towards fitness next.
Yeah, you'll get to see that also. All right.
Dr. Sriganesh sir and Dr. Cyrus both.
Yeah. No, I used to always watch him and say, one day I'll become like that. Anyway, so we all of us have done LASIK for 15, 20 years. And we have all had partial flap, torn flap, serrated flap, buttonhole, free cap, irregular, ingrowths, dry eyes, glare, and ectasia. If you have not had all of these, means you have done less than 500 LASIKs. Of course, we know that SMILE has no flap, and that's why 3/4 of the complications of refractive surgery disappear. But SMILE also has certain issues. And as you were seeing in the last talk, what happens if the patient moves? Can we continue? So let's see the first video dealing with the most common issue. Can we redock when the eye breaks suction? So the person is quite a nervous type of person. And so it does the lenticule cut. And person starts moving. I start shouting, don't move, but they move. Then the machine creates this kind of screen telling us that most of the cap cut is left. Now patient is moving, surgeon is moving, eye is moving, everyone is moving, assistant is moving. So what we do is, we will now redock the patient. But I can't find the pupil center. Now how to redock? Because he just refuses to look at the green light. He is in a panic state. So let's have a look at the infrared view. You can do an infrared view now. I'm telling him, look in the light, but either he can't see or he's just panicked too much. And now you can center the pupil. Redock the patient and start doing the procedure again. Of course, you've got lots of opaque bubble layer in the periphery. Luckily for us, not in the center, and luckily for the patient. So we are able to finish the procedure. Now the interesting thing is you have to do the dissection also. So this kind of case is a little bit difficult because you have to separate the lenticule in the area with the opaque bubble layer also. And this case occurred very early on in my learning curve. Today, the loss of suction is rather a rare occurrence because I spend a little more time explaining to the patient about the green light and why they should not move and things like that. And you establish a little bit of comfort zone with the patient with a little bit of chit chat before that. You ask them, what do you do and stuff like that. A little bit of comfort on the table now, then they panic less. So you can see the edge of the lenticule is lifting off when I go there. So I'm afraid it will tear. So I go from the dissected area to the undissected area. Still there's one large tissue bridge which just won't give way. So I use the Chansu dissector. Chansu is from the guy from Thailand who has done thousands and thousands of SMILE. He's the Thailand version of Dr. Sriganesh. And so you are able to dissect it. So I don't want to leave any lenticule bits behind because I'm not very sure that I'll be able to find them later on. So I'll try my best to get it out in one piece. I break that final tissue bridge. Luckily, it's in the periphery, so it shouldn't affect the patient much. I grab that lenticule and out it comes. So let's have a look at the next one now. So the next situation is basically what happens if the patient again undocks. Now, this was the other eye of the same patient, believe it or not. You will not believe it, but it's actually the same person. And instead of postponing the case, which I would have done for the other eye, and there it is. Person is now undocked the other eye also. Luckily, there's not much opaque bubble layer, but there are black spots. So this is a little bit of the cap cut completed, which I will now restart. Again, use the infrared to find the center, because don't rely on the person to look in the green light. If he's already the panicky type, he's not going to look there. Now finish the cap cut. And then just do the dissection like you would normally. Sorry that the video is not really centered, and that's because I had not really planned to show this in a meeting. This was the second eye of the same patient. But basically it's the same procedure. Where I go from the dissected area to undissected. There also there's one tissue bridge there in the corner, which I want to break. So once again, I go back with the Chansu dissector and I break that tissue bridge. So then just rather than using a separator, I have to use this dissector, and out comes the lenticule. Give it a good hold so that I don't want to leave pieces behind, and out comes the lenticule. Let's have a look. The final issue is either lenticule being stuck up or down, which again you saw in the last talk. So what happens is that in this case, you don't have to really go find the edge and separate it. You just hold the lenticule and just do a rhexis kind of movement. Just turn your hand like this and it just comes out. The lenticule is very stuck in an eye because it's stuck from the superficial and the deep part. If you dissect one part, actually you don't need to dissect the other part, it will just come off. In many cases, when I have a very good separation, now I don't dissect both the planes, I just dissect one and just hold the lenticule and just rhexis it out. So here the lenticule is actually stuck down, but for some reason or the other, I'm unable to get under. So rather than scratching around there and making a mess, it's stuck down. Just hold it and then just turn it around like a rhexis. So it comes off very nicely and cleanly. In this case, you entered the deep plane, and of course now the lenticule is stuck to the superficial plane. This does happen to me even now. Say, I would say 1 out of 50 cases, you will go in the deep plane like this. Once again, catch the lenticule and just do a rhexis and peel it off. So this is basically the things that can go wrong with smile. And finally, this was me about 1.5 years ago, about 95 kilos. I love to eat, and we all do. And if you eat all the wrong stuff and you don't do any exercise, you will eventually end up like this. And lockdown happened, and 4 months later, I look like this. So it is very possible, and anyone can do this. And I'm going to have a talk show coming on YouTube soon with a bodybuilding company to show how old people like me at 50 can regain some of their lost youth. And I think that would be of more interest to most people than learning how to do smile. So anyway, LASIK will be history. Soon, more smile systems are poised to enter the market. And hyperopia and presbyopic blended vision will come with smile. And you will have more and more smile courses as more and more machines hit the market. Thank you.
That was a very nice talk, Cyrus. Very nice.
Thank you, Dr. Cyrus, for a wonderful presentation. So we move now to our next speaker, also the last speaker for this session, Dr. Saurabh Patwardhan. Dr. Saurabh, sir.
Hi, hello everyone, and thank you BOA and all the office bearers for giving me this opportunity. and it was a wonderful session to learn a lot from. So I'm going to share a case of mine. I did maybe 3-4 years back, and this is a case where a young patient came to me, around 23-year-old, and he had trauma 12 years back when he underwent surgery for traumatic cataract and implantation of 3-piece IOL. So his vision at the presentation, the other eye was absolutely emmetropic, the left eye, while this eye, he had -7 diopter with -2 cylinder, and the best correct visual acuity was 6/18. And for last 10-11 years, he had not bothered about the vision, not using glasses as well. But he got selected in the company, and the requirement was that he should have at least 6/9 vision, even in the worst eye. So then he started looking for the options for treating this refractive error. Now, when you look at the patient, you can see that the pupil is superiorly decentered and iris is covering the visual axis, and iris appeared adherent to the superior incision. YAG capsulotomy was already done in this particular patient. So I thought about different treatment options, but most of the corneal refractive procedure, as well as if I think about piggyback IOL, which has 6 mm optic, it will require a good centered pupil, because otherwise there will be treatment at the edge and patient may not have satisfactory vision. Also for piggyback, there should be adequate space in the sulcus. I did the corneal investigations. They were good to go ahead with the corneal refractive surgery. Now, pupil, obviously the pupillometry revealed that there was significant decentration. So I cannot use the regular refractive procedure, the lasers. So I have to do first correction of the decentered pupil. So I decided to go ahead with small incisions and first do the pupilloplasty. You can see under pharmacological dilatation, the visual axis was revealed, but this was not so in the mesopic and the photopic condition. So I first marked the visual axis here. And then at the end of the procedure, I want this particular area to be uncovered even in the constricted pupil. So I first examined this IOL sulcus. How is it? Whether I can go ahead with piggyback IOL in such case. Now, what I found on examination was the IL-1 haptic was in the sulcus, while other was in the bag. And superiorly, in fact, there was possibly a posterior capsular rent and vitreous loss. And the superiorly, the membrane which was going into the incision was actually probably vitreous. Luckily, patient didn't have any retinal complication as such. So now I tried to pull this iris out, but realized that there is a vitreous membrane. So I decided to cut it using the micro scissors. And after cutting out this membrane, I decided that I will inject some pilocarpine and see whether it centered the pupil. But after putting the myocol or pilocarpine, I realized that still the pupil was not centered even after cutting this membrane and releasing this iris. So then I decided to sit at the head end, and even after dissection of this membrane further, it was not centering. So then I decided that I will cut this iris open. So I'm sitting at the head end and trying to cut the iris so that the pupil can be shifted towards the visual axis. Now today I might use endodiathermy based pupilloplasty to avoid any cutting of the iris to have reactive pupil, but at the time I decided to just cut the iris tissue. At the end, the pupil was centered, though it was much larger than what I wanted. So at this point, I just stopped. I decided that I will go ahead with the refractive procedure SMILE. And if patient has glares haloelectron, I can always do further pupilloplasty and constrict the pupil. So with SMILE, the advantage, as previously told by speakers, that there is no tracking which is required, but the patient himself fixes on the light. So the centration is done by the patient himself, and there is no pupil tracking is what is needed. I tried to use the large optical zone so that patient has less glares electron. And this was the dissection as has been done. This was one of my first few cases. So you can see the energy optimization was still not there. Today I will get much simpler dissection and much lesser OBLs. So the superficial and deeper planes were first checked for, and then they were dissected. So the smile surgery went uneventful. So I was expecting that the patient should have good outcome out of it. I had already explained to the patient, if required, I will do another pupilloplasty to reduce the size of the pupil. And this was done 3 weeks after the first pupilloplasty procedure. So these were the parameters. I had kept optical zone of 6.3, which the corneal parameters were allowing. And to my surprise and to patient's surprise also, patient got uncorrected 6/6 parts vision. And after 2 years postoperatively, when he visited again, he was not bothered about glares, halos because of the large pupil. So I decided to leave it as it is. And that's the case which I would like to share. Thank you so much.
Dr. Saurabh, was there a change in refraction after the pupilloplasty?
I was expecting that, but what I found that it was same even after doing the pupilloplasty. But earlier his best corrected vision even with refraction was not improving more than 6/18. But later it improved to 6/6 parts, maybe because of the centration of pupil later.
Yeah, but congratulations, this shows the versatility. So if
Yeah,
you
I think
can
if
manage
there was,
every step of it, you can actually have a very happy patient at the end. Well
yeah,
done.
I think this was one of my first 20 cases of smile when I acquired. I think when we have tool in hand, we can utilize it. Otherwise, I would not have thought of doing this.
Absolutely. Well done.
Thank you, ma'am.
Dr. Saurabh, beautiful.
Hi, thank you, ma'am.
Hi, thank you. Our very own star.
Thank you, ma'am.
So this was the last presentation of our session. And I request all the faculties to please unmute themselves and put on their videos and quick discussion of couple of minutes before we hand over to the next session. Yeah, Rupal madam.
Very nicely conducted. I think we all have to agree that smile is definitely adding to the refractive armamentarium, and I'm sure that many people are now already adapting it. So it's going to be one important addition to our refractive surgery sector.
I have one question for Dr. Sriganesh. Right in one video, you said that now there are black spots in the center and it's better that we abort. So if we abort the procedure at that point, what will we do next?
If you have black spots on the visual axis, then you have to abort, because if you go in for a dissection and if you have a irregular interface there, then there'll be loss of best corrected vision, which is very difficult to manage later on. So you can abandon the procedure and then you can either do a surface ablation or a LASIK later on.
But LASIK,
or you can even do a smile, but at a different depth. But don't dissect. Don't dissect when you have a black spot in the center, because you will go into something which you can't treat very well later on.
Dr. Bharti sir, Dr. Gaurav, Dr. Vardhaman, they are all, Dr. Ravindra sir are also in this session.
I think, madam, it's now past 2 p.m. So the next session.
They must be in lunch hall.
So now there is a beautiful concert going on in the Duke Elders Hall by our own ophthalmologist. It's a mini concert. The second song by Dr. Sunny Sen Gupta is on. So we can all enjoy it till the next session begins. And it's our own ophthalmologists who are singing well. Thank you everyone for this beautiful session. Thank you for taking out the time to be with all of us. I think we are one big happy family, and God bless us all, and please be safe. Thank you so much, everyone.
Thanks, Sakini.
Thank you.
Thank you. Thank you, respected Keki Mehta sir, Shashi Kapoor sir, Viral as always, Dr. Rupal Shah, Dr. Sriganesh Bhaiya, Dr. Sheetal, my dear sister, Dr. Cyrus, my brother, Dr. Saurabh, Lane sir, everybody, Jeevan Bhaiya, everybody. Thank you so much. Thank you so much.
Thank you, madam. Thank you for.
Thank you. Bye.
Thank you. Bye.
Bye.
Bye, Rupal.
See you in the other hall.
Bye.
Yes, bye. Thank you, Dr. Viral. Well done.
Thank you. Thank you so much, madam. Thank you to the BOA and MOS for the opportunity. Dr. Karishma, for the next session, you can call the next team. Yeah. Dr. Karishma, please. Yeah.
So Karishma is a young lady who has worked very hard for this conference, calling up everybody, coordinating the sessions, and he's working the whole week. So please, a big, big, big clap, round of applause for our dear own Dr. Karishma.
Thank you so much, ma'am. Thank you very much. Thank you, everyone.
Thank you. Hi, Vavi. Hi, Dr. Santosh Bhaiya. Hi, Hijab.
Yeah, good afternoon, everyone. Thank you,
Good
BOA,
afternoon.
ma'am, Lane sir, Karishma, everybody involved. Thank you very much.
For the next session on the panel, Dr. Santosh is here, Dr. Chandrasekhar is here. Is Dr. VC Mehta here? I guess he must be joining shortly. Our first speaker, Dr. Samresh is here, Hijab ma'am is here. Dr. Nitin Balkrishnan has had a family emergency, so he's not going to be joining us, but his daughter-in-law, Dr. Pavitra, will be doing the presentation on his behalf. Dr. Sudhank Bharti is here, and Dr. Parul ma'am will join, and Dr. Pranay sir. All right. So that's most of us are here.
Bharti sir, Dr. Samresh, hi. Condolences to Dr. Nitin Balakrishnan sir, who lost his mother-in-law today morning.
Oh.
Good afternoon, everybody. Good afternoon, Dr. Ragini.
Dr. Karishma will start the session at 2:15 sharp.
Santosh Bhaiya, he's the next president. So, you know, since he's one of my closest friends, he sacrificed to make me the scientific chairman, and he's now the incoming president, the second vice president of MOS.
We have 10 minutes to go.
Can I just try to share the screen and check if it's working?
Yeah, please, please. I think it's a good idea. Everyone should try. So, Dr. Samresh, you are trying to share the screen, right?
Yeah, I'm just trying to share my screen.
If you have any videos, please play those videos.
Yeah, it's just I made it into a full video only so that we can save on time. And is it running smoothly for everybody?
Yeah.
All right, great. I think that should do.
Can I try now?
Do you want to share your screen, please, and just check?
संतोष कोणाला मला सांगितलं?
तू शेअर करून बघतोस का स्क्रीन? होतोय का?
Yes. You can see this, right?
Yes, absolutely. Perfect. You can stop. Dr. Hijab, you want to share?
Yes, sir. 1 minute. Is it visible?
Oh, yes. We can see.
Yeah, so then I'll stop share. Thank you.
Yeah. Only. Okay. Dr. Bharti, sir, do you want to share and see whether it's running? Please unmute, sir. Please unmute yourself. Dr. Bharti, sir, please unmute yourself.
Everyone. And I will come when my time is there. I can share my screen anyway. There's no problem.
Hi, can I share? I'm Dr. Pranay.
Please go ahead.
Somehow I can't share. Yeah, okay. I really don't know how to put this as a background.
First, you open your presentation and then try to share. You stop sharing.
Yeah.
You stop sharing.
Yeah.
You open your presentation on the laptop and then start sharing again. Do that right now.
Sure.
Don't worry, it's going to work. Just open your presentation and then start sharing.
Yeah, sure. Okay. Yeah, I'll just start sharing now.
Yes. Yes, correct. We can see it.
Yeah.
Perfect.
Okay, I'll stop sharing. Thank you. I just wanted to know how exactly do you put this background that we've received?
First, you download that background.
I have downloaded it on my desktop.
Then see on your screen, there is one icon of stop video. Next to that, there is one arrow, upward arrow.
Yes.
So you click on that arrow.
Yes. It says choose virtual background.
Correct. Then choose virtual background. Then
how-
there will be a sign of plus. So you have to add that.
Yes.
You click on that plus.
Okay. All right. I'm trying.
Then you will see in the downloads that thing one which you have downloaded.
Okay. All right. Thank you. It
Can
just
you see
says
that?
that it just says that it doesn't meet the requirement. So I think I'll have to just forward. I have downloaded it. It just says prepare a green screen behind you and select.
Yeah, okay. It doesn't. Forget it then. Don't worry.
Yeah.
Or maybe plain background. If you have any plain wall, then maybe it is possible.
Yeah. I think that's all.
Okay.
Fine.
It's all right. No problem. Hello, Vardhaman. Jeevan is also there. Hello, Dr. Jeevan.
Hi, Dr. Santosh.
How are you?
Fine, going on.
We need your expert's opinion on all the queries and talks.
Yeah, sure. I have to leave for some time, but
no problem. When you join back.
Hi.
Good afternoon, Lane sir.
Good afternoon, sir.
Good afternoon. Good afternoon. Good afternoon. Sorry, I was on the other hall. So welcome everybody. Thank you very much.
Thank you, sir.
For joining. Thank you very much. Thank you, Bharti sir.
Good afternoon, Lane Saab. Good afternoon, sir.
Good afternoon. Good afternoon, Bharti sir. Good afternoon. Thank you very much.
It's a pleasure, sir. Once you ask, it is always a pleasure.
Yes, sir. Thank you. Please go ahead, sir.
Good afternoon, Vaishal. Dr. Kenya.
Yeah. Good afternoon.
How are you?
Very fine.
Shall we start? It's 2 minutes more. Good afternoon, Dr. Suvarna. Please unmute yourself.
Good afternoon, everyone.
Yeah, good afternoon.
Good afternoon, ma'am.
Good afternoon, sir.
Good afternoon, everyone.
Good afternoon.
Good afternoon,
Can we start, Dr. Karishma?
Yes, I think we can start.
Please start because.
Yes. Okay. So I think we'll start our session. Dr. Santosh sir, should I start introducing?
Yes, please. Yes, please. Go ahead.
All right. Okay. So good afternoon, everyone. I'm very happy to invite you all to the 4th session of the Refractive Symposium today, which is on achieving perfection. We would like to invite our panelists here, the chairman, Dr. Santosh Bhide, sir, who is the incoming president of the MOS. Good afternoon, sir. Our co-chairman, Dr. VC Mehta, sir, from Mehta Eye Institute, Ghatkopar. He should be joining us shortly. Our convener, Dr. Chandrasekhar Vavikar, sir, who heads the Vavikar Eye Institute at Thane. Our co-convener, Dr. Suvarna Joshi, ma'am, who is already here. And I'm the moderator of the session. I think without wasting any more time, we'll switch over to Dr. Santosh and then start with our next, our first talk.
Good afternoon, everybody. Sorry. Good afternoon, everybody. So let's start with this interesting session on achieving perfection. Our first speaker is Dr. Samresh Srivastav, and he is going to speak on imaging in ophthalmic clinics. Over to you, Samresh.
Thanks a lot, sir. First of all, I'd like to thank both the BOA and MOS for giving me this opportunity to give a lecture on this important podium. But I'm just going to start my my whole talk with a slightly different note this time. My entire talk now is not focused on refractive as it is focused on day-to-day issues that we face in today's time right now. Just one second. Yeah. So my topic is titled the air we breathe, because air is now such an important part of our system in today's date and time. And this is important because, all our surgeries, no matter what surgery which ophthalmologist is doing, FICO, eczema, is aerosol generating. And in today's scenario with so many numbers climbing up, it's always a fear in our heads as to whether or not we should do a surgery. Also in our outpatient clinic, which is a bigger problem, we don't know whether the patients walking in are carriers of the disease. And we are very concerned not only about ourselves, but also our staff and other patients who might get infected. Now, there's been a lot of studies, a lot of them from India discussing aerosol generation during surgeries and whether or not, it really happens. And one thing is amply clear that there is aerosol generation, which is minimal, which can be controlled by, by using better machines. But I believe that there is something more important to this, something that everybody should be able to take up at home. So we decided to do a study, and we published this in the IGO last year, where we looked at the aerosol generation in phacoemulsification in a real-time surgical scenario. This is our entire operating room. We had converted in the entire operating room into a UV compatible room to be able to see the areas and the distances to which the aerosol flows, if it does it. And if you notice, we've used BSS, which is laced with fluorescein. And the entire environment is UV lighted so that we can make out even if distant aerosol generation flows through. We did this study on cadaveric eyes, goat eyes, and also these model eyes. But eventually we realized that the goat eyes were best for demonstration purpose. And we realized a couple of important things in this during the course of our study. The first thing we realized is that a lot of aerosol that we generate in modern micro incision cataract surgery, FICO, is technique dependent. Notice that I'm trying to, move the FICO probe in and out of the eye, trying to elucidate and trying to make out any aerosol that's coming out, and not really much aerosol is being generated in this area. And that's because there's enough fluid moving. But notice over here that if I use an improper technique, probably like a novice surgeon, or maybe, a bad technique, and I'm trying to push my FICO probe, my tip against the sleeve, that is when the aerosol generation happens. That's because of friction between the sleeve and the tip. And this aerosol tends to move upwards. One more thing, which again studies have published, is that the use of methyl cellulose, HPMC, that I'll show you again, in an aerosol generation, if you dampen these aerosols using an HPMC or any other OVD, your aerosol generation reduces drastically. Something that we need to all be concerned about. Technique is now more important than ever before. And the use of OVDs, particularly on the cornea rather than inside the eye, is now even more important. So basic takeaway points: avoid incision distortion. Please pay attention to technique now more than ever before. Avoid compression and use an OVD. HPMC, cheapest OVD available, can be repeatedly topped up on the incision sites to avoid any aerosol generation. Refractive surgery again is a potential concern, and the problem is twofold. One is whether the microkeratome can generate aerosol, and I think Dr. Rohit Shetty's team has very elegantly demonstrated and published the microkeratomes do cause a lot of aerosol generation. So what's the choice we have? I think at this time for us as refractive surgeons, I would feel a femtosecond LASIK or a surface ablation may be a better option, simply because there is more controlled environment and less of chatter around the blades. Another issue with excimer, plumes causing any infective source. I don't really think so, because it's all plasma and it's all burnt out. But I think a good service of your machine to make sure your plume evacuator is working properly and there's no clogging and your filters are cleaned and done, it can go a long way to safeguard yourself. So I think with these small tips that helped us understand, I think surgery can be continued even in the worst of scenarios if you pay attention and let the airflow move through. But what's more important than surgery is how the air around us moves in an outpatient surgical clinic or inside an operating room, be it a LASIK room or a cataract theater. To understand this, we picked up a principle of Schlerin imaging. We had to go back in science and revisit it, and Schlerin is a way of imaging air. So we use the Schlerin imaging technique, which has been established in literature and is being used by optics scientists all over the world to study various factors. But this time we decided to study using a telescopic mirror, an SLR camera, and a point light source, which was bifurcated. There is a simple optical system to it and one can easily read it up. Setting it up is not the most difficult thing. But what we decided to do was to set up this whole optical bench experiment in a real-time clinical scenario for the first time. So we made an optical bench and we shifted it into the operating room and to the OPD to actually look at what is the airflow that is happening in our real-time scenario and to see whether something is good or bad and what can be done. So this is in the OT with the patient draped, and this is a telescopic mirror, and the whole optical experiment is laid out over here in the OT. And same way in my OPD, Schlerin is set up in the exact area where the patient would sit. And instead of a slit lamp, I've just kept a mirror to be able to image. We chose healthy patients, mostly pre-operative patients. This was last year, who were coming for OR and had COVID negative on RT-PCRs. And we decided to test all sorts of various masking barrier devices. We also wanted to study how the room circulation, like fans and air conditioning, plays a role. So this is just to orient you. This is a normal person breathing. Notice then when normal tidal breathing is happening, all the air tends to move towards the, towards the surgeon, to the examiner side, and there's an ample movement of air. Using an N95 mask, not only while talking, but also during simulation of cough, as you can see over here, significantly dampens both the volume and the direction and the distance traveled by the air. Now, whether this contains any active COVID virus or not is anybody's speculation, but with a good mask, this can easily be achieved over a cloth mask. So N95 mask works better. A very interesting finding we also found was, look over here. If you notice over here, there's an excessive leakage happening from the top of the mask because of these loosely fitted masks that patients normally come up with, the tendency to pull down the masks. So we decided that we are going to tape all the patients' masks even before they enter the OPD. In the outside, my security guard tapes all the masks. And this significantly reduces the amount of aerosol being generated and thrown out from the top of the nose all the way onto your slit lamp and maybe onto towards you also. Just to demonstrate, this is how loosely fitted mask is. And like most of our surgeons would tape our OT masks when we are operating, the same way we would do. This also tends to avoid this patient's tendency of trying to pull down the mask when I don't know why they want to do that, but it helps in that also. Barrier devices like a face shield or a breath plate go a long way in completely obstructing any flow of air from the patient towards the examiner's side. But I think these devices need to be larger to be able to cover more area. So there is absolute role for you and for the staff to be able to wear face shields at all time points. Same thing with the OR. You notice how the patient's breathing is moving upwards towards the operating microscope in a normal, uncontained environment. Putting up a mask dampens both the velocity and the volume of air being leaked out, although some air does leak out, but this will also be a thermal print because it's an N95 mask. But the same principles in the clinic also apply into the OR, because if you have a loosely fitted mask, this whole air plumes coming out of the patient's nose can potentially go towards the surgeon. So it's basic takeaway points, which you always knew, but we reinforce: use an N95 mask preferably, or a surgical mask, but tape the mask not only for yourself and your staff, but also for the patient. One more thing that we found extremely interesting and something that can be employed in every clinic is the use of forceful air. So this is the patient in my clinic, sitting and talking with a loosely fitted mask, and this is turning on the air conditioning. Notice that we have a cassette air conditioning on the top, and the moment the air conditioner is turned on, the entire downwards draft pushes the entire volume of patient's breath down. So it's not moving towards the surgeon at all, but it moves down towards the floor. Same way, a big advantage of using a laminar airflow in the operating room, and notice even if the patient coughs wildly, and this is simulated cough, none of the air goes up, and it is all blown down because of the heavy forces of the laminar airflow in the OT. So best to have an overhead AC unit, or to have yourself placed so that the draft of air comes from behind you towards the patient. If not feasible, it's best to put a big, large table fan facing backwards from you towards the patient, so it pushes the patient's air back towards themselves. We could not record with the fan because the fan causes a lot of movement of the mirror and it's unable to document it properly. This was also published in the JCRS back in December 2020, and JCRS actually came up with urgent guidelines. So even before publication, they circulated this widely amongst all the doctors to make sure that airflow circulation and simple things like taping the mask can be used to our advantage in a sorry situation like this, where we're all stuck up and we don't know when to start the clinic. And if you want to start a clinic, we have this big fear of catching the disease and bringing it back home. I think simple things can go a long way in protecting us and protecting the patients and making sure we don't add on to the burden of healthcare at this point in time. Thank you.
Thank you, Sandesh, for an excellent talk. Excellent showing. Now the next speaker is Dr. Pranay Kapadia, and he is going to talk on basics of LASIK. Over to you, Dr. Pranay.
Hi, good afternoon, everybody. I thank BOA and Maharashtra Ophthalmic Association for giving me this opportunity. Am I audible? Yeah, thanks. So we've had wonderful talks regarding LASIK, the advanced kind of LASIK, and wonderful talk from Dr. Srivastava. So having very difficult talks immediately post lunch is going to be a little difficult. So I just decided to do away with that and give a talk which is something really, really basic for the general ophthalmologist. So what exactly do we do? Just one sec. So what is the need for this talk? The need is to learn the fundamentals, to start doing LASIK yourself for all the general ophthalmologists, and to improve our skills. And there are too many webinars. Just a small little history that LASIK was invented sort of by a retinal surgeon called Dr. Freeman in 1989. And then we've come a long way after that. Lots and lots of types of refractive surgeries to choose from. So there is LASIK, PRK, RK, AK, which one to choose from? So let's start with something which is absolutely basic. So we have to learn LASIK first. So all of us 20 years back went ahead and did some learning, books, journals, courses. Now we have a lot of seminars, conferences, webinars. But what exactly do you do when you have to learn swimming? You go to the swimming pool. So you go to a LASIK center. Now, obviously the LASIK centers are going to be difficult to put up by every ophthalmologist. Typically, if you calculate it, it comes to around 3 crores for the next 5 years. That comes to 5 lakhs a month. So if you have that much amount of spare money, you can start, or you can just choose a LASIK center. A LASIK center which could be convenient to commute, which will have flexible working hours, friendly staff, experienced surgeon, well equipped. Sometimes even the cataract OT attached to the LASIK center is important to manage the unforeseen complications. What is an ideal patient? A non-demanding, well-motivated, well-counseled. It's like almost an impossibility. Age group of 20 to 30, moderate myopia, small astigmatism is something that you should choose. A regular cornea, And the best patient for the first LASIK is an amblyopic patient. Whom to avoid? The anxious ones, the demanding, too scared, those who have small eyes, too flat cornea, too steep cornea, the one who squeeze too much, and certain professions need to be avoided right in the beginning. And remember, it's not a surgery. It's just a topical procedure on a young patient who's in educated class, who's conscious of their looks. So do not overpromise them and do not stress yourself. And important to remember that it's a forgiving procedure. Most important, and all the steps, I think it would start with refraction and end with refraction. So do a correct and dilated refraction, do the refraction yourself, recheck it, and do a contact lens free refraction. Lots and lots of corneal evaluation. So depending upon what your center or the center in which you are going to go, what do they have, you can have access to topography, tomography, pentacam, pachymetry, pupillometry, and the works. Counseling. This is a very, very important part. Whenever we undertake the LASIK courses and we teach the young ophthalmologists, they all ask that where exactly are the patients? We do not get any patients. So the patients are an ocean of patients all around you, all of them wearing glasses and contact lenses. Only thing that is important is how to counsel them. So you start with anatomy, teach optics, draw and show them, do some video, show them some video, give them a post-operative and pre-operative schedule, tell them all the complication in a nutshell, and explain them about the alternate procedures. And it's important that we have in our busy practice, we want to give the counseling session to our optometrist, counselor, and sometimes we tell the patient that, okay, just talk to that relative of yours who's got the LASIK done. But it's important to counsel the patient yourself. Procedure is simple, but it's important to familiarize with the procedure. So most important thing is to familiarize with the microkeratome. So I've had an opportunity to use with most of the microkeratome. At present, we use the SBK, which gives a very good result. And we can, if you have an access to a femto, then you can try and learn that as well. I, at present, use a Schwinn machine, but I've used the Zeiss and the Alcon in the past. Important not to omit any steps. So betadine and antibiotic drops preoperatively, proparacaine drops only twice. Inform the patient about the fixation of light and put a retaining speculum, tell them to focus well, mark the cornea, dry the phonicis, place the ring, apply the suction, and wait for the suction to be achieved. After the suction is achieved, lift the eye little beyond the speculum so that the forward and the backward pass of the microkeratome is smooth. Give the suction release and give the microkeratome back to the staff. First thing that you do after removing the microkeratome is observe the marks. Observe that all the marks are there and observe the surface of the flap is smooth. After that, lift the flap completely and fix the flap so that it does not come during the procedure. Fold it if required, dry the hinge, dry the bed, and start the tracker and start the LASIK procedure. During the procedure, ask the patient to concentrate on the fixation light. Most of the machine have green and the red as 2 fixation lights. So you can fire the laser. After the laser procedure is over, most of the laser nowadays finish the laser in a few seconds. Give a thorough wash, replace the flap, and put the bandage contact lens and antibiotic. And it's important to communicate with the patient that the procedure has gone very, very well. Lots of way to learn the LASIK, but most important is to discipline. Choose a friend who can teach you LASIK. Choose a center which is friendly, mainly the neutral center. If it is important for your practice. Choose a patient who is not that demanding. Be confident but not complacent. Do not omit steps and have good bedside manners. Indications are all known to us. Prerequisites are also known to us that the eyes must be healthy with a good corneal thickness, patient must be old, vision must be stable. Contraindications, we have studied a lot, most important being an unhealthy cornea, but anything which is unhealthy, like the unhealthy lens, retina, IOP, Sjogren's, all those are the relative contraindications. Post-operatively, we give painkiller immediately to the patient after asking the history. Give antibiotic drops and mild steroids for 7 days, tear replacement drops for 3 months, protective goggles for a week. We advise patient not to drive for a week and not to swim for 4 to 6 weeks. Goal is very important. Goal of the procedure is spectacle freedom. We want ourselves to be happy as well as we want our patient to be happy and the whole family to be happy so that the family can refer more and more patients to us. So I just thought that let's keep light talk and thank you very much for the patient hearing.
Very much, Dr. Pranay. That was a very nice talk. Thanks for summing it up. We'd like to move to our next speaker, Dr. Parul Deshpande. I'm honored to get to introduce her. She has been a very big pillar of support to all of us young ophthalmologists during this lockdown. And she's the director of Sarvodaya Eye Institute based out of Mumbai. Welcome, Dr. Parul. Over to you.
Thank you, Karishma. Yeah, I can share my screen. Can you see my screen?
Yes.
Okay. Is it visible now?
It's visible.
Yeah, okay. So I would like to thank you, Dr. Karishma, Dr. Nikhil, BOA, for giving me this opportunity. So what I would be talking about is infection and refractive surgery. So when we look at a post-refractive surgery keratitis, it could be a non-infectious variant or an infectious variety. So when you look at a non-infectious etiology, it could be a diffuse lamellar keratitis, which in a very less severe form, we tend to see very often, but the reported incidence is about less than 4.5%. Now, these patients usually present within first 24 to 48 hours of the surgical procedure. They do not have any pain or lid edema, but they complain of drop in the vision if the DLK is in the central visual axis. Now, the clinical presentation is usually in the form of diffuse or a localized cellular reaction, which is mainly limited to the interface. These reactions then coalesce to form clumps as the severity increases if we are not able to start steroid in time. Now, this form of DLK is more commonly seen in femto-LASIK as compared to microkeratome LASIK. And the treatment of choice, again, is steroid in these patients, and they respond very well. And very rarely we have to take these patients for a flap lift. Coming to marginal keratitis, I think, yeah. Which is nothing but a hypersensitive response to the staphylococcal antigen, which is present in the ocular flora. Now, these are more commonly seen where, in the cases of PRK and CXL, where we have an epithelial defect. And these also respond very well to topical steroids. Yeah, so coming to the infectious form, which is usually seen in less than 1.5%. These could have early or a delayed presentation, but usually about 60 to 70% of the patients present within the first 1 week of the refractive procedure. What one sees is the rapid drop in the vision, significant pain, redness, discomfort, lid swelling in these patients as the disease progresses. So initially it starts with variably sized localized infiltrates seen mainly in the interface with edema of the overlying flap as well as the underlying stroma. And as the infection increases, you will see the spread of these infiltrates in the surrounding tissue. One may be able to see anterior chamber reaction, flap melt as the severity increases. Since these patients are on topical steroids, sometimes signs may be masked and the symptoms may be more obvious. Coming to the early and the late presentations, the early presentation is usually caused by bacteria like staphylococci, streptococci, pseudomonas. Rarely it may be caused by fungi and the opportunistic infections. And late onset, which is usually more than a week later, usually is because of either fungi, non-tuberculous mycobacteria, or viral etiology. A very late presentation is usually seen in post-RKI, where we usually have recurrent epithelial breakdowns in the area of cuts because of the presence of epithelialness. And they can develop secondary infections very late after a few months. Now, this is a publication by Gerg et al., which came in IJO December 2020, a very beautiful presentation, where Dr. Gerg has tried to identify the organisms based on the clinical signs and the time of presentation. So if you see a white infiltrate, rounded margin, overlying stromal edema and a defect, which is presenting within a week of the refractive procedure, then it could be mainly bacterial. If you have an infiltrate with irregular margins, satellite lesions, endothelial exudates, which is presenting about a week after the procedure, then it's more of a fungi. And if you see a variable presentation like a ring infiltrate, linear, patchy, irregular infiltrates presenting more than a week later, then it's more of a mycobacteria or a nocardia. What are the risk factors? So a pre-existing dry eyes, MGD, or a lid margin disease Intraoperatively, there is contamination because of the reusing the blades, use of common surgical instruments between two eyes, or use of contaminated ring-lactate solution. Or if you have an excess intraoperative flap manipulations, so where you can give an access to the local flora into the interface and one can develop infection. And post-operatively, if there is a development of an epithelial defect, in patients with PRK and CXL, where you use bandage contact lens, topical steroids in presence of epithelial defect, there is a high risk of developing infection in these patients. Or if somebody does not follow the hygiene, can develop infection. So this is a very good, smooth flowchart which has been given by Gerg et al. So if you suspect a case of infectious keratitis in a refractive surgery patient, it's best to scrape them, subject them to microbiological assessment. So if you have a PRK, you can take the scrapings from the surface, but if you have LASIK, you can take it from the bed by lifting the flap. And in case of SMILE, you can go into the bed. This is followed by irrigation of the interface with the antibiotics. I also prefer to add antifungals. So if the patient has presented less than a week, you can give a combination of vancomycin along with 4th generation fluoroquinolones. Or if it is more than a week, you can add amikacin along with 4th generation fluoroquinolones before you have the microbiological reports. And one must subject these samples to the routine cultures like blood agar, chocolate agar, and the specific media like LJ medium for atypical mycobacteria, Sabouraud's agar for fungus, and also subject them to an add-on smears like 1% acid fast to pick up the atypical mycobacteria and nocardia, in addition to grams and 10% KOH. So if these patients show a good response and your microbiology is positive, you can continue the same therapy. But if you find that the microbiology is negative, but patient is still responding, you can continue the therapy. But if the patient is worsening, then one may have to decide to relift the flap, re-scrape. And in cases which are very severe, one may have to resort to surgical procedures like glue or flap amputation, or one may have to do a therapeutic keratoplasty if the infection is very severe. So this is one of the video where which is showing the how you can take the interface scraping, and so you try to identify the flap edge by trying it. So you take a surgical sponge, dry, then with the Sinskey hook, you can just remove the epithelium and then try to lift the flap. Now, once you are lifting the flap, it's important that nobody puts the saline or RL, so that the interface sample, is good enough for the microbiology. And once you have lifted, it's important to just lift a partial flap till the time you are able to expose the infiltrate. So once you have done that, you can take a 15 number Bart Parker, 15 number needle, the blade, and just take the sample from the interface. So once you have done that, and it's important to directly inoculate this on the culture media. So it's important that you keep all the culture media ready with you rather than sending a sample in ring-lactate or valence salt solution. Once that is done, you can deposit the flap and do a thorough wash with antibiotics, antifungals, and then similar to what we do in LASIK, you just dry the LASIK flap and see whether it is well in place. So with this, I'll come to some of the cases that I have managed. This is for the first case, which is a 24-year-old male, had undergone LASIK for low myopia. His right eye was normal, but on 4th post-op day, his left eye, he started having pain, redness, and blurred vision. So the primary surgeon discontinued his steroids and put him on tobramycin and moxifloxacin eye drops based on possibility of an atypical mycobacteria. So he was referred to me on the 9th post-operative day when his best corrected vision was 6/12 part. He had an irregular infiltrate in the interface and the overlying flap. There was a small localized epithelial defect. Based on the clinical picture, I felt it was probably a gram positive. And I went ahead with the interface wash, the flap lift, and the smears in this patient showed occasional gram negative bacilli. and cultured grew Pseudomonas sutseri. Now, this is an organism which has not been isolated so far in any of the post-refractive surgery. This is supposed to be a contaminant seen in a lot of media, but in eye, it's not been seen in the ocular flora. But a recent article which I went through, and it showed that it is localized in our meibomian glands. So I'm not sure whether this patient got it from there. So this patient was then continued on his ceftazidime eye drops along with tobramycin, and his best corrected vision improved to 20/20 at the end of 15 days. Another case, a 25-year-old female who came with pain on the third post-operative day in the left eye. The right eye was normal. Her best corrected vision was 6/60. And if you can see here, there was a central hyphate, or I could say the branching lesion, which you can see in the interface, and you can see an immune ring of an infiltrate around the infiltrate. So based on that, possibility of a fungus was there, but we went ahead, since it was too early for a fungus to present, I went ahead with corneal scraping, the interface scraping, and on the smears, it showed occasional gram-negative bacilli, but there was no other thing which was positive. The interface wash was done with vancomycin, ceftazidime, and amphotericin B, as I usually prefer to do it with that. So the next 48 hours, the infiltrate continued to worsen, and there was no growth in bacterial as well as fungal growth. So at this point of time, the dilemma was whether we should re-scrape. So I decided to wait for 48 hours, look for an additional response. If it was going to be worsening, then I decided that I would take up the patient for a relift of flap.
Dr. Parul ma'am, sorry to interrupt.
It's
We're
another
slightly
one.
overshooting time. Okay.
1 minute.
Sure,
So
sure.
this patient turned out to be a fungus, and we treated with antifungals, and she responded well. This is the third case, which was a bilateral progressive keratoconus. Since she was shifting her base, we did a bilateral simultaneous CXL. My routine convention, I put a bandage contact lens, I use a steroid with BCL. Now, the right eye was okay in the next post-op day, but the left eye was very bad. So if you can see this, you can see the multiple infiltrates, defect, but this patient also had an endothelial reaction, a trace hypopia. So based on that, we decided to go ahead with corneal scraping, which showed gram-positive foci. So we put her on fortified vancomycin, withdrew her ceftazidime eye drops, removed her bandage contact lens. She was showing a good response. On 7th day, we put her on steroids. She was still doing well. These infiltrates, which you see, are more of a, actually look like sterile. But since the patient had a GPC, we decided to continue antibiotics. And when I was withdrawing her steroid, she again had a flare-up of endothelial reaction. Now, since patient was shifting, she had these recurrent episodes of redness there again. Came back to me after 4 months, was doing okay. I withdrew her steroids. There was minimum scarring. She improved to 6/9 with the scleral lenses in both the eyes. But after a year, when she presented to me, this is her cornea. She was not on any drops. So I don't know whether this patient had a possible viral or an immune-mediated response. So to conclude, prevention is the key. Rule out dry eyes, meibomitis, proper sterilization is the key. Role of preoperative antibiotic prophylaxis is doubtful, but beta-adenine clinic is, I think, which we can do it. And it's very important to follow up these patients for first 2 weeks to look for any of these things which are developing in these eyes. Management is early pickup, intervention, scraping, and one should very judiciously use steroids and bandage contact lens in presence of epithelial defect. Thank you.
Thank you so much, Dr. Parul. That was some really nice photos and videos that you put up. While our next speaker, Dr. Hijab, is sharing her screen, if anybody would like to direct any questions to the speakers who have spoken so far. Till then, I'd like to invite our next speaker, Dr. Hijab Mehta. She's an eminent ophthalmologist from Mumbai and the director of Infinity Eye Hospital. Hijab ma'am, over to you.
Yeah, good afternoon, everybody. I hope you can see and hear me.
Yes, ma'am.
Yeah, thank you, BOA. Thank you, MOS. not able to move the screen.
Good afternoon, Mehta sir. Good afternoon, Hijab. Good afternoon, Dr. Suvarna Joshi ma'am. Good afternoon, everybody.
Good afternoon, madam. Thank you for the opportunity. So, in the initial days of excimer laser surgery, broad beam lasers were used for surface ablation. There were small optical treatment zones, and PRK was associated with iatrogenic haze, poor predictability, and regression, especially in high dioptric corrections. However, today with the new generation flying spot lasers, smoother ablation profiles, and the reports of iatrogenic corneal ectasia, there is renewed interest in surface ablation. Surface ablation is suited for patients up to 6. Now it has been extended up to 10 diopters of myopia, 4 diopters of hyperopia, 4 diopters of astigmatism. In patients with epithelial dystrophy, with borderline pachymetry, recurrent corneal erosions, narrow fissures, deep sockets, patients indulging in contact spots, very flat and steep corneas. It is contraindicated in patients with severe ectasia, presence of severe dry eyes, previous herpes, zoster and simplex infections, patients with severe atopy, autoimmune diseases like rheumatoid arthritis, SLE, and uncontrolled diabetes. There are also reports of PRK extra, where PRK is combined with cross-linking in patients with pachymetry between 450 microns to 470 microns, having a normal topography without any form thrust keratoconus. The outcomes are comparable to PRK alone. However, few patients did develop post-op haze, which took 6 months to resolve. Ectasia can occur after PRK, but the incidence is much lower than LASIK. The ectasia following laser refractive surgery that has been reported, 96% is post-LASIK, only 4% is post-PRK. And in these patients also, they had a pre-existing suspicious topography. The fellow eye had keratoconus. They had thin corneas, and there was also family history of keratoconus. Surface ablation can be done by mechanically debriding the corneal epithelium using the excimer laser or using dilute alcohol. Each has its own limitations. The epithelial healing time, the post-op corneal haze, the visual and refractive outcomes are comparable in all the three. So how does PRK compare with its peers? The safety, efficacy, predictability of PRK today is similar to femto-LASIK. About 94% patients having undergone PRK, 98% with LASIK at 1 year follow-up had 20/40 vision or better. SMILE had better outcomes at 1 month post-surgery, but at 3 months, both SMILE and PRK had similar outcomes. The biomechanical stability on Corvus ST post-PRK is better than that of SMILE and LASIK. PRK can also be done for residual refractive error treatment post-LASIK, post-SMILE, especially if the residual bed thickness is low. It can be done post-PK, DLK, and RK. Dry eye is less after PRK compared to LASIK. The corneal sensitivity and tear function improve much faster after PRK than LASIK. The 10-year follow-up results of PRK done for myopia more than 6 diopters show that there is significant myopic regression, almost as much as -1 per year. And 10-year follow-up for PRK less than -6 diopters shows that regression is much lower, about 0.01 to 0.1 diopter per year. These are reports where the older generation lasers have been used. Mitomycin C has not been used, but the newer reports show that the outcome of surface ablation is as good as LASIK. Only thing is the recovery, the visual recovery took much longer, almost 3 months to compare with that of LASIK. The results in hyperopia are safe, effective, and stable. However, the visual recovery is much faster, patient comfort is much more, and regression is much lesser with LASIK than PRK. The problem with PRK is the post-operative haze, which all the surgeons dread. The epithelial removal during the surgery releases cytokines which are responsible for the post-op corneal haze. TGF-beta plays a key role. It results in the activation of keratocytes into myofibroblasts, which result in the haze and scarring. Topical TGF-beta blockers such as SAHA are now being studied to modulate the wound healing. The transient haze, which is seen after PRK, it starts at about 1 month post-surgery. It becomes maximum at 3 months and then gradually subsides. It depends upon the laser platform that is used. The greater the depth of ablation, high astigmatic correction, exposure to UV, darker skinned individuals, delayed epithelial healing, genetic factors, poor ocular surface health, dry eyes, and nutritional deficiencies. Previously operated eyes such as post-PK, RK, history of keloid. There was the study conducted at Narayan Nesrale where they analyzed the corneal epithelium obtained at the time of PRK in patients who developed post-op haze, and they showed that they had this genetic dysregulation of the extracellular matrix remodeling pathways. The late onset corneal haze usually occurs 3 to 4 months post PRK. It persists much longer. It can occur as late as 2 years after the initial treatment. It is usually seen in patients with small optic zones. It is triggered by sun exposure, trauma, and surgery. This is one such patient who presented to us 1 year post PRK with haze. Regression is another problem that is commonly seen following surface ablation. It occurs due to small optical zone treatments and high refractive errors. The reason is epithelial hyperplasia, stromal remodeling, corneal steepening, maybe changes in the axial length, and lenticular sclerosis in old age. Mitomycin C is used to prevent haze. It inhibits the replication of keratocytes and the myofibroblast progenitor cells. The dose that we use is 0.02%, 10 seconds per diopter is the time, above 2 diopters. In high myopes, more than 6, mitomycin C is seen to inhibit the haze at 1 to 3 months, but may not help at 6 to 12 months because there are cases of breakthrough haze which are seen. So the questions remain regarding the optimal treatment parameters and the long-term safety of mitomycin C. This is a good recommendation from the December 2020 IGO issue where they have mentioned that all ocular surface problems, lid margin problems need to be addressed prior to the surgery with topical steroids, lubricants, immunomodulators, oral doxycycline. Once the surface is stable, then we need to plan the surgery. The other measures that one could take intra-op is give a chilled BSS wash for 30 seconds after the ablation. This reduces the pain and the haze by dampening the inflammatory response. High decay silicone hydrogel bandage contact lenses, they help in epithelialization. They reduce the pain. They inhibit the polymorphs and prevent reactivation of the keratocytes. UV protective eyewear is recommended for a year post-op. Oral vitamin C and topical steroids need to be given for at least 2 months post-op. The topical steroids definitely dampen the inflammatory response and delay the onset of haze, if not prevent altogether. There are some patients with corneal haze who do not respond to topical steroids. One of the reasons could be that the anterior stroma gets repopulated by myofibroblasts of different stem cell lineage. Either they are bone marrow derived, which respond to steroids, or they are from the residual corneal keratocytes, which are not steroid responsive. NSAIDs can be used judiciously in the first 48 hours or 72 hours to reduce the pain in topical or oral form. One needs to be cautious while using them. They block the cyclooxygenase pathway and direct the excess arachidonic acid to the lipoxygenase pathway, which produces leukotrienes, and these in turn recruit neutrophils. There have been case reports of peripheral sterile corneal infiltrates following PRK. The corneal haze can be graded depending upon the intensity and the visibility of the anterior chamber details. For late onset corneal haze, it is still suggested that we could give a trial of topical steroids for 8 to 12 weeks, use preservative-free lubricants, can add tacrolimus eye ointment at bedtime, can give oral doxycycline for the meibomian gland disease, oral vitamin C and UV protection.
And just a gentle reminder.
Yeah, the last slide.
Yes,
Yeah,
thank you.
So for retreatment, anybody who comes with an uncorrected visual acuity of 20/40 and significant haze regression with complaints is a candidate for retreatment, which should not be done till at least 6 months post-surgery. And it's a good idea to do an epithelial OCT prior to surgery to determine the epithelial thickness. Sometimes the regression may be due to the epithelial hyperplasia. So patients who come with an epithelial hyperplasia simply need an epithelial debridement with mitomycin C without ablation. And those who do not have epithelial hyperplasia but have still regressed need a repeat PRK with mitomycin C or LASIK depending on the corneal thickness. Those who come with severe haze will need a PTK with mitomycin C and without ablation. So just to conclude that the long-term outcomes for surface ablation are safe in patients with low to moderate myopia, hyperopia, and thinner corneas, and advanced surface ablation will definitely be one of the treatments available to the refractive surgeon. Thank you.
Thank you so much, Dr. Hijab. We will move on to our next speaker because we're running slightly tight on time. Our next speaker was supposed to be Dr. Nitin Balakrishnan. Unfortunately, he has lost his mother-in-law this morning. And on behalf of him, his daughter-in-law, Dr. Pavitra, will be presenting. Welcome, Dr. Pavitra. She's a young ophthalmologist who has joined our Bombay clan. Over to you, Dr. Pavitra.
Thank you, Karishma.
Dr. Hijab, till Dr. Pavitra starts the presentation, you mentioned a patient coming for a retreatment having a persistent or a severe haze from the previous treatment. In such a patient, would you be modifying your treatment parameter or would you be following a slightly different protocol to ensure that there is no recurrence of a haze or a regression?
So, after conservatively treating with steroids and all, if the patient still doesn't improve, then we would consider a PTK and definitely will use mitomycin C minimum for a minute to prevent haze. And maybe the steroids also, normally I use only for 2 months post-op, but for this patient, we need to be used at least 3 months post-op.
And a stronger steroid.
Yeah, and a stronger steroid.
Hijab, I also have one, sorry.
What?
Go ahead.
How long do you wait before intervening? So
at least 3 months.
So do you think 3 months the haze is going to stabilize?
Minimum 3 months, unless the patient is like really uncomfortable and complaining, but 3 months.
Because sometimes we see the haze over a period of
many times. Yeah, many times, but that could take, over a year, maybe more than a year also. Most haze disappears. Even if you don't do anything, but that may take years.
You would need to differentiate whether it was basically a haze and a regression versus a primary undercorrection, probably. Then.
Correct.
If it comes early on.
Correct.
Any role of cyclosporine A?
What's sir?
Any role of cyclosporine A?
Actually, it's not so effective. And studies have also shown that it really doesn't work so well. Maybe I have not tried tacrolimus, but that could be used. That's stronger than cyclosporine. But steroids are the go-to.
Pavitra, can you share your slide?
So I'm trying, just give me a minute.
Till then, shall I ask someone else to go ahead and speak?
Yeah.
The next speaker.
Can I start?
Yes, please. Dr. Vavikar. Dr. Vavikar, you can start your talk.
So good afternoon, friends, and thank you, Dr. Lahane sir, Dr. Ragini, team BOA and MOS for giving me this opportunity. I'm going to talk on Contoura LASIK, improving quality. So we started doing LASIK in the late 90s of the last century, and immediately we realized that we are having a problem of glares and halos, and it was attributed to HOA. The various approaches were taken to treat them. One of them was wavefront guided LASIK, second was the Q-adjusted LASIK, and the third was topo guided LASIK. All of them had their limitations. But today we are having more interest in the topo guided LASIK. It was used basically for treating the corneal surface irregularities. But because the ablation was irregular in different areas, unequal, it did not follow the standard Miralles equation, and therefore we ended up with refractive surprise. And therefore it was made to be a two-step approach where the first step you correct only the corneal aberrations or irregularities, and the second step you correct the refractive surprise or whatever is left behind. In the meantime, US FDA wanted data for topo-guided LASIK for primary eyes, And that is where the C4 C12 compensation mechanism was thought of. Now, C4 stands for the spherical refractive error, and C12 stands for the spherical higher order aberration. Now, whenever we are treating corneal irregularities, in essence, we are treating HOA, and they will be reflected by change in the C12 value. And so this change in C12 value is responsible for the refractive surprise, which can be manipulated by altering the spherical equivalent and thereby manipulating C4. So it looks, to say it looks very complicated, but actually it's quite simple. And when USFDA study did that, they found to their surprise that the results were very good in terms of uncorrected, best corrected visual acuity, quality of vision, photic phenomena, and most of the patients said that they would recommend. Now, when people, okay, now how to do this? You use Vario topologizer for acquisition of the data and workstation, and this is the example EX500 machine, and various calculations are done on the workstation. Now, this is a simple PDF file sent by Alcon on what to do and what not to do while doing Contoura. Now, this is adhering to the USFDA study, but what we realize is that only around 20% of the patients, they fall in this. And there are lots of patients who do not fall in this. So in reality, when you start applying, you have to scratch your head quite a lot, and the results were not as good. Canalopoulos started working on this, and he said that let us try treating only the topo refraction and or the cylinder basically. And of course, he landed up with surprise. Then a second stage came when we were treating midway between the clinical refraction and the manifest refraction or the cylinder. The results improved, but still we were having problems. Now let us look at how it is actually done. This is the workstation, raw sagittal data, as many identical maps you can take as possible you have to take. And then you feed in the modified refraction as 0. Once you do the refraction 0, whatever you're left over here is the higher order aberrations you're going to treat. Now you can understand that on one side there is a aberration of 10 microns. How much refractive effect it will have, it is very difficult to understand. This is where the C4 C12 compensation is done. Okay, and you saw that the results were quite good, that 31% of the patient had at least one line improvement in the uncorrected visual acuity, best corrected visual acuity, but 11% of the patient had the exactly opposite effect. So there were some patients who had a problem. And therefore now, okay, so as far as USFDA study is concerned, Contoura is good, but there are lots of patients who do not fall in that. And therefore, roughly we can divide the eyes into 3 categories. Number 1 is virgin eyes without any pathology. That means a person who walks in for LASIK and we find that he's a good candidate for LASIK, but the axes do not match and cylinder do not match. Then second is the virgin eyes with pathology like FFKC, keratoconus. That is the second level where we can extend our indications to. And the third is previously treated eyes with or without pathology, post C3R, enlargement of optical zone, or decenter ablation, LASIK ectasia, post PKP, etc. Now, for this, Mark Lobanov did an excellent work in the form of a software called FRCS, which is an analytical engine which is used for improving the accuracy of the topo-guided LASIK refractive, result. So in this diagram, you can see that there are 3 elevations. We call them taluses, and what effect, refractive effect they have, that needs to be calculated. And there are 4 sources of cylinder. Number 1 is the anterior corneal astigmatism, topographic astigmatism, these taluses, posterior corneal astigmatism, internal corneal astigmatism. All these need to be factored in, and they are vectors. So you cannot just add them or subtract them. So you can see over here, there are the diagrams, and this yellow line is the posterior corneal astigmatism, and the net effect of all this vector summation is cylinder in this direction. So roughly you can say at around 20 degrees and whatever the power be. This is done by FRCS, and then adjustment for a spherical equivalent is done. That means if you are treating additional cylinder, it is going to have some effect on the refractive error. And so you'll have to decrease the sphere by half of that. And then nomogram is applied. All these things are done by FRCS. And so for the cases for which I used to take around 20 minutes breaking my head over how much exactly to treat, FRCS is doing it in 10 seconds. So, and the results are much better. Now, expanding your indications. I'll show you one case here. This is the FRCS. This is how you fill in your data. And now you see in this case, I'll read it for you, this red warning, that it says that either you don't do Contoura or you do two treatment, dual treatment. One is Contoura treatment and then WFO treatment with a 0.75 residual cylinder. We did exactly like this, where we did a dual consecutive treatment and the result was bang on target. Then expanding our indications, this is a case of FFKC with a low refractive error, and we use FRCS and try to correct the refractive error as much as possible, along with PRK extra. Of course, proper counseling was done, and we worked out the patient extensively before taking the decision. And this was the output of the FRCS. You can see that various vectors are there. I showed you earlier in a different manner of the same case. And the last and the most interesting case is this patient of Keratoconus grade 3. You can see that K reading was almost 65. Okay, and patient was really, having 6/18 vision. We used FRCS. Over here, the aim was only to cause within the corneal surface. We did not bother about the refractive error at all. And we did topo-guided PRK. We can't call it Contoura now because it is no more a primary eye or a virgin eye. So topo-guided PRK along with C3R we did, and this is the post-op result. You can see the tangential anterior map. I'm sorry, this is MS39 picture, and this is the pentacam picture because by that time I shifted from pentacam to MS39. But it's sufficient to say that the cornea is very, very regular, and patient improved from 6/18 best corrected to 6/6 best corrected. And that is where we are giving real benefit of the procedure to the patient. And so after 6 months or 1 year, he will be a very good candidate for ICL or scleral contact lenses or something like that. So that way, that is all, friends. It's a wonderful technology, Contoura or topo-guided PRK, topo-guided ablation, and we must exploit it more. But the journey has just begun. A lot more things to do. Thank you very much.
Thank you so much, Dr. Bhavikar, sir. We are running a little tight on time, so without further delay, let's move on to Dr. Pavitra, please.
Dr. Bhavikar, sir. Bhavikar sir is actually a sir for me because he was 1 year senior to me. And though I bullied him a lot, I think he's the one who taught me so many things that I know in ophthalmology, suturing, correcting my basics. So he's actually my guru.
Pavitra, you'll have to unmute yourself.
Mute yourself. Yeah, please unmute.
In spite of everything, I really thank you to come for this scientific program. Condolences to you, Pavitra.
Thank you, ma'am.
Good afternoon, Dr. Lane, sir.
Good afternoon, Ragini. I was listening, Bhavikar.
Dr. VC sir is here, Suvarna madam is here. Santosh is here.
I saw the all stalwarts are there. So I was just all these. Yes.
Dr. Sudhan Bharti sir is also here.
Yes, yes. I spoke to him.
Karishma, am I audible?
Yes, you're audible.
Yeah. Good afternoon, everyone. I'm Dr. Pavitra Patel. Sorry for the inconvenience, but I'll be presenting this topic on behalf of Dr. Nitin Balakrishnan.
We can't hear you, Pavitra. Yes, now we can.
Now?
Yes, yes.
So
No, I'm sorry, Pavitra, your voice has gone again. There seems to be a loose connection.
Am I audible now?
Yes.
So I'll start my presentation now. Am I audible?
Yeah. Yes, yes.
Okay. So surface ablation or PRK was a surgery of choice in the early 2000s, but with the advent of femtosecond LASIK and SMILE, it went out of vogue. So what were the reasons?
Pavitra, I'm sorry, we have lost your voice again.
Am I audible now?
Yes, yes.
Okay, so the main reasons for it to go from vogue was mainly post-operative haze and post-operative pain that patients develop. So now it is well documented that patients develop haze following PRK, and main predisposing factors were ocular surface inflammation and exposure to UV light, which were known to cause the same. So how do we overcome these pitfalls and ensure exemplary outcomes post the procedure? So what do we do preoperatively mainly to prevent haze? Firstly, we should check for any kind of meibomian gland dysfunction and treat it with either oral doxycycline or topical azithromycin ointment to see and to diagnose any kind of dry eye disease or ocular surface inflammation. And in milder cases, to treat it with artificial tear substitutes, and in severe cases, to treat it either with intense regulated pulse light therapy or liquid flow procedure. Also to check for contact lens intolerance and treat it, to check for any systemic problems like keloids or acne, because these are the patients who have more tendency to develop post-operative haze or scarring. And also to check for vitamin D deficiencies and also treat the same if it is low. Now, intraoperatively, the method of epithelium removal also plays very important role in haze formation. Normally, we either remove it by alcohol or mechanical removal, which can be done by spatula or Amoy's brush, or it can be also removed by laser. Now, in a study of 75 patients undergoing PRK surgery in our center, we categorized them into 3 equal groups and found that alcohol removal patients developed more amount of haze in which the epithelium was removed with the alcohol as compared to mechanical removal, and it was least in the patients where the epithelium was removed by laser. So laser removal again can be either done on different platforms like Schwind or the Alcon Streamlight. Also, second important thing to prevent haze is judicious use of mitomycin C, 0.02%. And a collagen corneal shield is soaked in mitomycin C and placed over the cornea, following ablation for around 10 seconds per diopter. Now, things that are supposed to be done post-operatively are high potency use of steroid eye drops for at least a month, along with cyclosporine eye drops to prevent any kind of inflammation, to continue with the vitamin D supplements, and the most important thing, to ask your patients to wear any UV protective goggles for at least 3 months to prevent any late onset haze. Now, the different exercises that we implement to prevent post-operative pain includes, of course, the use of chilled balanced salt solution both before and after the ablation, as again it helps us, to reduce inflammation. Study conducted at my alma mater, Narayan Netralaya, Bangalore, proved that the use of BCL soaked in any form of NSAIDs like ketorolac prior to the usage of BCL acts as a depot, and it drastically helps in reducing post-operative pain. Again, the mode of epithelium removal will also play important part in post-operative pain. Thus, patients who underwent epithelial removal with the help of laser had faster reepithelialization in our study, and hence had subsequently lesser amount of pain post-operatively. Now, having spoken of the different practices to improve post-operative outcomes, I would also like to discuss advantages of PRK over other refractive procedures. Now, this published literature, again by Narayan Ectasia, highlights the facts that biomechanics of the cornea post-PRK is stronger as compared to other refractive procedures. So hence, in patients of suspicious topographies and thin corneas, PRK is the preferred option. Also, in cases of irregular epithelium, if the patient undergoes LASIK or SMILE, which spares the epithelium during the surgery, the postoperative quality of vision may continue remain altered as the aberrations which are induced because of the irregular epithelium are not treated. Therefore, again, such patients, if being treated by PRK, will obviously do better. And this fact can be refurbished by the data that risk of ectasia shows best results with a surface ablation. I mean, there are very minimal amount of ectasia patients that are being published post PRK. Also, in some professions like merchant navy or army, where a hinge or a LASIK flap or SMILE cap may lead to disqualification at the time of recruitment, PRK being a starless keratorefractive procedure is a better alternative. Also, because of the absence of flap or flap in the LASIK procedure, PRK again is a preferred choice in patients playing contact sports. Now, quickly run through few.
Dr. Pavitra, sorry to interrupt. We're running a little short on time. If we can wind up as early as possible.
30 seconds.
Thank you.
So this is a 29-year female who's a married female having moderate amount of myopia. Because she has a borderline pachy with a steep cornea of around 46.5 diopter and a suspicious bad D, PRK is always a preferred option in such cases. I'll skip this case. There's one more. This is a case of thin cornea. All other parameters are normal, but because the thinnest pachy is 491, it is always a safer. PRK is always a safer procedure to do because of its stronger biomechanics. Thank you. Thank you.
Thank you, Dr. Pavitra.
Shall I introduce the next speaker?
Yes,
yes, please, Dr. Vavikar, go ahead.
Yeah, our next speaker, it's my pleasure to introduce Dr. VC Mehta, sir. He is a founder and director of Mehta Eye Clinic, Ghatkopar in Mumbai, and very cool, composed surgeon. It has always been a pleasure attending his OTs and learning lots of clinical pearls from him. Over to you, sir.
Oh, thank you, Chandrasekhar. It was pleasure to hear you and to see you in person, at least on the web, since a long time. I'm going to talk to you about how to create femtoflaps. Am I visible? Am I audible also and visible also?
Yes, sir. Yes, sir.
You all know that the treatment part in the refractive procedure, excimer laser, has gone through a lot of sea change, and the creation of the flap has to keep pace with that. So traditionally, the flaps were traditionally created by the microkeratome, and it has served us well for the last 2 decades. But if you see the difference between the femto flap making and the microkeratome flap making, you immediately can make out the difference. The difference being that everything that happens in femto flap making is under direct vision, while everything that happens under a microkeratome flap is hidden behind the microkeratome. And unless and until you lift up the flap or lift up the microkeratome, only then you come to know what has actually happened. And there are many more advantages also of the femto flap making, as we will see as we go into the presentation. Other thing is that the flap related complications are quite few, no free caps, no buttonholes, and very precise depth, uniform and planar flap, so that when the flap goes back into the position, it fits in so well. You can see in this particular slide, this is how the microkeratome flap is sitting back, while as the the femtoflap sits in perfectly well, and there are less chances of microstray, which is very common in the microkeratome flap. So how do we create a femtoflap? Obviously, you have to go through these steps like pre-op evaluation, planning, and execution. In a pre-op evaluation, the most important thing is have a good look at the patient and the eye, and have a good look at the cornea. This is very important because even a slightest of a scar in the deeper level will create a problem during the femtoflap making. And also look at the eye measurements like the white to white measurements and the K readings. You also need to look at the patient characteristics, whether the patient is apprehensive or no, whether the patient has a small palpable fissure, tight orbit, large nose, floppy conjunctiva, because this can create problem during your femtoflap making, and you need to address this little differently. Planning, we need to look at the thickness of the flap. What are we going to create the flap? Traditionally, conventionally, I do a 100 micron flap, but you can go in for a 90 micron or 120 micron, depending on how much residual you're going to leave behind. The flap diameter also needs to be adjusted according to the type of treatment that you're going to do. Like hyperopia treatment will require a larger bed and therefore a larger diameter of the flap. And the hinge position will differ. If you have an astigmatic treatment like this, then you have a nasal hinge preferred in this case. And in the astigmatic treatment like this, the superior hinge is good enough. All the parameters you can adjust beforehand before you start the machine, and you can always change your hinge position, the angle, the side cuts. Energy is the most important part, which will decide how freely the flap will separate when you try to lift up after the femto treatment. Before you start, most important is make the patient quiet and peaceful, and tell them what do you expect. Light ko dekho is not the word to be used, because patient is seeing too many lights when they lie down under the machine. So be specific what light to look at. Also explain regarding the pressure sensation and the blackout. On one hand, you are talking to the patient that light ko dekho, and suddenly the pressure goes up and everything becomes blank. If you do not forewarn the patient about the black lights, he may panic, or he or she may panic. So these are the things that you will make your patient more cooperative than otherwise. Docking is the most important part in a flap making, femtoflap making. You have a PI, which is a single piece, and it is it is one for each patient. There's a one-step suction and a shorter suction time also, and it is quite okay for the patient to go through this. Very important when you dock the patient, when the dock, there should not be excessive fluids. There should be no debris, eyelashes, or conjunctival folds. You try and avoid fogging, because once the fogging takes place, you just can't see anything. So you need to wait till you go close to the eye and inform the patient regarding the pressure sensation. Let's look at this particular video of femtoflap making, and you will realize the docking. And very important is that your docking should be on the center of the pupil. If it is not, then you can make some last minute adjustments. And here you can see that the docking is proceeding very well, and there are no leakage of fluids, etc. So this is good enough docking for you to proceed with the cut. Now, last minute fine tuning is something that is very, very, very useful for the surgeon, because you see here we have done the docking, but the center of the flap is not on the center of the pupil. So you make certain adjustments. You make the flap diameter a little shorter to keep the flap centered over the pupil, and all these things can be done before you actually make the cut. So this fine tuning is a very important kind of aspect of a femtoflap making compared to the microkeratome flap making. Now, observe closely when the flap creation is taking place, because there might be some clue here that whether everything is good enough or not. In this particular case, everything looks good enough. I would not have any problem in lifting the flap. But there are clues when something is missed out, these areas are missed out, then that's where the adhesion is likely to be there. So when you lift up the flap, be careful in that particular area. OBL management in a different platforms, like I have used FS200 and I'm using actually the LensX platform for the flap making. In an FS200, the venting takes place from just 1.7 millimeter of area, while venting in a LensX platform takes place all around 360 degrees. Therefore, the chances of an OBL formation in a LensX platform is much less than with the FS200. In one of the cases of FS200, I had an air bubble in the anterior chamber as well. So the gas management in a LensX platform is fantastic. We will see the gas management in FS200 versus the LensX. You can see that the gas is trying to evade from this 1.7 mm opening, and sometimes it can get clogged there. And if you see here, then you can see this gas escaping all around, and there's no chance or very minimal chance of an OBL formation at the end of the laser treatment. Okay, flap lift. So once you have observed that the flap is properly made while the femtosecond was going on, it's quite easy to lift up this kind of flaps. Just go in and just swipe your separator up and down once, and you can lift up the flap. You can see the quality of the bed is so wonderful that it's easy to appreciate the quality of the bed. So in my opinion, the femto flap making offers a lot of precision. It offers a lot of control, in the sense that what is going to happen, you have a control over what is likely to happen, unlike the microkeratome flap, where things happen based on the nomograms. Of course, microkeratome has served us so well, but in today's time, where the treatment part has developed so nicely, I think we need to supplement this with a femto flap making rather than a microkeratome flap making. And both the precision and the control offers a greater safety for us in doing our LASIK. So ever since I got the femto flap maker, we have almost given up the microkeratome flap making, reserve it for certain cases where the femto is contraindicated. And mind you, the complication rates has gone down drastically, the flap related complication, and there is much more ease of making the flap, and which will complement also to the treatment that we do, like the Contoura, etc. So thanks a lot talking to you guys. If you have any questions, I would be definitely answering it. Thank you.
Thank you, sir, for excellent talk. And may I request Dr. Suvarna Madam to introduce
Yes.
Bharti, sir?
Thank you so much, Dr. Mehta, sir, for a wonderful talk. And may I introduce our last speaker, who is a guest speaker, Dr. Sudhan Bharati. He is the director of Bharati Eye Hospital, Delhi, and he will be talking to us on biomechanics as an aid in decision making in refractive surgery. Over to you, Dr. Bharati, sir.
Thank you, Dr. Suvarna. And I must thank Professor Lahane and Professor Ragini for giving me this opportunity to be part of this BOA virtual meeting, which is absolutely wonderfully going on. And I'll be Okay, somebody has to unshare the screen.
Thank you, Dr. Bharti, sir.
Mehta sir.
Thank you, Dr. Mehta,
VC
sir.
Mehta sir, will you stop sharing, please? Please stop sharing. VC sir, please stop sharing your screen.
Mehta sir, you have to stop sharing your screen.
Bharti sir, you can start now.
Yeah, so now I can start sharing my screen. And there we are. We are talking about, I'll be talking about biomechanics as an aid in decision making in refractive surgery. And I'm sure I'm audible as well as my slides are visible.
Yes.
Yes, sir.
Great. So the most important fact we have come to understand over whatever 25, 30 years I've been doing LASIK, it sometimes becomes impossible preoperatively to identify all patients who would go into ectasia. And in fact, a couple of patients who were like having a possibility of ectasia, and we were very conscious of the fact that we'll be careful and do everything and other measures we take like thin flap and all those factors, still they don't go into ectasia at all. So those two things, and we started doing topography and then went on to go on to pentacam to to understand that pentacam is the gold standard as of now. But still, sometimes we go wrong wherever, even when the parameters, the cutoff is 1.6, sometimes even those patients show a sign of ectasia at a later point in time, maybe 6 months to 1.5 years down the line. And then we are at a loss to understand what has happened. So there's a new tool which has come up in a combination of pentacam, and that is the corneal stiffness parameter, which is measured by Corvus. So what I'll be talking about is the biomechanics, which we can safely predict as to whether this patient's cornea is weaker, and we have to take extra measures to be safely doing LASIK or a refractive corneal procedure in all these cases and not have any issue at a later point in time. So this is good for pre-refractive surgery screening, also to measure the effect of cross-linking, predict the outcome after refractive, and customize treatment in refractive and corneal surgery. So now this corneal stiffness parameter was developed by Vincigura, and we now realize that once we are doing an applanation with the Corvus, there is a flattening and then concavity which occurs on the corneal apex, and then it starts coming back, and that is what we are measuring, and this is what we are going to measure as a corneal stiffness parameter. So this is a measure of load by direct measure of deformation of the air puff which is provided by the Corvus system. And this is the vertical displacement, which is measured by a blue light, which is not exactly ultraviolet, but it measures the deflection to a very accurate extent, and we find how much is the deflection which is there. And there'll be two things which are happening. So we'll, and this evaluation, which becomes, important once you see that all this was different when it was measured preoperatively, and when there is a little bit of corneal thinning measured after the LASIK or whatever corneal surgery you have done, even SMILE. So changes in the biomechanical properties in PRK compared to LASIK and SMILE, we have come to understand that there is hardly any changes in PRK as compared to LASIK and SMILE, which are comparable, and the changes in the biomechanical properties are almost the same. So the other factor which is important, this is all in vivo, and this is not, you can do the measurement in a patient and during or before the procedure and understand what is going to happen. And this is what is the measurement, what is the picture which we are seeing. This is the initial stage, and then there is the applanation, where after the applanation there is a puff, and this deformation occurs, which is a concave, and then it comes back and reaches the original situation, and you understand what kind of deformation was there and how much time the cornea took to come back. So this is the first applanation, then the highest concavity, and the second applanation. And these parameters are measured over a very small period of time, which is approximately 33 milliseconds. And this gives a very great idea and a very accurate idea about the corneal strength and all. These are the other pictures which are the same thing. Now, another factor which is important is, while there is the pressure on the eye, there is a deformation or there is a displacement of the cornea, as well as the whole globe also displaces backwards. So this has to be compensated, and these are the pictures which are superimposed over the previous pictures, and then we compensate for the movement of the eyeball as compared to the cornea. And that's another factor which we came to understand, that's important, that we don't take into consideration the movement of the globe. So, and there is a deformation and deflection, and this is what we have to understand. Now, the dynamic corneal response parameter, the whole eye motion, are deformation, and the when this is removed is the deflection of the cornea. These are two important facts. And this is the inverse radius curve, and this is the difference, that in the keratoconus, the thinning and the corneal thickness going towards the periphery is different than normal thin cornea. This pachymetric progression is very important to understand, and this is also measured with this system. So stiffness parameter and all these reports defined by Vincigura, and these factors, they are very important in understanding the biomechanics and to understand whether this patient is going to develop ectasia at a later point in time. And those two parameters, those two indices which are now having great importance is CBI and TBI. And CBI is biomechanical index, and I'll come to the reports. The second important thing is the TBI, total biomechanical or the tomographical biomechanical index formed by the Corvus. These, when the measurement for 11 millimeter as compared to 13 millimeter, as compared to 15 millimeter, and as compared to 19 millimeter, you will find that all these parameters, the movement of the graph remains within those three lines, which indicates that this cornea is, whatever is the pressure, it doesn't affect the corneal movement, despite the fact that there is a pressure difference. But if there's a change in the corneal thickness, or there is a possibility of central corneal biomechanical weakness, then these parameters change to that extent that you understand that all these factors come into play, and then the possibility of ectasia is there in all these. Now, another thing is that CBI, it is green up to about 0.25 or maybe a little less than 0.25. But anything more than 0.5 and going up to -1, it indicates that the cornea is weak and we should not be doing a corneal refractive surgery. And these were studied in Brazil and Italy. And this was almost 98%. They were very specific and also sensitive, and they can efficiently separate keratoconus from normal eyes. So these are the two important. And then after CBI, the TBI was very important, the tomographic and biomechanical index combined, and that was a even better parameter to understand the corneal weakness. In all these cases, you will find that they have this is the machine, the Corvus and the Pentacam, and the combination of the parameters, and you will find that in all these cases where there is this area falls in green is good, but even the CBI and TBI when they fall in red, so as compared to the bad display, sometimes CBI, TBI are not good, and in all those cases also you have to be very careful doing a corneal refractive surgery, and you may avoid on all these cases. So accuracy of bad for detecting mild or subclinical cases is much lower when detecting frank keratoconus, but this particular parameter, the TBI and CBI, they can detect them better, and they give you a warning signal whether you want to go ahead and do all this keratorefractive surgery in all these cases or not. So these are the study results from Renato Ambrosio, where TBI gave nearly 100% accuracy and gave a prediction accuracy of 100%. So these are biomechanical assessment, and as you can see, when bad displays within the green, sometimes the TBI, CBI are in red, and that is where you have to be very, very careful in all these cases. These are the few pictures which I can show you that these bad display are not showing as much weakness of the cornea as compared to the TBI and CBI, and this is the ultimate thing, that if it is from 0 to 0.35, you can go forward and do LASIK SMILE or any other laser refractive surgery. But anything between 0.35 to 0.75, you'd rather do a ICL or maybe a Trans-PRK or a extra. And anything more than 0.75, I think the best thing will be to follow up and no surgery now unless you're very sure that it is not progressing. Thank you very much.
Thank you, Dr. Sudhan. That was really nice. I think Dr. Chandrasekhar has a question.
Good afternoon, Dr. Bharti. It was a very nice lecture. Practically, on a day-to-day level, how much your decision is altered by Corvus? Because we have been hearing the reports that it is not so so refined the technology, and cannot be used in mainstream. But now a lot of people coming and saying that yes, he is using it regularly, or they are using it regularly. What is your observation that how much in the mainstream it is in your practice?
See, if I go back and look at my own cases where I did and did not do, the Corvus or TBI CBI combo throws up much more, caution, and you make you much more cautious for doing all this, or may not be doing a corneal refractive surgery. And in our armamentarium, if you have an IC, then in all these younger patients or especially younger ladies, I would say that, being overcautious is better than repenting at a later point in time when these ladies become pregnant, or at a late, long term, you have a possibility of having these ectasia. So definitely I would say that our number of cases which we wanted to do and now we wanted to reject is slightly increased by at least 15 to 20%. That I agree. But as of now, there's no other technology to challenge. the outcomes at that point in time, and that is why our number of patients who have undergone ICL, the phakic IOL, they have increased. But I am not regretting that. At least we know that all these cases are not going to develop any issues because of us. So that's very important.
Comment by Dr. Vaishal. You want to say something?
I just want to say the first generation Corvis ST was totally different. There the readings were not that predictable. Now the latest generation or the latest version of Corvis ST is much better. The TBI value is very, very good. It's a composite index which is using the simulation as well as artificial intelligence. So in my next talk, I'll be talking about more about it. So definitely it is here to detect subtle keratoconus, subclinical keratoconus cases, form-fruit keratoconus cases for sure.
I'm fully in agreement with Dr. Vaishal. Thank you.
Dr. Bharti, if the Corvis or the biomechanics study throws up a red flag, then in such a patient, would you totally, not do a refractive surgery procedure at all, or would you then opt for a surface ablation? What would your protocol be?
Unfortunately, I started my refractive long back in 1990, 92. So I personally never did surface from the beginning, because at that point in time, mitomycin C was not so, easily available, and there were no studies regarding the mitomycin, and there were a lot of my friends who were doing PRK had developed, the patients had developed a lot of reticular haze, even when the power was only -2. So from day one, I started doing LASIK. I had a microkeratome, and from day one, so there is absolutely hardly any real experience of PRK in my own hands. And but in all these cases, where looking at my clinical acumen and whatever clinical experience I have, in all these cases, I would rather wait for a period of maybe 6 months, and then go ahead and do another workup for LASIK before jumping upon the ICL. And if I find that the parameters are still not so good, I would rather not do a corneal refractive surgery. But there is a possibility that I'll get another 5% back into the fold of corneal refractive surgery after 6 months.
Thank you, sir.
Thank you, Sudham Bharti. Thank you very much. Thank you.
Thank you, sir. Thank you very much, and all the best to you for the upcoming election, sir.
Thank you, sir. Thank you very much. Thank you. Thank you, Bede Saab. I think RC and all the speakers, thank you very much. Thank you. Go ahead.
Thank you, sir. Thank you. In fact, we have another session lined up.
Yes.
And
go ahead for the next session.
Speakers are, yes, sir.
Before overshooting by 3 minutes. Over to you, Dr.
As Bede was the this convener, this apna chairman. Should overshoot.
I welcome you all.
No, sir, no problem with the overshooting. There is always some time gap.
We have got 15 minute का शाक अवसर है बीच में है.
So we just thank everybody for being here, giving your time and the warmth and the affection. Don't worry about the time. Thank you so much, everybody.
Goes to your efforts and planning, Professor Ragini and Lahane sir and everybody in the team BOA. And thank you from MOS for involving us also in this wonderful.
We are one family,
and
not
we are one
only
family,
BOA
yes.
and MOS. See,
Yes.
Sudham Bharti sir, it's all India is one family, not only BOA
it is all
and
one
MOS.
family, yes. Yes, it is all one family.
Yes.
Definitely.
And it's a solidarity which we are showing.
So it's my name, but you see one girl over here, Karishma.
Yes.
So it's my
She
name
has
and
done
her work.
wonders, Yeah.
Thank you, ma'am.
Behind the scenes.
Thank you, everyone.
She was coordinating everyone.
Thank you. Yes. Thank you,
you,
everyone. Thank you so much.
Thank you, everyone.
Thank you, Professor Rajesh, for next session.
Yeah, thank you, sir. We have all esteemed faculties who are topmost refractive and cataract surgeon of India. And with me, Dr. Sonu Goel, who is a chairman, Dr. Kishore Pauja, who is a co-chairman of the session, Dr. Sujal Shah and Vaishal Kenia, who are convener and co-convener. We have 10 talks lined up in 1.5 hours. So we have very limited time, maybe around 10 minutes per talk. In fact, 9 minutes per talk. So I request everyone to stick to their time, and without taking too much of time, I request Dr. Mustafa Parikh to share his slide. His topic is cataract surgery in keratoconus.
Good evening, Dr. Foglas. Good sir. Good afternoon. Thank you. Thank you for being with us. Thank you, Dr. Rajesh, Vaishal, Dr. Mustafa,
Hi,
Dr. Kishore sir, Natasha, father-daughter duo.
Thank
Dr. Reddy sir.
Thank you. Thank you, everybody. Dr. Fogla sir, thank you. Thank you, Joshi. Thank you, everybody. Thank you all. Joshi Sahib, continue.
Yes, sir.
Thank you, Sujal.
Joshi is a teacher, so he will be strict. Okay, Joshi. Go ahead.
Hi.
I request Dr. Mustafa Parikh to share his slides. His talk is on cataract surgery in keratoconus.
Hi, how are you? Am I audible?
Yeah. Go ahead.
Yeah, you can see my screen?
Yes. No, we can't see your screen, in fact.
Okay, just let me. So I need to go on the screen share.
Yeah, share. That share option is there. Yeah.
Yeah.
Now we can
Is
see your slide.
Yeah. Is it fine?
Yeah, perfect. Go ahead.
Hi. Very good afternoon to one and all. And I would like to thank at the onset Professor Ma'am Dr. Ragini. Wonderful present. You have run a wonderful program. Professor P.P. Lahane sir and our co-esteemed chairman. Very good afternoon to one and all. My topic is cataract surgery in keratoconus, and the challenges which we face are 4 challenges. Very important challenges is what is the formula we would want to use, what is the IOL we would want to use, what are the challenges in the surgery, and how do you manage the unpredictable refractive outcomes. Of this, our esteemed speaker for IOL selection, Dr. Goel, is also going to be later on, going to be talk about it. So I'll be brief about this. Very essential point to consider in this is the age of the patient. What is the stability? What is the staging of the keratoconus and the high risk characteristics? 2015 in IGO, Dr. Natasha and all have a wonderful presentation, and they've listed the high risk characteristic, 5 of them: age, eye rubbing, atopic eye disease, systemic diseases. So these are very, very important points which one has to consider. In these cases, tomography is very important, and we would want to know what is the stability of the cornea. And if it is not, then collagen cross-linking would be an answer. Various presentations which are there, BJO in 2016 by Stephen Tuft et al., they had concluded in this article, surgery cataract outcomes. In mild to moderate cases, the actual K values would be a suitable option for spherical IOLs. And when you have a severe keratoconus, in this case, the use of actual K values may lead to a hyperopic error, and hence they have recommended to use a standard K value of 43.25. Similar review of articles 2018, which they have, the conclusion is Pentacam is reliable and repeatable, standard K for severe cases, and they have said SRK-T formula stands the test of time. But overall, in this article, there was no really consensus of what would be the best formulas. A wonderful article, JCRS 2015, again, highlights when we are taking the K reading, and the posterior corneal curvatures should be considered when you're applying it in for your IOL power calculations. This is a very important study which they did, where they compared 4 important measurement criteria. One is with a keratometer autoref, true net power, ERK, and manifest cylinder. So here what we are seeing is, as you can see in this slide, your equivalent K reading, the number 3, and manifest cylinders are very similar, but your true net power and a keratometer overshoots. So the take-home point is holiday EKR, the equivalent K reading, would be very important, which is there in Pentacam. And this is a report which we see, which shows the power distribution curve for KCN. And these readings would be very important in our calculations. Studies of our trifocal IOLs have also come in, and again, that's the same point. In your mild to moderate cases, if there's a stable K at a later age, can be considered after risk assessment of ectasia. This again important article, JCRS 2017, which states that sequential intrastromal rings and monofocal IOLs have a favorable and a stable outcome. As recent as 2020 JCRS, they did a bibliographic search of PubMed database articles, 851 articles, and the conclusion was, okay, yes, anterior and posterior curvature measurements are important. Optical biometer is important. SRK formula T still stands a test of time, and you can use also online ACR, ACSR as IOL power calculators. For the IOLs, the decision tree is, I'll be brief about it. Madam Goel is again going to be talking in details about it. But what you come to know is, if it's a stable and a K-cone, what you would want to go is for a traditional IOL with a positive spherical aberration. Once you have a RGP contact lens compatible, you can go for toric and a refractive multifocals. In a moderate type of keratoconus, if it's cross-linked done, age is more than 30 years, regular astigmatism, then consideration of a toric lenses can be done. Otherwise, a traditional IOL with positive spherical aberrations. So take home message in this slide, what I would want to know is, okay, we would want to avoid the negative aspheric IOLs, which we are all very fond of and which we routinely use. So this is one indication where your traditional IOL would suit the patient in all the three cases. The other indication for traditional IOL will be a post-hyperopic LASIK patients. Coming to the surgical trip, you need to plan the incision should be considered, scarring opposite the scarring area. Main incision should be 90 degrees away. C for the areas of thinning. C for the capsule thinning is recommended. And enhance visualization during CCC and use of rigid contact lenses to enhance visualization. This was one paper which was there in 2014, which says, okay, you're using a rigid Gaspar pupil contact lenses can aid in your cataract surgery in cases of severe keratoconus. One consideration which we would want to do is to do a primary posterior capsulotomies, as some of these cases are patients with Down syndromes where they may be uncooperative post-operative, secondary gag laser, and scarring, corneal scars. So primary posterior capsulotomy can be considered. Keratoconus corneas are thinner and floppier, so avoid clear corneal wounds as they may leak post-operative and induce significant astigmatism. Suturing can be an option considered, and preferable to have a 3-step corneoscleral incision. In advanced keratoconus, you may want to combine it with DALC or with FICO with monofocal IOLs. This was one interesting paper which was done, which mentioned about corneal ectasia following cataract surgery in patients with keratoconus. So in these cases, again, high-risk criteria should be understood. Pregnancy, hormone replacement therapies, and proper evaluation is important. Cases which would require a surprise and which you would require to do this thing, you have these wonderful IOL called as a Cellcoflex IOL, which can be put in as a piggyback IOL. Here, as you can see, point number 1, which is showing you a concave posterior surface. Point number 2 is showing you a convex anterior surface, clear corneal margins, and you will have a very good favorable results with this. These lenses are available as a toric lenses also, and toric multifocals up to the 6 diopters are easily available. Pre and post-operative consideration we would want to do is use anti-inflammatory eye drops, ketorolac eye drops, pre-operatively, start them 15 days before, trehalose eye drops, and low-dose steroids, use it for at least 2 months post-operatively. A wonderful research done by Dr. Rohit Shetty et al., where they talked about, augmentation of autophagy by using of trehalose and AMP9 elevators and inflammatory cytokines are inhibited by cyclosporin A. So to summarize, for IOL power calculations, it is nice to have AKR, equivalent K readings from Holiday Pentacam, quite reliable, quite stable. optical biometer for mild to moderate cases. And in advanced keratoconus, use average of 43.25. Time-tested A-scan sonography are sometimes used in operation theater when we are doing congenital Down syndromes and Turner syndromes and in cases of advanced keratoconus. IOL power selection, Madam is going to be talking, Dr. Goel, but I'll just briefly here mention, okay, yeah, this is the thing. This is one indication where you'd want to use a positive spheric IOLs. Toric IOLs can be considered in mild to moderate cases when you have stable and where you have age limit of more than 30 years. An option of Sulcoflex IOLs can be used for cases of piggyback and surprises. Surgical challenges, GA evaluation, look out for mitral valve prolapse. Incision should be at the thickest corneal depth. Use of corneoscleral incisions, use of contact lenses on the corneal surface, dye staining of the capsule, do it for a little more time, wait for 2 minutes because you may require it if you have a hazy cornea. Primary posterior capsulotomy can be considered, suture if necessary. Unpredictable refractive outcomes, think about collagen linking, Intacs, and therapeutic PRK. Our previous speakers did a wonderful presentation on that. Sulcoflex piggyback IOLs an option. Reevaluate the risk factors, and the use of cyclosporin and trehalose eye drops can be very helpful. Thank you very much. Thank you, all of you.
Yeah, thank you, Dr. Mustafa, for elaborating on so many IOL options in patients having keratoconus. Shall we go to second talk or and queries at the end of the session? If there are no queries, we can go for second talk.
You can ask them to send in questions in the chat box also, so we can just collect it at the end of the session.
I think there are no questions at present in the chat box. So we'll go for Dr. Natasha's topic on Intacs in keratoconus.
Thank you very much. At the outset, I would like to thank our respected mindful workaholic, Professor Lahane sir, and ever so humble Ragini ma'am, and a very dear friend, Karishma, for this wonderful opportunity and humbling opportunity. I'll share my slide. It's so good to see everyone doing well, smiling and not talking of COVID for once. Are my slides visible?
Yeah, perfect.
Okay, perfect. So the next 8 minutes, my job is to just refresh the reason why we are using. Let's start with why Intacs. This is quite an old technique. We are trying to flatten a steep cornea, and it had started many, many years ago with Von Graffe, when the gentleman said that you have to use pressure bandage with silver nitrate solution to cause flattening of the cornea. After which they caused visual rehabilitation by heavy blown glass that were used as contact lenses for a better and clear vision. So our intention with Intacs is to basically flatten a steep cornea. That in itself improves or reduces the spherical equivalent or the mean refractive spherical equivalent. Also, it improves the aberrations of the cornea. The total optical aberrations improve eventually. It basically works on the Barreker's law of thickness, which with the stretching in the steep meridian, it causes flattening of the steep cornea in the center. But what is really essential here is that with the advent of Intacs, the other factors that actually cause flattening or probably stopping of progression, which is the main etiology or the thing that we're concerned about, is cross-linking. So we cannot forget, along with Intacs, we have to consider cross-linking for these patients if the patients are progressive keratoconus. But of course, Intacs is indicated specifically for keratoconus, which was originally introduced for correcting myopia up to 3 diopters. So in order to cause flattening, let's just see how do we do, when do we consider Intacs, how do we do it, and what is the stepwise algorithm? The basic one when to correct is there is a simple algorithm that has been published in IGO by Nara Netral group, which basically says if a patient has got high risk for progression, depending on if the patient is young in age or has eye rubbing or has atopic eye disease, other factors like pregnancy, these factors, or if there is a frequent change in glasses, you would want to classify them if the patient is going to progress or it is going to remain stable, or you would want to observe this patient. So in that case, what you essentially do is look at the demographics. If there is a low or moderate risk of progression, you would just want to give contact lenses and watch for progression. If there's no progression, you continue with the glasses or contact lenses. But if there's high risk of progression, you would want to stop the progression first. This is done by corneal collagen cross-linking, after which you can do visual rehabilitation. But if there is progression and the patient is contact lens tolerant, you can just do away with corneal collagen cross-linking and go back to visual rehabilitation. But if the patient is intolerant to contact lenses, this is where our intervention comes in. If the corneal thickness is more than 450, that means there's adequate corneal thickness, you would want to do an ablative, laser ablative procedure. But if it is less than 450, that is the time you would want to cause flattening of the cornea with intracorneal ring segments. And in this particular case, we'll be talking of Intacs. So the most important factor that we need to understand in Intacs is we need to have central clear corneas. It can be used for keratoconus, pellucid marginal degeneration, and works wonders in post-LASIK ectasia. Intacs predominantly comes in two variants, that is the regular rings and the SK rings. SK rings are basically steep keratometric rings, and they have an optical zone that they cover. Let's come to how, the main aspect of it. This is just very simple 6 steps that we need to follow. Take a topography, take the refraction of the patient, and sit down with these 6 things. The step 1 is looking at the location of the cone. Now, how do we look at the location of the cone? Whenever we have a topography, we first look at the back elevation. We also see the most elevated point on the back also corresponds to the most steepest point on the axial or the sagittal curvature. Also, it corresponds to the thinnest point. Now, this will not correspond in patients who have got pellucid marginal degeneration or post-LASIK ectasia. But in classic keratoconus, you can have these factors corresponding, these points corresponding, after which you would choose the back elevation map, draw a square or lines around the 3 mm zone, which you can see here. And the most elevated point, if it is half of the cone is, or 50% of the cone is inside the 3 mm zone, then it is a centered cone. If 50% of it is beyond the 3 mm zone, then it is a decentered cone. It's as simple as that. If it is a centered cone, obviously you would want to choose a symmetric ring. If it is a decentered cone, asymmetric rings make sense, or you can also choose a single ring. Now let's come to the stepwise algorithm. Now this is again published in IJO, and it had received a gold award for being the most downloaded article as well. This is again published by my mentor, Professor Rohit Shetty. So now once we have decided if it's a centered or a decentered cone, step 2 is looking at the superior-inferior asymmetry. It's very simple. From 0 and 180, just draw a horizontal line. Look at 3 points above 0 and 180 and 3 points below and 0 and 180. And if the difference is more than 15 diopters, that means there's significant superior-inferior asymmetry. You would want to balance it somehow. So in that case, you would want to put a single ring. But if the difference is not more than 15 diopters, you can go ahead with putting a asymmetric ring. Now coming to, after which we are going to come to what is the mean keratometry of the patient that we are considering. Again, it's a very simple step. You go ahead and look at the KM, that is the K mean. If you don't have KM in your topography, just look at the K1 and K2. That means the steep K and the flat K, take an average of it, it gives you the K mean. If the K mean is less than 55 diopters, you would go ahead with a regular ring. That means it is equally balanced. And it is, the optical zone is much wider. If it is more than 55 diopters, that means it's a steep cornea, and you would want to specifically use SK rings in this case. After which you would come to the refraction of the patient. You would calculate the mean refractive spherical equivalent. Here is how it is calculated: sphere plus half of cylinder. Now, if you, whatever mean refractive spherical equivalent you get, you've already decided if you're choosing a regular ring or an SK ring from the from the mean keratometry. On that basis, you would choose what regular ring or the size of the ring is chosen based on the refractive spherical equivalent. So here is what you do. If it is less than 3 diopters, you would use a smaller ring, if it is more than that, then you would use a thicker ring, which is about 0.45 millimeter. Now, in this case, the next thing that we consider is the first 4 steps basically help us decide the ring, only the ring. The next two steps are actually the steps that help us decide where do we place those rings. Now, as we already know, depending on which variant we have selected, a regular or an SK ring, you would want to mark the 6 mm zone, and in the 6 mm zone, simply because we're placing the ring in the 6 mm zone or the 7 mm zone. So you just look at the thinnest point in the 6 mm or the 7 mm zone, mark that point, and 75% of that depth is where you'll place the ring. After which you come to the last step, which is the steep axis. You can get this from the refractive error of the patient. Also, you can get it from the topography. Now, in most of the topography, for instance, Pentacam gives us the flat K. You simply have to add 90 to that, and you would get the steep K of it. So this comes out to be about 120 degrees, and the refractive error, the steep K we were getting was about 110 degrees. So it is more or less similar. You would go ahead and put the place the incision at 120 degrees. This is just a very short video of how Intacs is done. It's best to do it under femtosecond platform. This is how we do it. I do it on the Bizumax platform. This is how the femtosecond basically makes a very quick channel, as incision is placed at the steep axis. This was done when I was a fellow. I was very fortunate to have the intraoperative OCT. So this is where I learned how the radial incisions look like, how the cut looks like. Now, this is a symmetric glide blade. It is primarily used channels. It is very, very important, especially in post-LASIK ectasia. You have to go deeper so that you don't go into the flap. You have to go at least 75% deep. You get a free, there's no resistance, and you know that you're in the right channel. After which you would use the brown insertion forceps. These are very specifically meant for Intacs. As you can see, there's a hole in between. It holds the Intacs ring very well in place. After which you would first direct the Intacs ring downward so that it opens directly into the channel from where you have already opened the channel. And this is how the ring is simply inserted. Try not to rub too much on the epithelium and try not to touch the epithelium, because you don't want the epithelial cells to go into the channel. So you very gently, just along the curvature, just nudge it and it simply goes inside. And you can do the same way for the other ring. What is very, very important here is that if you notice, you don't need to suture the primary incision. It sort of pauses very, very well after the Intacs ring is placed. And this is the simplest procedure. Here are just very simple, gratifying results after Intacs ring. If you look at the axial curvature, it just flattens significantly. In this case, it is flattened by almost 3.5 diopters. And where I've used asymmetric rings, where there's superior inferior mild asymmetry, with regular rings, asymmetric rings, it shows significant amount of flattening in the inferior zone. So to summarize this stepwise algorithm, first look at the location of the cone if it is centered or decentered. Look at the superior inferior asymmetry, more than 15 or less than 15 diopters, which will help us to choose what kind of ring, if it's a single or an SK, a single ring or two symmetric rings. The mean K value, if it is more than or less than 55 diopters. And of course, the refractive spherical equivalent, it helps us decide what is the size of the ring that we're going to place. The steep axis is where we get from the refraction or the topography. And the most important aspect is the thinnest point. It is about 75% of the thinnest pachy in the 6 mm or the 7 mm zone. And that's about it. It's very, very simple. It hardly takes 5 minutes to plan an Intacs ring and about 10 minutes to do the procedure. You can augment it with cross-linking. If you don't want to do it in the same sitting, you can always do it after 3 months, after the Intacs rings have completely stabilized. Thank you very much.
Thank you, Dr. Natasha, for an well elaborated talk on Intacs. Now I invite Dr. Kavita to talk on algorithm for an management of an corneal ectasia. We're given an algorithm for an keratoconus and the Intacs, but she'll just give us an algorithm for management of an keratoconus. We welcome Dr. Kavita Rao.
Thank you so much.
much, sir. I'll be talking about the algorithm of management of keratoconus. A lot of things have already been covered by Natasha, which is wonderful for me. Are my slides seen, sir?
Yeah.
So I'll be starting out with just talking before moving to the algorithm, just a little bit about the basics of keratoconus. Keratoconus, as we know in textbooks in literature, has been defined as a non-inflammatory ectasia of the cornea, which is usually bilateral, and there is ectasia and there is thinning. But when all studies which have looked at pathogenesis of keratoconus, now we know that there is also an upregulation of all the inflammatory mediators in the tear film. So it is not exactly a non-inflammatory disease. There is inflammation, though it might be a white inflammation. The causes could be varied, as she's already shown, probably like a lot of risk factors like eye rubbing, hormonal factors, etc. Diagnosis, the most basic way of diagnosing, of course, apart from clinical examination, you look at your placido. If there's more than 48 diopters of curvature, and if there's a difference, especially of keratometry between two eyes, that would be diagnosed keratoconus. Tomography, for those of us who have it, is definitely more advanced way of diagnosing keratoconus. We are not only looking at the sagittal maps, but also at elevation, the posterior elevation, which shows us the ectasia, and of course the various other indices which help us in diagnosing. When you are wanting to look at the algorithm of treatment, it's very important to define progression, because oftentimes it's, patient is just taken up for cross-linking if he's just coming to you for the first time. And that's where probably having a good, instrument which gives repeatable results, which is probably like, no financial interest here, but the pentacam repeatability is very good. If there's increase in corneal curvature over 6 months of 0.5 diopters, or if there's a decrease in pachymetry by 10% over 6 months, I think that can be safely considered as progression. That is like, and I think the newer modalities probably the subsequent speakers will be covering. And looking at the treatment algorithm of keratoconus, I often find that the patient has been cross-linked, but not much, thought has been given about the vision of the patient. The patient would be cross-linked, but the patient doesn't have much functional vision in the eye. So it's important first and foremost to look at what the vision of the patient is. Is he improving with glasses? Is he improving with contact lenses? And is he progressing? These are the two things which will help us, decide where we are going to fit this patient on this chart. If there is no progression and if he is happy with his vision, there is no risk factors, then you just monitor the topography 6 months, 1 year as possible. If his vision is, he's not happy with the vision and it's not progressing, then you could still consider some treatment modalities. Now, coming to the more common, in arm where the patient is progressing, but the vision is acceptable, then we just do cross-linking. But if he's not happy with the vision, or he has ghost vision, the accepted, not happy with the vision with lenses, BCVA is not improving, then depending on the corneal thickness, you could either do a topo-guided treatment. You could use Intacs, as Natasha has extensively talked about. And also if it's very advanced, then sometimes there's no choice but to go ahead with a component corneal surgery. So just talking about cross-linking, I'll just rush through this. There are so many terms which have been used. The idea was first proposed by Theo Seeler, and when he was in the dental chair, that's when he got the idea of cross-linking. Then he subsequently used various materials to try and cross-link the cornea, and he found that UV light with riboflavin. He studied the stress and strain on the corneal strip, and he found that the UV light with riboflavin was the best. There are various theories which have been propagated. Essentially, two types of reactions which are taking place. One is where there is a direct interaction, and second is when there is a photochemical oxidative reaction. Now, we need minimum 400 microns. That is the basics which was taught to us. Of course, there are modifications to this as well now, because we don't want to damage the endothelium. The first, the Dresden protocol is essentially where you're using 0.1% riboflavin, to the cornea every 3 minutes for 30 minutes after removing the epithelium. And then the UV light 3 milliwatt is applied for 30 minutes. These are the initial results which shows improvement in BCVA and also stable, corneal curvatures. Accelerated cross-linking then was thought of, I think, essentially because probably the surgeons wanted to save time, and they thought that essentially if they gave the same amount of, the UV light to the patient, it should work. These are the results. I think most of them, they show that if the 9 milliwatt has been used for 10 minutes, it could be comparable to Dresden, but not when a much higher power is used.
The rationale being that the demarcation line is definitely more deeper and well defined when you're doing a Dresden protocol. Now this happens because of this type 2 photochemical reaction. As you can see that the oxygen is depleted much faster in an accelerated cross-linking versus the in a Dresden protocol, and that's where the limitation of the Bunsen-Roscoe law comes in. Pulse cross-linking has been propagated. I'm not really sure about the rationale of that. Now coming to epi on and epi off, I think the single sentence that the epithelium consumes 10 times more oxygen is enough to show that an epi off is what really works well compared to epi on. Now, quick word about Athens protocol. I think the subsequent speaker is talking more about this, where you are doing a topo-guided treatment. Along with that, depending on the corneal thickness, you could also correct a little bit of the refractive correction and cross-link at the same time. And Creton's protocol is where you're just removing the epithelium using laser. There's no topo-guided treatment happening here. You're just doing essentially a PTK with the cross-linking, but doing the PTK itself helps in regularizing the corneal surface. So looking at our results, this is a retrospective study. Of course, initially when I was just doing only cross-linking, there were just the Dresden protocol, and later when I started doing laser corrective along with cross-linking, these are the initial results with just cross-linking. In fact, if you see for the first 3 months initially, I don't know. In fact, I almost, used to be afraid when I used to do cross-linking about a decade back, because for the first 3 months, I used to see worsening, probably, because of the inflammation or whatever the reason. And then there used to be a dip, and the patient's keratometry used to then stabilize. And if you see the around 2 years, it goes down by around 1.5 to 2 diopters. This was at 6 years post the cross-linking. The corneal curvature is down by around 2 diopters. Whereas post-PRK, of course, as expected, the corneal curvature is going down immediately, and then it kind of plateaus over the next 2 years. This is just a quick, go through towards of the pictures. And this is at 6 months post-PRK with cross-linking. This is at 11 months, and this is at 2 years, where there's around a 3 diopters reduction. The important thing is that the vision improves, in these patients, not only the corneal curvature, but 85% patients show improvement in vision. So cross-linking, I would end with saying that I still feel that Dresden protocol is reliable. Accelerator 9 milliwatt may be comparable. There are newer algorithms which have come up for ultra-thin corneas, where just the time of, depending on what your corneal thickness is, you just use 3 milliwatt, but you may modify the amount of time that you may cross-link the cornea. I think that is too detailed to cover in this this talk. Now, moving on to looking at the next modality, which is Intacs. Natasha's covered this extensively, so I'm just going to run through that. So she's already talked about this. What is important is looking at the corneal curvature, and most importantly, seeing if your cone is centered or if it is decentered. Again, I will skip through this because she has covered this. So if it is a central cone, then this is a case where I've used double asymmetric rings, and patient is a young boy, actually. I've done bilateral, Intacs in him, and he's really doing well. And this is the post-LASIK ectasia patient, where it was a decentered cone, and I have done just a single inferior ring. And again, this was a SK ring which was used, and she's doing really well as well. Now, moving on to the second arm, where if you're not, a patient comes with very advanced keratoconus, the cornea is really thin, if it's say 300, 250 microns, there's a scarring in the cornea post hydrops. And sometimes, cases like this, and it could be bilateral, when we're can't really use any modality to visually rehabilitate this patient. We have to go ahead with DALC. I don't know if I have time to show the video. So should I show the video or move forward?
Yeah, you can share.
Okay, so this is just a quick video for showing DALC. This is advanced case. This is a child with post hydrops and bilateral. So it just we had to rehabilitate him, and this was not possible with doing any. And cornea was around I think 150, 200, really thin cornea. So here I'm doing layer by layer dissection. It's very difficult to get a big bubble in this kind of cases. And you could you do a groove and peel, or you could just peel off your cornea. And this is the patient at I think day 7, and this is later. He's doing well. Component corneal transplant. Just wanted to talk about this, where Bowman's layer has been proposed by Meles, where he is doing it in cases where they're too thin to be cross-linked, and this has been he's got extensive experience with this, where he actually takes out the Bowman's, the acellular structure from the donor cornea, and this is then inserted into the this is me doing the surgery in the wet lab. It's quite difficult. It's not as easy as Meles shows it. You need to be very, very patient to peel off that Bowman's, and then this Bowman's is then stained and then can be inserted into the stroma. This is still, I do not have too much experience, but I thought this is a good technique to share. There is, I think, Dr. Fogla, who is also the speaker, he also does stromal, intrastromal transplantation. Maybe he can talk to us about that a little bit. So this is another technique which can be used. So just to conclude, I feel that when you have a keratoconus patient, please look at the patient as a whole, have a holistic approach. You look at not only your corneal, whether the patient is progressing, look at the age, look at what his vision is, try and rehabilitate him in terms of vision. Treat all the other factors like allergy, whatever you may have in the eye, and have a complete holistic approach towards the patient. Thank you very much.
Yeah, thank you, Dr. Kavita, for that wonderful talk for algorithm for management of corneal ectasia.
Thank you, sir.
Now, I request Dr. Sujal Shah to share his slide on topography guided surface ablation. Will you please unshare, Dr. Kavita? Yes,
Kavita, can you unshare?
I have one question to Natasha. What do you do with the Intacs? Suppose if the patient develops cataract.
The Intacs rings can stay in place, sir.
Yeah. And IOL power, do you do differently or same what we do on optical biometer?
It's the same, sir, because you would predominantly measure it in the central zone, that is about 4 mm, and the optical zone that the Intacs covers is about 6 mm. So it's still beyond that, and you would be wanting to actually correct the central visual axis. So you would want to take the optical the same way that you would do your biometry for any keratoconic eye.
Okay, thank you.
I'd just like to thank Dr. Lane and Dr. Ragini for, I'm sorry I didn't mention that earlier. Also want to wish a very happy Mother's Day to everybody, and thank Karishma for the wonderful moderation that she's been doing, and the entire BOA team for the hard work. Thank you.
Thank you, Kavita. You are a part of the BOA family. You are very good. You are a rock star. And thank you so much.
Thank you, ma'am.
Dr. Kavita, can you unshare the screen?
I have unshared it. Is it still showing?
Yeah, it's still there.
Really? Okay. So, I don't know what to do.
Yeah, options. Go to options and then unshare.
Is it better? Is it stopped now, sir? So sorry about that. Yeah.
Is my screen visible now?
Yeah.
Yes, sir.
So at the outset, I'd like to thank Dr. Lane and Dr. Ragini, the BOA and the MOS for this wonderful opportunity. And I think Dr. Karishma for a very efficient coordination. Happy Mother's Day, of course, to all. So I'm going to talk quickly about topography guided ablations and the gratifying results with this. I'm going to give you a quick overview of some short cases, some of LASIK complications, and then several cases about keratoconus. So I have personally used the Schwind and the Zeiss platforms for this. I find the planning for this quite simple. I haven't used the Alcon Contoura, but the older Alcon TCAT, but I actually found that to be quite complicated. And seeing some of the earlier presentations today, I think the Schwind and the Zeiss platforms are definitely more simple in this planning. So this is just to show you how it is done on the Zeiss. You import the topography in the CRS master platform, and that gives you the different options to treat. As you can see, standard or topography guided treatments, and you can do it as a two-step treatment, or you can add 50 microns to the ablation to do it as a one-step treatment or a trans PRK or
what stray light and the other things that Alcon and the other platforms have at the moment. So just quickly going down to a few cases of LASIK. This was a decentered ablation in a young male, mid-30s, high myope. It was infranasally decentered. You can see his vision uncorrected is 6/6, but he has halos at night, as you can obviously see from his topography. So we did a topography guided LASIK to enlarge the optical zone, or actually to center the optical zone, and post-operatively his refraction remains largely unchanged, but he has complete resolution of his photopic symptoms and he can drive at night. This is another example of, this is one of my patients, so high myope, very anxious and kept moving during the treatment. We had to stop the treatment many times, ended up with an irregular ablation. We waited a few days. He had mixed astigmatism post-operatively, but was best corrected up to 6/6. He did have halos and blur, and we waited about, I think, 2 months before we did the second procedure, and we were able to regularize the optical zone completely with, of course, resolution of his vision and his photopic vision symptoms. This again was a young myope, -12. So he had LASIK, maybe a phakic IOL would have been a better option, but he had a very small optical zone. So though he could see, he had halos at night. And with the topography, these are all done on the Zeiss platform. So we were able to enlarge the zone, minimizing his symptoms. As you can see, his pupil is still large, so his halos haven't gone completely, but they have reduced. This was an interesting case. This is a hyperopic astigmatism post-PRK, post-RK, who has an apparently small optical zone which is also decentered. So with a topography guided LASIK, we were able to center the optical zone, enlarge the zone, and correct the hyperopic refractive error. She's about 6'9" now, uncorrected, and she's been following up for many years. We recently did her daughter's LASIK. This is not a keratoconus, but this is just asymmetric bow tie pattern, and look at the power of the corneal. So I think as people have been advocating the Contoura approach even for primary treatments, I think it's basically not only Contoura but any topography guided approach. So in this asymmetric astigmatism, using topography guided LASIK and getting a better regular cornea post-op, his uncorrected vision has improved to 6/5, 6.4.5 actually. Now coming to some cases of keratoconus. This boy had come to us for a LASIK evaluation. He's about 18. He clearly has keratoconus in one eye. The other eye was thicker cornea and about spherical myopia. And we did a topography guided Trans-PRK classic Dresden protocol, 9 milliwatts with 10 minutes. And you can see it's a fairly symmetric cornea post-op. His uncorrected vision has improved to 6/6 and he's stable at 4 years. This is another case of a moderate keratoconus, in the mid-30s. And the right eye, which is the earlier cone with a topography guided PRK followed by cross-linking, we were able to get uncorrected 6/6 vision. In the left eye, which is a more advanced cone, he ended up 6/12, was best corrected 6/6 at about 3 months follow-up. This is another another example of a moderate keratoconus. Again, a male in his mid-30s, pure cylinder, very thin cornea. We did a topography guided ablation with cross-linking, and for some reason he developed haze with scarring, which is persisting after even a couple of years. So there is mild haze now in the center. His vision remains 6/9, but he is happy with it and he doesn't want to wear a contact lens. This is another example of keratoconus, again a moderate keratoconus, fairly moderate degree of cylinder there. And with this combined approach, we were able to get uncorrected vision of 6/9 in both eyes. As you can see, the cornea has obviously become a lot more regular, but he ended up with a hyperopic shift. So he is best corrected 6/6, but about spherical 1.5 plus 1.5 in both eyes. This is another example where we could not regularize the topography completely, but the symmetry has improved. and it was the 5 diopter cylinder. His best corrected vision was 6/18, the uncorrected was 6/30. So following the combined procedure, his uncorrected vision is 6/12, and he is now correctable at least to 6/6 with mixed astigmatism. So I think as you will see, many of these, for those of you who have been doing this, many of these people are really very happy because their vision, quality of vision has been fairly poor pre-op. This is a difference map of a young female, 22, who underwent cross-linking and the topography carried PRK at the same time. Her uncorrected vision improved to 6/9 about a month post-op, and after that she's been lost to follow-up. As you can see, her vertical coma was very high pre-op, and so also the horizontal coma. She didn't have much of spherical aberration. Post-op, there is significant reduction in the vertical and the horizontal coma, but the spherical aberration has increased at 1 month. You can see from the point spread function that the quality of vision has improved, and she is a very happy patient. But after a month, I haven't seen her yet, so I don't know what the subsequent follow-up has been. This is just an image simulation of the same point spread function or the Zernike map. Here you can see from the E chart that the distortion has gone. It's more like a defocus, which is why with correction she comes to 6/6. So I think I'd just like to summarize quickly by saying that in LASIK, complications can occur, and ablation complications will cause visual symptoms. Topography guided LASIK will help you to improve the corneal regularity, therefore improving the quality of vision and the visual symptoms. It will of course improve the uncorrected vision. If not that, at least the best corrected vision. You can do a PRK or a LASIK approach depending on the pachymetry available, and you can also do a refractive neutral ablation as I showed you 2 cases. And the planning doesn't have to be as complicated as some of the other platforms. For keratoconus, it improves the corneal symmetry and the quality of vision. The quality of uncorrected vision, the quality of spectacle corrected vision, to the point that some of them may not need a scleral contact lens. They might be able to get away with a soft contact lens. Of course, the results are better and more predictable refractive wise in the early cones. And you can combine this with the cross-linking for stability. You can sometimes get a refractive surprise and haze in some of these patients. Thank you all for a very patient listening.
Thank you, Dr. Sujal, for a wonderful talk. And with each cases you have elaborated that, I think you aim as a 20 happy patient. Thank you, Dr. Sujal. I invite Dr. Vishal Kinya, my very old friend, to give us a talk on an Ectasia screening. And we were talking about biomechanics for since last almost about 12 years when we started on biomechanics. Welcome, Dr. Vishal.
You need to unmute yourself.
Vishal, can you unmute? Dr. Vishal, unmute yourself.
Yeah. Can you hear me now?
Yeah, sure.
Yeah. At the outset, I thank Lahane sir and Ragini ma'am and BOA and MOS for giving me this opportunity, and thank Karishma for giving me this topic of ectasia screening with newer modalities.
Thank you, sir.
Yeah. One second, the slides are not moving. 1 second.
Just click on that and then move.
1 second.
Click on the screen and then move.
I'm trying.
So there will be a watermark below. You can choose that.
Okay. Yeah. Fine. So identifying at the risk corneas to avoid ectasia is very important. Today, the standard of care is tomography, by which we identify suspicious corneas. But however, iatrogenic ectasia has been reported with normal topographies also. So we require better methods to screen at risk corneas. So all this time we were thinking about preoperative susceptible corneas. but we have never put much thought on severe biomechanical impact from surgeries, meaning because of surgical impact, meaning thick LASIK flaps, lower residual stromal bed on high PTAs. Even this can cause ectasias in normal corneas. At-risk corneas or suspicious corneas or keratoconus suspicious corneas require a multi-corneal imaging modality to identify these at-risk corneas. So a multimodal approach would be a better approach than just a single modality. In 2008, it was Randleman who gave this landmark paper of ectasia risk scoring system. And this has been one of the main scoring ectasia risk evaluating system. PTA given by Marconi Santiago has also added value for our planning before refractive surgery. So comparing ERSS versus PTA, definitely PTA was found to be better, but having a limitation of not using the third dimension means it did not account for the zone diameter and the flap diameter. Any cornea may undergo ectasia, even though it may have the same PTA. So if you create a thicker flap, then the same cornea may decompensate because of the thicker flap. So that is very, very important. What surgical impact you have or what refractive procedure impact it has on the cornea has also to be evaluated. Biomechanics always precedes topographic changes. So in order to catch the subtle subclinical keratoconus, we need a better tool. So Corvis ST, it uses a real-time corneal deformation data to analyze corneal biomechanics. Corvis ST gives us a Vincigura screening display, an integrated display of the Pentacam and the Corvis together, and the latest version gives you the comparative display of pre and post procedure. You can compare the SSI. So Vincigura display, it basically has 4 modalities which have been taken, and as any corneal deformation event, there are 36 parameters, out of which these 5 parameters were chosen for the CBI or the Corvis biomechanical index, and this were found to be more better than the other parameters, which did not alter more with the thickness and the IOP. So corneal biomechanical index has a specificity of 98.4 and sensitivity of 100%, and it helps us to distinguish from keratoconic, identify the keratoconic corneas from the normal corneas. And in the latest version, they have the CBI LVC, especially for post-LASIK or post-refractive surgery ectasias in one go without doing any comparative evaluation over time. You can at one go identify ectasia post-refractive surgery. TBI is using the artificial intelligence and the regression analysis. It gives a combined CBI and a bad display analysis, a TBI, and which has a very good sensitivity, almost of 100%, and it is much better in detecting subtle keratoconus or subclinical keratoconus. A biomechanical comparative display or the SSI, it gives you the value for the material stiffness, and this is independent of IOP as well as the corneal stiffness or thickness, and only with age the SSI increases. So SSI more than 1 is stiffer and less than 1 is softer. A normal value of 1, and this was taken for a 50-year-old cornea. Epithelial mapping is another modality which helps us in identifying suspicious corneas, and this should also be used while screening for refractive surgery. So use of artificial intelligence and pattern recognition, an example of which is TBI. An optimized TBI value of 0.29 and above is considered to be suspicious for corneal refractive surgery. use of finite element modeling to simulate in vitro biomechanics is the latest advancement. So AcuSimMex uses the finite element simulation and artificial intelligence and uses data inputs from the tomographer, Corvus, epithelial maps, demographics, and refractive details, and then power prediction tool for biomechanical outcomes after refractive surgery and ectasia risk estimation. So you can beforehand simulate what would be the post-surgery biomechanics by doing a finite element simulation. So molecular diagnostics, and this was shown in a paper by Dr. Rohit Shetty and et al., where in a normal cornea, smile was done and they found ectasia post-smile, and the lenticule was the smile lenticule which they had in their repository. They had analyzed the LOX levels and the collagen levels were less. So if a point of care test, just like an MMP9 tear film point of care test is available just now, LOX or collagen level tear film tests can be done in future to really identify corneas which are weak. So because of low LOX levels, the cross-linking in these corneas is much lesser, so they are weaker. And it is also shown that more the inflammation, less the LOX levels. So we can beforehand treat such corneas and improve their LOX levels also. The another prototype which Narayan Netralaya at the moment has is polarization sensitive OCT. This also helps us to evaluate the corneal collagen fiber strength by retardation maps. So all these modalities in future definitely together would help us better identify weaker cornea. So integrated multimodal corneal imaging and molecular diagnostics is the answer, but not a complete answer. So I would like to share one example of a 24-year-old male seeking refractive surgery with no contributing history. You can see the topography, pachymetry, and the front and the back elevation maps are all normal. The integrated display shows a softer cornea. Here, the CBI value is borderline around 0.47 and the TBI value is 0.06. This is in the right eye. The left eye, again, the values of the topography, pachymetry, elevation maps are normal. The integrated display shows again a CBI value of 0.52 and a TBI score of 0.06. See here, the SSI value shows slightly softer cornea, but the most important composite index here is the TBI. So looking at the TBI score, definitely what I would do is do a surface ablation more than a LASIK procedure in this case. So this is how it would guide me to plan my refractive surgery. So to conclude, for ectasia screening, definitely suspicious corneas need to be seen, identified. Impact from the surgery on these corneal structures also should be kept in mind. And we anticipate fast developments and the integration of simulation analysis and artificial intelligence strategies, which would help us to better identify these subclinical keratoconus and suspicious corneas. Thank you so much.
Yeah, thank you, Dr. Vaishal, for that wonderful talk. In fact, we need to identify ectasia before we go for keratorefractive surgery. And of course, presence of ectasia is definitely contraindication for performing refractive surgery. Now, we have seen cataract surgery, we have seen Intacs, then CXL. Now, the next talk will be by Dr. Vinay Agrawal on holistic approach for keratoconus.
I think Dr. Vinay could not attend because of some family emergency. I think we need to move on to the next.
Emergency.
Yeah.
Yeah. So we can move on to the next speaker, please.
Yeah.
Thank you.
I think next speaker is Dr. Reddy, who will be talking on what's new in collagen cross-linking.
I thank Dr. Kishore for giving me this opportunity, and BOA and MOS for inviting me for this talk. Coming back to my talk, what is new in collagen cross-linking today? There is nothing great new things happening except for modifying a little bit this way or that way for the past 10 years. And I have a few points which I would like to stress, why we need to modify the cross-linking from the standard Dresden protocol. Coming to the cross-linking, there are many things like chemical cross-linking. And chemical cross-linking is a process where the chemicals will be bound irreversibly and forms a very strong. There are many agents commonly used in glutaraldehyde. Glyceraldehyde is also a very good one and less toxic, and we have genipine, and we have many biological cross-linkers. But somehow in cornea, we are fairly settled with the physical cross-linking, where the covalent bonds are formed without the presence of a new chemical. With the existing bonds or chains are formed. So this is initiated by, as all of us know, that by UV light and a photo initiator. And these three gentlemen, they formed the protocols. Somehow the Walensek, Dr. Gregor Walensek disappeared from the scene. We don't know why. And Sporel has formed all the mathematics and protocols, and Dr. Seeler popularized the technique around the world. It's more than 15-20 years now. So they're coming to the Dresden standard protocol, which is commonly followed. We use a riboflavin for 30 minutes for penetration, and the UV light for 3 milliwatt for 30 minutes. And over a period of, this is the sporal radiation one given by the mathematical calculation by Dr. Sporel, how each corneal thickness can be changed for the power, the amount of irradiation used. But unfortunately, we are not, very few people are following. Now it started picking up, though he has given it more than 10 years back. The plot, which gives how much radiation should be used for each thickness of the cornea, starting from 450 microns to 280 microns. But somehow it missed in the standard distance protocol commonly used, and everybody started using only 5.4 joules as a standard one. Then there is another one, Gaussian curve, which shows that 3 to 7% are likely to fail, and there will be a mass flattening in another 0.5%, and some amount of flattening, aggressive flattening will be there in 10 to 20%, and most of the people will be unstable. My talk today is why we needed newer protocols. For example, this is a patient who had cross-linking done 2007 December, and patient had a very good vision to start with -1 cylinder 6.6, and over a period of time in 2010 he is very happy, unaided he is 6.6, and 2012 now the problem started, the vision started to drop because you can see the flattening. Then with the progress, it didn't stop. 2012 December. This is a plot from 2007 to 2016. His vision dropped from 6.6 -1 cylinder to 6.6. It improved, then ultimately dropped to 6.18. Now it is NIG and NIP. He is not able to improve beyond that. And this is another case. This is my own case where the patient had a central keratoconus, and this is after a year. Patient is very happy, 6.669 unaided vision. Then in 2000, then with the time, the cornea started becoming slightly irregular, then massive flattening and further flattening. And now the patient is having 6.18. She started with the first year MBBS. Now she is in final year MBBS. She finished and she is entered post-graduation. Now she can't read anything without contact lenses. And this is what we expected initially. We see a mild haze in first post-operative day, but we no longer want that. This haze is not indication for cross-linking. Cross-linking doesn't produce haze. This haze is more a sign of radiation toxicity. So we do see a visual changes in the cornea and cross-linked cornea, but theoretically speaking, the cross-linkings cannot be visualized with a naked eye in a slit lamp. And these are the changes which we see. Mostly, I think these are unwanted changes because of radiation effect. And we have different types of corneas, keratoconus, and a keratoconus a little bit asymmetric bow tie. This is a central cone with a more a globus, and this is a totally inferior cone, and this is a further only inferior cone. And applying the same resident protocol, 8 mm zone centered onto the pupil, and I feel it's irrational for each case. So that each one is a different one. It needs a different method of management. And this is a globus cone, and this is asymmetric, and this is inferior, and this is a superior cone. So coming back to another one, where this is the patient stays. This patient is 6'9" unaided with a central cone. I cannot understand from where he is reading. None of the cornea is in focal point. Most of either is in the red or is the blue, which is very flat, very steep. A small green zone here and there. From there, the patient is able to see 6'9". Repeatedly tested vision is quite fast with 6'9" and N6. So this brought to my point that each patient needs a customization depending upon the standard equipment, using of standard equipment with what we are having right now available. The total which we can vary, the total amount of energy we can vary, the size we can change, and the location of cross-linking we can change, and we can add, as previous speakers have nicely demonstrated, whether we can add PTK or PRK, and riboflavin 0.1% is the standard now. We can change it, but it's very highly becomes highly unpredictable. So better to stick on to that. From various manufacturers, when I spoke with them, I came to know nobody uses 0.1. Most of them use 0.11% or 0.14%. That's why when you see different manufacturers riboflavin, each one the color will be slightly different. 0.14 looks more stronger, more orange-like look, and 0.11% looks more yellowish look. So what you can customize in these cases and change the Dresden protocol. So as we go back to the first slide, the size, shape, and location. Then came the accelerated cross-linking. So in accelerated cross-linking, we can use the same energy but reduce up to 2 minutes or 1.5 minutes. But whereas clinical studies have shown that 2 minutes and 1.5 minutes is not good time of exposure. We need at least 8 to 9 minutes. So most people settle down with 9 milliwatts, 10 minutes, which is not standard Dresden protocol, which is a modified protocol, not even accelerated, it's a modified accelerated protocol, where we are giving a constant exposure, again, 5.4 joules, and we are able to get a reasonably good amount of what we thought a corneal mild haze or the signs of cross-linking. So 9 milliwatt with 10 minutes. So it's all depends upon beliefs and interpretation of clinical results and clinical observations, assumptions, and hypotheses. And at the end, what you like, the surgeon like. There are always two sides for a coin. And coming to the keratoconus, I believe is a local weakness, which over a period of time progress becomes global. There is other school which strongly believes keratoconus is a global disease and it starts as a local elevation. So you have to treat the entire cornea. You cannot treat at this specific point. And the second point, a very important point, I think, is the steepest area, I believe, is the weakest area. It is not the thinnest point of the cornea. Whereas other school believes the thinnest location is the weakest point in the cornea, and the elevation is just a consequence of biomechanical effect. So I believe that strengthening the weak and steepest area strengthens and prevents further progression, correcting the weakness at that point. Whereas the other school believes, other surgeons believe, keratoconus is a progressive global disease. So wide area has to be treated as a standard protocol, as a distant 8 mm area should be treated irrespective of what is the size of the cone to arrest the further disease. I believe that visual acuity is paramount importance in treatment and the critical parameter of success of treatment, whereas many people argue that is the shape of the cornea and strengthening the cornea is more important. Visual acuity, even if a few lines drop, doesn't matter. So what we can customize? I customize total amount of energy from 3.5 joules to 5.4 joules. And depending upon thickness of the cornea, thinner corneas, I reduce the energy. Thicker corneas, I use the more energy. Then the another important thing is I take into consideration uncorrected visual acuity. Many of cases we are seeing early nowadays, not the advanced cones we are seeing, but more and more early cases where the contralateral light most of the times will be very early case. We don't want it to become worse. So uncorrected visual acuity 6.9, 6.6 is not unusual. So these cases I use 30% less energy. People who accept high spectacle power, I use more energy. Who expect very small spectacle power, let's say -1 cylinder, 1.5 cylinder, I use less energy. And going by thickness as the same, like spiral graph, I'm using this standard, what he has given more than a decade back. And another thing I customize is the location, size, and shape. Where the cone is there, depending upon that, I change. If the cone is very much inferior, not in one pupil area, I just cover off the superior half of the cornea, and I recommend only irradiating the lower half. So one of my good friend during a meeting many years back, 5 to 6 years back, when he proposed, he said, no, you cannot do all this mess up. You cannot tinker with the eye. You have to do the standard resident protocol. That's widely accepted. You have to do it. So look at this patient, 2014. It is his patient, not my patient. And 27 years female, and best corrected vision 6.6 right eye with -0.5 cylinder, 1.75 cylinder, 0.5 sphere, 6.6 vision, and right eye. And they recommended, this is his discharge summary, and she underwent cross-linking. I happened to see her a few months back because of loss of corrected and uncorrected vision. Her vision is now, you see, look at the right eye, +1 plus 1.5, 100 is 6.9. So it's not like it's everybody gets it. Then another modality we introduced for this patient is PTK. This is not a PTK onto the pupil. It is a cone apex centered PTK. This again changes. It's not standard for every patient. We change from 55 microns to 75 microns depending upon the cone availability of the tissue at that weakest point. And zone also we change from 5 to 6.5 millimeters depending upon the size of the cone in topography. The concept is epithelium is thinnest over the cone. That's what we found. Usually it's around 38, 35 to 39 microns. And the thinnest cornea is not the steepest cornea. So the thinnest cornea will be somewhere else, and the steepest cornea will be somewhere else. That's what we found in most of our topography in Keratoconus. And PTK removes tissue in the center of the PTK zone, then in the periphery. And you can limit cross-linking only to the cone area instead of wide like in resident protocol. So for example, this patient with the inferior cone, we do a PTK onto that inferior decentered. So for example, in the left, this one shows the standard PTK, whereas a decentered PTK, what we do is decentered to the pupil like this. These coordinates will be entered into the excimer laser while doing a PTK. And this is a video showing this is the pupil. You can see the PTK going down in the inferior zone, just touching the pupillary border a little bit. And these are the results. It gives very good results. This is a pre-op, this is a post-op, this is a pre-op, post-op. So the key points I want to emphasize is that the same energy, though the Bunsen-Roscoe law says it is produces the same effect, actually it's not in the cornea. Cornea is not obeying that rule. It doesn't know the rule, maybe it's not obeying. So if you use for 2 minutes, the effect you get is much less when they use it the same energy for 10 or 30 minutes. So the best corrected visual acuity decides the treatment plan, and you have to modify your protocols. And corneal topography also decides the location and size of the cone, what is the size to be done, and where it should be done. And we have to keep in view visual acuity, which is the most important parameter. It's not being the shape alone. Thank you very much.
Thank you, Dr. Reddy, for a very wonderful talk. And then, I mean, everyone is just working hard to get some optimum method or a methodology where we can get in the best possible vision as well as the stability of the cornea. Thank you very much for a nice talk. I invite now Dr. Sonu Goyal for a talk on IL power calculations in keratoconus corneas. So welcome, Dr. Sonu Goyal.
I think we have to go.
Yeah, because I don't see him in this. So
we have to go to next speaker, I suppose.
Yeah, so then I invite Dr. Rajesh Vogla, who doesn't need any introduction, to give us a talk on laser-based treatment and cross-linking.
Thank you. Are my slides visible?
Yes, sir.
Sure.
Okay, at the outset, I would like to thank BOS and MOA for inviting me to be part of this interesting session. The topic given is laser procedure for keratoconus. This topic, part of it has already been covered wonderfully by Sujal. And I will try and just go over the basics of how we go ahead and do this procedure in a small subset of patients with keratoconus. We've already heard the previous speakers explain what keratoconus is and how it affects the eye. But if you look at the vision and the high order aberration that it induces, you will see that predominantly it's the induction of coma because of the kind of curvature of the cornea. The part which is ectatic is much more steeper than the uninvolved part. So you have the wavefront map, which is not planar anymore, and you have the induction of coma. So in the management, you can arrest the progression of keratoconus by doing cross-linking, and to improve the eyesight, predominantly we use contact lenses. The other options being doing a customized laser ablation, intracorneal ring segments, toric IOLs, phakic IOLs, and corneal surgery. And if you combine the cross-linking with any of these procedures, such as topo-guided PRK or intracorneal ring segments or phaking IOL, it's often referred to as cross-linking plus. Coming to the topo-guided PRK, basically, this is a customized laser procedure to treat corneal irregularities, regularize the front surface to achieve a desired outcome. Sujal has given great examples, and early keratoconus also falls into this category, where we can use the topo-guided laser ablation. We basically measure the aberration profile on the surface of the cornea. It's not centered on the pupillary center, but on the corneal vertex. And you capture the unique shape of each cornea, and which is then used to dictate the placement of extra pulses to reduce the aberrations of the cornea. It's not a very complex treatment planning. You need a device to capture the corneal aberrations, which can either, for the wavelight system, we can either use the topolyzer or the oculizer. And then this data is then transferred to a software planning, and then it's transferred to the laser machine to be carried out. Now let's look at some publications. This was a paper published by Kanellopoulos and Peribinder back in 2007, where they looked at the option of doing a sequential topo-guided PRK. So they had a 26-year-old male patient that undergone a Dresden protocol of cross-linking, and 12 months later, they planned a topo-guided PRK. And from a pre-op refractive error of -3.5, -4 cylinder, they treated about 70% of the refractive error, and 18 months after the topo-guided PRK, the patient on it was 20/20. The best spectacle corrected was 20/15, and the residual error was only 0.5 cylinder. So this formed the basis of the role of topo-guided PRK, but this was a sequential treatment. Subsequently, in 2009, Kanellopoulos again published a paper using a large series where they did a comparison between a sequential versus same-day simultaneous cross-linking and topo-guided PRK. And the treatment parameter was basically to normalize the cornea by reducing astigmatism. So this was not a refractive correction. They reduced the optical zone to 5.5 millimeter, and the transition zone was only 1.5. So the overall ablation zone was only 7 millimeter. They treated 70% of the cylinder, along with any possible sphere depending on the preoperative corneal thickness. The ablation depth was limited to 50 microns, and they also used mitomycin C 0.02% for 20 seconds. As the Bowman's layer was absent after the topography guided laser treatment, the riboflavin drops was applied only for 10 minutes, gave adequate penetration, and they did a conventional cross-linking protocol for 30 minutes. And they found that the simultaneous topo-guided PRK and cross-linking, it kind of gave similar results, and in certain parameters they were superior to the sequential, especially in the time frame where the sequential treatment required the patient to wait for a long duration of time. In 2016, George Quinones also gave a comparative study looking at the similar simultaneous treatment versus cross-linking alone. And they also, in 30 eyes, they had done a combined treatment versus 30 eyes, they did cross-linking alone. And they found that the group which had a combined treatment of topo-guided PRK with cross-linking had greater flattening, had, the depth of cross-linking treatment was at a deeper plane, and the visual acuity was slightly better. So they felt that the combined treatment significantly improved vision compared to patients who had cross-linking alone. Now, this is what J.K. Reddy was referring to, is if you look at the epithelial map, you find that in keratoconus patients, at the thinnest point at the apex, usually the epithelium is also, at the steepest point, the epithelium is also thinner, and surrounding that, there is a compensatory epithelial hypertrophy. So you can use the epithelium as a mask. And if you do a laser ablation like a PTK to ablate the epithelium for 50 microns, what happens is in the center part where the epithelium is thinner, you tend to ablate 10 to 20 microns of the corneal stroma, and that kind of allows some amount of central flattening by the time the peripheral epithelium is ablated. So using this pattern also, this is called the Cretan protocol. The previous one by Kanellopoulos was referred to as the Athens protocol. So the Cretan's protocol plus was when you do a PTK in the central 7 to 8 millimeter zone, followed by topo-guided PRK. And in their protocol, they used the correction was basically up to 33% of the myopic error, 66% of the astigmatism using a smaller ablation zone of 5.5, limiting again the ablation depth only to 50 microns. And they found that this approach, the patient's visual acuity improvement was significantly more compared to the standard cross-linking, and the findings remain stable over a 12-month follow-up. And in the Athens protocol also, there is a new protocol called the Athens Protocol Plus, where they do the topo-guided PRK, and instead of doing a conventional cross-linking, they do a customized cross-linking. So how do you go about it? The kind of cases which are eligible to this are mainly early to mild keratoconus or early ectasia. You have to have a minimum corneal thickness at the thinnest point, about 475 microns. Some people use this as 450 microns. You need to be able to have good repeatable corneal maps to have a good planning. If you're not able to get repeatable maps and you cannot capture the data, then your topo-guided treatment may not be ideal. And also the patient needs to have realistic expectations, because this is not a refractive correction. This is not like LASIK or where PRK, where you're trying to give the patient unaided 6/6 vision. This is more to reduce the higher order aberrations. So if you look at some of the clinical cases, this is a 22-year-old female who had a decrease in vision, and with unaided vision of 624, and with refraction, she could improve only up to 6.9. Her pachymetry was about 488 micron at the thinnest point. And this is a topography map. And if we decided to do a topo-guided PRK with cross-linking, this is the ablation pattern. If you see, you have the treatment which is happening at the thinnest point. We are trying to flatten it, the steepest point, and the periphery, you have an ablation which is trying to steepen the flat part of the cornea. So basically, you're trying to normalize the cornea. So this is what the post-operative looks like, and the difference map, which shows you the flattening and the steepening of the cornea. So post-treatment, unaided vision had improved to 612, residual refractive error of 0.75, cylinder improving to 6.6, and that's the topography map. And if you look at the high order aberration map, you can see preoperatively, high order aberration was about 1.2 microns, whereas post-operatively, it had dropped down to about 0.39. And if you specifically look at the coma, you will find that the coma has significantly reduced post-laser ablation. This is another patient with early keratoconus. The pre-op PACI was 476. This is post-topo-guided PRK with the cross-linking procedure. The protocol for cross-linking is 9 milliwatts for 10 minutes, what we use. We don't use the Dresden protocol because we have found that the haze that you develop is very close to the decimates in these eyes. So if you use a slightly accelerated protocols, you can have the haze appearing at about 2/3 depth. So this patient also had a best corrected vision of 612 post-treatment. And again, if you look at the difference map, you can see the amount of flattening over the steep area and the steepening over the flat area, which is normalizing the cornea. This is again the high order aberrations for the same patient. You can see the pre-op significant amount of coma, and that's the post-operative. You can see there is a good reduction in the coma, which can explain why the patient's symptoms have improved. This is again another patient similar to what J.K. Reddy had presented. Patient had cross-linking 10 years back, and now she had scarring in the cornea with abnormal flattening, irregular astigmatism, plus 3.5 with minus 4.25. So we went ahead, did a topo-guided PRK. You can see the central ablation was only 6 microns. So it's more of peripheral ablation to steepen the central flat cornea. And she ended up with 0.75 cylinder, improving up to 20/30. So that's a difference map showing you the central cornea had undergone significant amount of steepening after the topo-guided PRK. So basically the clinical pearls are that these are not too suitable for all eyes. It's basically for early to mild keratoconus. I like to have a pre-op pachymetry of 475 microns or greater. Ablation depth, I try to keep it less than or equal to 50 microns. Combine it with cross-linking. You need to continue with the steroids for a slightly longer period of time. You can use mitomycin, but the mitomycin will prevent only the superficial haze, subepithelial haze that comes. The problem in these eyes is sometimes you get a dense posterior haze deep in the cornea, which does not appear immediately, but occurs several months after the procedure. So that's why you need to continue with the topical steroids for a slightly longer duration of time. And again, this is not a procedure that you perform very frequently. So you have to do one eye at a time. Don't be in a hurry to treat both eyes, because sometimes despite undercorrecting the refractive error, you can have an abnormal response to the cross-linking where the patient can have greater than desired flattening and patient going into slightly hyperopic error. So if you see that response in one eye, you can either avoid doing the treatment in the fellow eye or modify your treatment plan. Thank you. Thank you for a patient here.
Excellent talk by Dr. Rajesh Fogla. As usual, very informative. And now I call on the last speaker of the session, Dr. Parmeshwar, to give his talk on beyond C3R for keratoconus.
Thank you, Dr. Fogla, sir. Thank you.
Is Dr. Parmeshwar?
Yeah, he's here.
Yeah.
Good evening, everyone. First of all, I'd like to thank Dr. Lahane sir, Dr. Ragini madam, BOA and MOS for giving me this opportunity to speak with you all. So after listening to all the great talks and all technical aspects of the keratoconus treatment, I would like to discuss what kind of a treatment, holistic treatment, a keratoconus patient needs to receive. So what we are most bothered about a keratoconus patient is to diagnose the keratoconus, to ascertain whether it is progressive or stationary, whether we should treat it or not. If it has to be treated, whether it is a conservative treatment or a surgical treatment, collagen cross-linking should be done or not, and if surgical, which kind of a surgery has to be done. We are all bothered about this kind of surgeries, and there are a host of treatment we have learned from all our respected speakers about how to go about the treatment of the keratoconus patients. But what is least thought about or bothered about a keratoconus patient is what should we do after cross-linking or a surgical treatment has been done. Does the treatment of the progressive keratoconus finish after a surgical treatment of the collagen crosslink has been done? And do we need to have a more holistic approach rather than focus only on surgical aspect of the treatment? But then what should be considered for a keratoconus patient is what is the long-term stability of the keratoconus, what kind of a psychological assistance we need to give to the patient, what nutritional and vocational assistance has to be given, what kind of a lifestyle modification has to be done to the patient, the genetic assessment and the screening of the family members, the marriage perspectives and the screening of related or associated body disorders has to be done. First point that I would consider is stability of the keratoconus. I'll not go into the details of the detailed technical analysis of how we ascertain the stability of the keratoconus, but what needs to be done is patient has to be counseled about the long-term follow-up that he has to give to us. Frequent topographic analysis has to be done because it has been found that although if a keratoconus patient has been stable for a certain amount of time, in a longer duration, the keratoconus progression can recur. In a recent publication in American Academy of Ophthalmology, it has been found that even after 20 years, a patient showed progression of keratoconus. So a proper counseling of the patient has to be done, and patient should never assume that once the surgical therapy has been done, he should not assume that everything has been done and he need not to follow with us. Psychological assistance is also one of the very important aspects of the treatment, holistic treatment of the keratoconus patients, as it has been found that nearly 37% of the patients have some kind of a psychological disorder. About 14% of the patients have moderate to severe depression. About 21% patients have moderate to severe anxiety disorders. And severer the keratoconus, higher is the chance of having psychological disorders. These psychological disorders causes reduced productivity and reduced partake of the patient in the social activities, and thus the patient become more frustrated. They don't participate in our treatment, and then their social health goes downhill. So what we can do is like we can have some kind of a depression or anxiety questionnaire in our clinic, and then do a small assessment by asking patient to fill up those questionnaires. And if we find some kind of a psychological problem that patient is having, we should take care of our psychiatric friends and help patients to have a good psyche. Another point very important is that we should give nutritional assistance to the patient. It has been found that keratoconus patients have a lot of nutritional deficiencies. Very important is vitamin D deficiency. Almost 54% of the patients of keratoconus have been found to have lesser vitamin D levels in their body. Also, a patient who is having lesser vitamin D level is found to have 2.9 times increased chances of developing keratoconus as compared to the normal patients. Also, the levels of copper, zinc, and selenium have been found to be lesser in the keratoconus patients, and also vitamin A deficiency has also been found out. So even after we do cross-linking or any surgical therapy for the patient, it is must and necessary that we should regularly monitor deficiencies of these vitamins and minerals, and then think of supplementing the patient. Also, one of the most important factors is vocational assistance. Because keratoconus, the quality of vision of a keratoconus patient is poor as compared to normal people. They have reduced efficiency at work, and also they could be unsuitable for some of the occupations. So a good career counseling has to be done for the keratoconus patient. If a keratoconus patient has already not chosen a career, then a proper career assistance regarding which career he has to choose has to be given. Already, if he has chosen a career, then if he can make a switch of his career, if he is not suitable with his career, then it has to be given assistance. If a patient is not able to switch to a safer career, then the employers of the patient should be taken in confidence, and they have to be sensitized about limitations of the patient, and appropriate changes in the workplace has to be done. What this will do is that this will reduce patients' financial, social, and psychological burden and make them more happier, and their life will be more happy. Also, we have been lately there is a surge in increase in the screen time. So what we need to do is like the screens have to be adjusted, such as the larger and the flat computer screens should be used by the keratoconus patients. The glare has to be reduced. There are keratoconus friendly fonts like Arial font, and the font size should be larger. Patient of keratoconus should use enlargement softwares in their computers, screen readers, or speech softwares. Minimum time has to be spent on the screens. Regular breaks are advised. The light levels should be, ambient light levels should be adjusted to reduce the eye strain, and patient should be asked to avoid dusty environments. Also, because their vision quality is poor, the driving at night and at late hours should be advised to be avoided. In a recent paper published at American Academy of American Journal of Ophthalmology, the quality of life of patients in keratoconus was studied, and they found out that a moderate keratoconus patient has a poor vision quality as poor as age-related macular degeneration of category 4. So we need to counsel patient. We need to give all the vocational and social assistance to the patient so that their life becomes more easier. Another aspect of the treatment, holistic treatment, is the genetic assessment and the screening of the family members, as it has been found out that up to 25% of the patients' family members may be affected with the keratoconus, and there is a 15 to 67 times higher risk of a family member developing keratoconus as compared to those patients who don't have a keratoconus. Most of the familial keratoconuses are autosomal dominant. Although we don't, in India, we don't have any specific non-invasive test which can predict development of keratoconus. Although topography will diagnose a keratoconus patient, but before topographic changes occur, there are some tests like Avagen which are available in the West, which take a buccal swab, and it tests around 1,000 different mutations of 75 different genes which are responsible for keratoconus. These kind of tests can be used in siblings of the keratoconus patients to determine, to ascertain or to check whether these siblings are going to develop keratoconus or not. Unfortunately, these tests are not available in India. We hope they are soon. They will be soon available in India. Also, one of the important factors is the marriage perspective. Consanguineous marriage is a bigger risk factor for keratoconus. So, a patient marriage counseling has to be done. The genetic testing of the spouse, if it is possible.
Sir, will you please sum up? I think Dr. Parameshwar has lost his internet connection.
Hello. Hello.
Will you please sum up?
Yes. Final. This is final slide. This is just a final slide. Also, screening of the body disorders such as VKC, atopic dermatitis, Hashimoto's thyroiditis, immune-related mediated disease, and asthma and all other disease has to be done to the patient. So my take-home message to everyone is that management of the keratoconus patient does not stop after doing surgical or medical management and establishing the stability of the keratoconus. A more holistic approach has to be taken for these patients. Thanks for your kind attention. I'm open for any questions or comments.
Thank you very much for a wonderful talk. And I thank all the speakers for their wonderful talk. I think we started with the basics of keratoconus from a diagnosis, and then we came to a treatment part of it. And at the end, Dr. Parameshwar also talked about a holistic approach. I thank everyone for being a part of this, and a special thanks to Dr. Agni and Professor Hane and Karishma to give us this opportunity to have a session on keratoconus. Thank you very much.
Thank you, Pooja. Thank you all the Rajesh. Thank you, Kalekar. Thank you, everybody. I think it was a wonderful session. I was listening since beginning. And Rajesh, thank you. Rajesh, Pogla, thank you very much for your
thank you, sir. Thank you for the opportunity for including me.
The Rasmin Gandhi, Reddy, then the Mustafa started, then the Vaisal, everybody. Thank Kavita, the Natasha, everybody. Swapnesh, thank you very much.
Thank you very much, sir.
Thank you, ma'am.
And all the best, sir.
Thank you
All
much,
the best
sir.
for this coming elections. Thank you.
Thank you so much.
Thank you, madam.
Thank you, Kishore.
Thanks, ma'am. Thanks.
Yeah, now moderator can start, just announce the second session now, last session.
Sure. So welcome everybody.
This is also there. Yes, sir.
Welcome everybody for the last session of the day, and it's I think the most closest session to my heart. FRCS, ICO, FRCO. What are my options? We have with us faculty esteemed faculty, Dr. Ashwin Gandhi sir, Dr. Devendra, Dr. Akshay Nair, and Dr. Rohan Sawant all the way from London. So without much ado, I pass on the baton to Akshay to begin the proceedings.
Thank you so much, Swapnish. So we've structured the course in such a way that the 4 topics of ICO, FRCO, a clinical examination of FRCO and FRCOph gives a very holistic, comprehensive overview. I will now present my screen. It is visible?
Yes, Akshay, it is visible. Akshay is an alumnus of Shankar Netralaya and LBP and is an oculoplastic surgeon at Aditya Jyot and Agarwal's group of hospitals in Mumbai, a very close friend. Thank you, Akshay. Please begin.
Thanks. So in the ICO, the International Council of Ophthalmology itself conducts the examinations and offers fellowships. So why think of the ICO examinations? The first thing is that it is a very structured and objective assessment that gives you an understanding of your own knowledge level in ophthalmology. It is as any other examination, it gives you your standing amongst your peers and also gives you a recognition amongst your peers. It could possibly have better job opportunities since it could convert into a fellowship as well. And at the end of the day, some of us like to take exams. Indians in general are often give a lot of exams right from class 1 right up till ICO and FRCS. And we love 4-letter initials after our name or 3-letter initials after a name. So this could be just one more degree that we add. And more importantly, during your residency, if you take your ICO examinations, when you're paying such a huge amount of money, it is a good way to make sure that you actually end up studying. An important update is that the Royal College of Surgeons of Edinburgh have a reciprocity with the ICO since 2018. It says that the partnership between the Royal College of Surgeons and the ICO will ensure that the route from ICO to MRCS Edinburgh is seamless, and then it allows the candidate to sit for Part C of the FRCS Edinburgh, which is the highest standard of examinations for them as per what they've said. So how does this work? There is a very clear guideline that they have put up on their website where you can see that what was in 2016 FRCS in Edinburgh Part A, that along with your ICO clinical examinations and the advanced is something historical. Currently, what we are seeing is if you've taken your ICO basics and optics refraction, that is equivalent to your FRCS Part A. In addition to that, if you've taken your ICO and advanced, that is equivalent to your FRCS Part B. Therefore, you automatically are eligible for a membership of what is called the MRCS ED. In addition to that, for your FRCS, if you clear that and then do your FRCS Part C, plus 4 years of clinical practice, and then you give your Viva examination, you are then eligible for the FRCS fellowship. So it has simplified the pathways. Everything is on the ICO as well as the FRCS websites. So you can easily have a look at it online and clarify things. Coming to FICO, the fellowships. There are 3 different structures of fellowships. There is a 3-month fellowship, the 6-month fellowship, and the 1-year fellowship. So the ICO examination, your eligibility for getting through a fellowship increases if you have taken your examinations. The website says it is recommended that applicants sit for the ICO examinations. It is not an absolute compulsion because there are a few people whom we know, anecdotally, who've actually gotten ICO fellowships without taking the exams. But typically, since the denominator of people who are taking the exams is so high, they make it a point that most people who end up with fellowships are those who've taken these examinations and passed them. Before you go in to the FICO or the ICO examination route, you need to understand it is multi-stage. There is, like I said, the Part A, Part B, or the basics, the clinical sciences, and the advanced, and now subspecialty. It is an expensive route. So you need to know the pros and cons of both of this. Your advantages are that you get the post-nominal FICO to add it after your name. It helps you to navigate the FRCS pathways, like I explained, because of the reciprocity. And it could possibly translate to better job opportunities where people they're becoming more cognizant of what FICO is and what the examination is. So they could obviously, understand that having cleared your ICO examinations, you are of a certain caliber. But the ICO examinations clearance is not a licensed examination. It does not guarantee that you're allowed to practice in any other country, unlike the FRCOph or the FRCS. And ICO fellowships, again, they are, while they give you the ICO fellowship, the utility of these fellowships, unless you really make sure that you make the best out of it, may not be that useful. And like I said, they are expensive. So that is an overview of the ICO exams. Finally, which exams do come in the ICO tree? So you have the visual sciences, which is a part A. Typically, this is conducted twice a year in March and October. It is an entry-level examination that residents typically take during their residency. 120 questions, MCQ-based questions with 4 choices, strictly based on the anatomy, physiology, the embryology, neuroanatomy, and these things. Also, there is a section on neuroanatomy, which is typically difficult for us who've forgotten anatomy of our first year. So it takes a little bit of hardcore studying. Then you have the optics and refraction, which is part B. Also conducted in March and October. Typically, part A and part B are taken together. 60 questions, again, MCQ based for 1.5 hours. Remember, if part A and B are taken together, the candidate must obtain separate passing marks for each of these two. Only then they can apply for part C. If you fail part B, then you must reappear for part B on your next attempt and clear it, and only then can you go ahead and apply for part C. Your part C is your clinical sciences. Typically, the ideal time to take this would be just after residency, because you are fresh with your knowledge from your Kansky or Parsons or whichever books you've read. 200 MCQ, single best answer. And as you can see from the list of subjects that are covered in this examination, it's more or less what you studied in your residency. Again, conducted twice a year in March and in October. The advanced examination is what is taken after residency or in fellowship, or even beyond that. It is a slightly tougher examination. It is competence and technical ability based. It does not verify training, but tests your practical competence. There are 10 extended matching type of questions and 75 context setting description, which means it could be a written or a visual or a graphical, like an OCT or a fundus diagram. And associated with that, they would give you 4 statements, and you have to choose the single best response. Now, of course, they have started a subspecialty examination, typically held in October, but for the year 2021, it may not be conducted. As of now, they have not yet announced the dates for the subspecialty examination for 2021. Essentially, you should have completed at least 1 year of clinical experience in the specialty that you're applying for. It is a 2-hour based exam with 80 context setting description. Again, with a diagram or a clinical history, you will get 4 responses, of which you need to choose the single best answer. All subspecialties will include a module on cataract. So regardless of what you do, cataract is a part of it. So those are the exams that you need to clear. And once you finish, before you get into that, you need to know what it is worth. So I've put it up in francs because this is the only thing that is not changing. The exchange rate keeps changing. At last count, it was 1,73,000 rupees. This is for your entire course. So it is prohibitive. It will only increase as time goes on, because the exchange rate is usually not in the favor of India. So that is what it takes to appear for the examinations. What do you have to read for the ICO examinations? And I know, I'll be going over it very superficially, because Devendra will be talking about this in a little more detail when it comes to the resources for the FRCS examinations. For the basic sciences and optics and refraction, the essential readings are your clinical optics by Elkington and theory of optics and refraction by Professor Khurana. They are lucid, simple, easy to understand books. For your MCQs in basic sciences, ophthalmology by John Ferris is a standard book. The ICO of late has become it's been a little lazy, because oftentimes we find questions from John Ferris taken verbatim, with even the order of the options being the same. So this is a highly recommended book. as is the Forrester, the eye basics in practice. For your clinical sciences, essential reading that as per what we've seen is the Massachusetts Eye and Ear Infirmary Review and Kansky. Kansky is something that I would expect almost every resident to go through cover to cover a few times during their residency. That was the cover when I was a resident. This is the cover of the book right now. And now coming to ICO fellowship. So what are the different types of ICO fellowships? There are, like I said, there are 3 month, 6 month, and 9 month fellowships. There are subspecialty fellowships focusing only on retina, uveitis, glaucoma, retinoblastoma, and ocular genetics. But overall, these are limited in the sense the fellowships are limited in number and offered only to select people who qualify for the criteria. Largely, the ICO 3 month fellowships are the ones that are chosen across multiple specialties. So these 3 month fellowships, there are almost 60 to 90 such fellowships awarded twice a year, which means there are almost approximately 120 to 180 fellowships awarded every year. With the fellowship comes $6,000 US of support grant from the ICO. You need to have completed your residency and to be a qualified ophthalmologist even before applying. So you cannot apply for this during your residency. You have to be typically below 40 years of age. They are very particular about this. And you must give them enough proof that you would be returning to your home country after your fellowship and resume your original position such that you're able to put into use what you've learned. How do you apply for this fellowship? It is a very, very straightforward process. The ICO fellowship, ICO examinations website is icoft.org. It has a 6-step process. First is you choose your fellowship, whether it's a 3 month, 6 month, 1 year, choose your subspecialty and submit your documents that prove that you are a trained ophthalmologist and qualified ophthalmologist in your country. It takes a day for them to check whether you fit their eligibility criteria and let you know. Following that, they allow you to choose the center of your choice. Depending on which country you want, you can apply. 2 things to know. You can apply to only 1 center at a time. And if they do not accept you, then you are allowed to choose any other center. However, once you choose in your center and they accept it, they will let you know. But if at any one point in time you fail the process of getting through a fellowship, you cannot apply again. Each college, once rejected, the candidate cannot apply again. So you need to make sure that your file is well filled. What about you want to apply to a center that is not in the list of directory, in the directory of centers? So this is something that, this is a screenshot of an email that I had written to them when I applied 7 years ago for my ICO fellowship. And they said that, yes, there are, because at that time, there were not too many oculoplasty centers for ICO fellowship. And they said, if you are interested, you'll get in touch with them, let them know that you want to join. And if they're okay with you joining as a 3-month ICO fellowship, give us that letter of confirmation and we'll be able to run this eligibility check and we'll be happy to support that. So yes, they do, entertain such requests. So things that you need to consider before applying for fellowship. This is something more from my experience and applies. You need to take it on a customized basis, whether it is applicable for you or not.
Akshay, 2 minutes.
Yeah. When do you need to apply, before fellowship or after fellowship? Typically, it is better to apply after you've completed your fellowship in India, such that you're able to pick and choose what you want to learn and what you want to focus on when you're there. Is it worth it? It is absolutely worth it because it changes, it allows you to see how practice can be different and how much more you can learn. You should not treat it like any other vacation. Your contacts improve, your network improves, and it definitely adds credibility to you. And things that you should also be considered is when should you apply? Towards the end of your fellowship in India here, or a year or two after your clinical practice here is a good time to apply. Things you need to know before applying. What are the skills and knowledge that you particularly want to acquire through this fellowship? What are you going to do with it? For example, for me, the focus was cosmetic aesthetic surgery and endoscopic surgery, skills that during my fellowship here were not that great. And finally, what are the practical implications of your fellowship when you come back here? Will you be able to, put that into practice here? If you get your answers to this, then you will be able to help well. My last couple of slides, my experience. I went as a fellow in 2015. I was able to share with them. At the same time, I had fellows from Bolivia and Spain, and my mentor there in New York, Anya Infirmary, also allowed me to visit Memorial Sloan Kettering, where I was with a week with Dr. Abramson, who's the pioneer of intra-arterial chemotherapy for retinoblastoma. Not just, we also managed to publish a lot of papers during my time there. So you should make it productive. And it is only through my ICO fellowship that I was inducted as a member of the American Society of Oculoplastic and Reconstructive Surgery. So it definitely helps. To summary, you plan well when you want to apply for the examinations and which exam when, and also your fellowship when you want to plan it. Take into consideration opinions, and all stakeholders should be involved, your family and your employers, to know how it is. Choose wisely, because these things, your ICO examination and ICO fellowship, can definitely help you build connections, build network, build skills, and eventually build your career. Chart a timeline. Don't just go blind into it. At the end of the day, having cleared your ICO examinations and an ICO fellowship is undoubtedly an asset in your practice and your reputation. So I would strongly recommend it for all trainees to think about it.
Thank you, Akshay. That was a great presentation, and we could see your illustrious career throughout those slides, and we could see that you are getting younger and younger by the years. Rashmin sir, any comments? I request Devendra to load his slide.
I think Akshay has covered it beautifully well. Just one question, Akshay, as to how did you choose your mentor? How did you choose your center?
Yeah, so I actually looked at where it was, the location, and also it's a good idea to see the list of your members in the directory. Do a PubMed search and see what are their areas of interest. That's what I did. And based on that, I could choose the area that I was looking for: endoscopic, lacrimal, and aesthetic surgery, which, as we know, is more common on the East Coast and the West Coast of USA and less in Central America, so in Central United States. So also doing a little bit of reading up and digging up on the mentors will help you realize what they are focused on, and obviously that's what you will end up seeing at their clinics.
Perfect. Thanks. Thanks.
So our next talk is by Dr. Devendra on FRCS examinations, and the first slide gives away his introduction. He is a very well-known vitreoretinal surgeon at the prestigious Lakshmi Eye Institute in Panjim. Devendra, please continue.
Thanks, Swapnesh, and to the organizers for this opportunity. This is a topic that all the speakers are very interested in, and I hope it is of use to budding ophthalmologists around the country. So the Royal Colleges in the UK, I'll dive into it, are three. The Royal College of Surgeons of Edinburgh, which was established more than 500 years ago. The Royal College of Physicians and Surgeons of Glasgow, and the Royal College of Ophthalmologists in 1988. For the purpose of my talk, I'll be focusing on the first two, and Dr. Rohan Sawant, who would be joining us from the UK, will talk a little bit about the Royal College of Ophthalmologists based in London. And so practically, it's the FRCS Glasgow that is the most commonly appeared for examination. And as I said, it is a very old institution with a hoary past. And these are a few scenes of Glasgow from my visit over there when we went for the convocation after successfully clearing the examination. This is with my good friend, Dr. Asif Virani from Thane, who was my study partner. And that's a very important point I would like to make at this stage itself, that having a study partner really helps. A few glimpses of the very glamorous convocation ceremony where everyone is dressed in very beautiful robes depending on their specialty. So what are the advantages of giving the FRCS examination? Practically, there is no need to give the PLAB if you have cleared the FRCS. That means you directly apply for registration with the GMC. Comparatively, if you are an FRCS, then you have better remuneration scales or packages in the Middle East. It is accepted as a valid degree in ophthalmology in Singapore and Hong Kong, but times are changing, so I would suggest looking at the rules very closely before applying. As Dr. Akshay talked about, there's a cross-exemption with ICO. And I think a lot of us, as Dr. Akshay also mentioned, like to give examinations. That was the only reason I gave the examination. As you can see, I'm very well entrenched in practice in India, and I have no intention of going either to the Middle East or the Far East. But it was just something that gave me joy of writing examinations and adding initials to your name. I don't think anybody needs to go to the extent of this great scholar of medicine, but I think it is an important factor that all of us look at the prestige that comes with having an international degree. There are certain disadvantages. It does not really allow you to practice anywhere because it's not a licensing examination. And as with the ICO examinations, the FRCS examinations are also fairly expensive. Now, I'll give a brief overview of the FRCS Glasgow. The part 1 consists of written examination in the form of an MCQ test, which covers basic sciences and optics. Part 2 is an MCQ test as well as a written paper, which covers clinical sciences. And I think everyone would be aware that in the written paper, you have 4 essay type questions. One question is on general medicine, basically medical emergencies, and that has to be passed individually or independently before one can clear the second part. I'll be focusing my talk mainly on the structured oral examination, which forms one of the parts of part 3. This is also called the Viva, and the clinical examination will be dealt with by Dr. Ashwin Gandhi in the subsequent talk. Who is eligible for appearing for the FRCS? It depends, of course, on which part you're applying for. So in part 1, you need to have completed your internship along with 1 year of post-qualification training. And for part 2, you need to have spent at least 5 years of training post-qualification, of which 4.5 years should be in ophthalmology, essentially meaning that even a 6-month post in an allied specialty is valid as part of your eligibility. And for part 3, you just need to have completed parts 1 and 2 successfully. These are the fees as of late, but just as Dr. Akshay mentioned, these are increasing year on year. We are at a little bit of an advantage because post-Brexit, the pound has devalued a little bit. So you do get a small benefit, about 5% benefit, as opposed to if you had appeared for the examination a couple of years ago. But they are expensive examinations, and one really needs to have some financial planning apart from your academic planning in this. One can appear for each part for a maximum of 6 attempts, but I think that one would really be old and infirm if one has to depend on the 6th attempt to clear the part. So I'm sure everybody would clear it in the first or the second attempt. This is the website for the Glasgow College, and everybody can go through these guidelines on the college website. I've just taken out the main guidelines from here itself. I'll skip this because this has been covered, the ICO RCS Edinburgh reciprocity, and now the Royal College of Surgeons of Edinburgh no longer conducts examinations but depends upon the ICO ICO results to confer the degrees of MRCS Edinburgh. Now, a general principle of these examinations is that they use this technique for grading, which is the modified Angoff technique. As you can see, the pass mark 62.21 is a very odd figure, and this pass mark is basically derived on the basis of how difficult the examination or the questions are. So it's not that 50% is a pass cutoff or 75% is a cutoff. It actually is weighed upon the number of difficult questions in that paper, and that pass mark actually fluctuates. It would be higher if the paper is relatively easy, and the pass mark would be lower if the paper is relatively more difficult. How does one prepare for these examinations? Again, this was touched upon briefly, and all examinations follow roughly the same syllabus pattern, and I can't go wrong if I recommend these 2 books, those by Elkington and A.K. Khurana for optics and refraction. Really excellent books with very different approaches, but if you are able to successfully read both of them, I think you will successfully pass part 1 without any problem. John Ferris and John Forrester, the 2 textbooks for part 1, also extensively cover basic sciences, and these are also recommended reading. For part 2, a review manual is available, the Massachusetts Eye and Ear Infirmary Review Manual, and it's an MCQ based review manual, very useful. But essentially at this stage, one would be required to read the MS and DNB syllabus, whichever one has appeared for, in great detail, because these are basically based on the clinical syllabus that all ophthalmologists would have to know. The emergency medicine question has to deal with medical situations, emergency situations like these that are mentioned over here. And the Oxford Handbook of Clinical Medicine, a little handbook, has the final section on medical emergencies with lovely flow charts. And I strongly recommend reading that and mugging up those flow charts when one appears for this part of the examination. ECG is also an important question. So just a tip is to revise yourself with common abnormal ECG patterns so as to be able to clear that. So let's see some other tips. These examinations, unlike the Indian examinations, are very practical. There is a very methodical approach that one needs to take and plan one answer. They don't really ask you for lists of conditions, but rather look at the approach to a particular clinical situation or a problem. And in general, the schema that one should follow is dealing with life-threatening conditions first, followed by those that threaten vision, and the least on that list would be cosmetic issues. So if one follows this schema, I think one cannot really go wrong. Coming to the some practical tips about the Viva, it's called this fancy name, the structured oral examination, but it's really a whirlwind which consists of these stations where you get to deal with different subspecialties of ophthalmology. And these are structured examinations because the examiner has a specific set of questions and model answers. So he really cannot ask you too much out of those specific sets of questions that are in front of him. But at the same time, neither can you answer too vaguely and expect to pass, because you really need to hit those key notes or the key words which are mentioned in the model answer for him to be able to award you those marks. In many cases, the question is in the form of a picture or a clinical situation. Pictures are in the form of a colored printout. The quality of the printout, unfortunately, may not be very good. And if it's not, the examiner will give you a hint. So don't lose your cool. That's the most important take home. Generally, the subparts of each question follow the scheme of going from an easy introductory question to more and more difficult subparts. And each of these builds on the previous answers. In other words, if you're not able to identify the condition being discussed in the first subpart itself, then the questions on the management or genetic counseling, etc., will really not be answered correctly by you either. Now, practice really pays. I think this is the single most important take home, because we are not used to performing this kind of examination in India. It's quite different from what we are used to. We have this course that we conduct at Lakshmi Eye Institute. Unfortunately, because of the pandemic, since the last year, we have not been able to conduct it. We have esteemed faculty who are themselves examiners for the FRCS. And we go through a rigorous hand-holding of clinical examination of patients, as well as examination of techniques, clinical techniques. And I think it's quite useful to practice either in a formal course like this or one-on-one with a friend, and really go through the rigors of doing those tests and demonstrating those results for yourself. So I'll end over there. That's my email address if anybody has any questions. And I hand over to Dr. Ashwin Gandhi, who would be focusing mainly on the clinical examination and what kind of patients one can expect and questions one can expect.
Thank you, Devendra.
Welcome, Gandhi, sir. Dr. Ashwin Gandhi, as you know, is ex-faculty at Shankar Nethralaya, and sir is now associated with CFS International. Thank you, sir, for coming and blessing us with your presence.
Thank you so much. Thank you, Swapnesh. Thank you, Dr. Lane, sir, Professor Agini, and the entire management committee for inviting me for this very nicely organized conference. Devendra and Akshay has made my job very easy. They have covered most of the aspects, and I would be giving you a little bit of introduction of what to expect once you reach the clinical examination part of FRCS, how to navigate the clinical examination part, and what are the ways by which you can prepare for these examinations. As Devendra mentioned, most of the questions that will be asked either in the Viva or in the clinical examination would be extremely clinically oriented. Unlike some of the other exams, they would not be really asking you a long list for you to rattle out, but it will be a pertinent clinical question which you'll encounter once you clear out the exam in your day-to-day practice. So what are the steps for the clinical examination? A lot of times in our busy practice, in our day-to-day life in India, we may not give our introduction to the patient as to who we are and what we're going to do. And sometimes we skip and go directly to the examination. In FRCS, this forms an integral and important part, that you need to introduce yourself to the patient and also explain to him very briefly as to what you're going to do. Now, this requires practice, as I said, because though it should be done in our routine clinical practice, but a lot of times we skip it, maybe because of the load of patients that we see in our OPD. So this practice has to be very, very focused as to one sentence: my name is so-and-so, and I'm going to perform this examination. If you have any discomfort with the examination, let me know. Because a lot of times we see when you are told that you should introduce and explain to the patient what you're supposed to do, a lot of times candidates in the early stage would spend a lot of time in this. And you have to remember that your time is limited. You're given 20, 25 or 45 minutes. And those allotted time, you have to impress upon the examiner that you know your subject, you are able to apply the knowledge that you have gained through your reading, and that you are a safe doctor. These are very important things. You need to recollect and apply the knowledge that you learned, and to prove to the examiner that you're a safe doctor, and that has to be done. They're very, very strict with the time. Even if somebody is halfway through the question, if the bell rings, the examiner generally would avoid that question and go on to the next station. So remember this, practice how you introduce and explain as to what you're going to do in your clinical examination. The second important point is listen to the instructions that the examiner gives you very clearly, and you have to make sure that you understand what examiner has asked you to do. I'll give you an example. In clinical examination, generally, you are not given the history, you're not supposed to, or you're not expected to ask the history from the patient. You'll be given a clear instruction about performing a certain test. So examiner might ask you, demonstrate pupillary light reflex, or he may say, examine the pupils. Now these two they sound similar, but the way you begin your examination in these two instructions will be different. If examiner says, demonstrate pupillary reflex, you straight away go and perform the swinging flashlight test. If examiner, the instruction was examine the pupils, then you need to comment on the size, the other signs that might be present, and then you go on for the swinging flashlight test. So it's extremely important, because a lot of times, to save time and to give you more opportunity to demonstrate your knowledge, examiner might just ask you to say, perform swinging flashlight test or demonstrate pupillary light reflex. Patient might be having RAPD, and then you go on from there. So listen to the instructions very, very carefully. Now, carrying on with the example, if you were asked to demonstrate a pupillary light reflex, you make sure that you follow all the ideal steps, ideal test conditions which are present before you start performing the test. So in pupillary light reflex, a swinging flashlight test, as we know, you need to make sure that the room lights are off. It is performed in a dark room. So if the room lights are on, or if you're performing it in a bright room, you must politely ask the examiner to switch off the light. Make sure that the patient looks at the far object. He's not looking at you or at your torch. And then you follow the steps of a swinging flashlight test. This is extremely important. Most of the candidates, initially, if they have not practiced, they lose out. They might be knowing the subject very well. They lose out on the examination because they didn't follow all the steps, requisite steps carefully. During this examination, one of the important points is patient's comfort. And this is a joke that we repeat often. There was an examination. This is something which was passed on to us by our seniors and our examiners, that there was an exam which was being conducted in UK. A candidate was not doing too well, but as he was examining the patient, he realized the patient was feeling a little uneasy. So he stopped his examination. He inquired about the patient's health and offered him a coffee. And later on, the candidate passed. That does not really mean that you keep offering coffee every time you feel that you're not doing too well, but the whole crux of this is that you need to make sure that the patient remains comfortable all the time. So again, a lot of times by reflex, if you're seeing a patient on a slit lamp, you touch the patient, or if you're checking ocular motility, automatically our hand goes on the patient's head, and we start checking the ocular motility. Now, all these should be avoided in the FRCS exam. So if you have to touch the patient, you make sure that you do it gently, and you first say, excuse me. You don't have to explain that I'm going to touch your head. You say, excuse me, and touch the head. You don't plonk your hand on the patient's head. That sometimes we end up doing during our routine practice. Similarly, on a slit lamp examination, you make sure that if the patient is not touching his forehead on the band, you gently make sure that he touches instead of really banging his head against the hand. When you start the examination, start with a low illumination on a slit lamp or in indirect ophthalmoscope, because if the patient starts squeezing, one, will not get all the examination data point that you require. And second, the examiner would get that clear impression that you have not really looked after the patient's comfort very, very well. As Devendra mentioned, here also, as you start examining, you would start forming your thought and also conveying to the examiner as to what you are seeing, so that performing a swing flashlight test and on a direct illumination to the right pupil is reacting normally. When I go to the left pupil, now left pupil has started dilating. When I come back to the right pupil has started constricting, signifying that patient has RAPD in the left eye. I would like to know what the patient's vision is, whether he lost the vision acutely in the recent past. I would like to check for the color vision. I would perform the confrontation test and would like to know what the patient's visual fields are. At this point in time, the examiner might ask you to perform the confrontation test. And once you have done all that, and you'll say that I would like to check the fundus, you examine the fundus and find the disc edema in that eye, for example. So immediately you go back and tell the patient that patient has a left optic neuropathy with disc edema. He's a 24-year-old patient. And if patient has an acute loss of vision, my first priority is to rule out optic neuritis. I would like to request for MRI brain in orbit with contrast. And if if you were on the right track, if MRI has already been done, the examiner at that point in time might hand over an MRI for you to read. Most of the time, most of these examinations, there'll be a clear-cut findings. It's very rare for them to keep a finding which is very subtle or not very clear. So that's how it proceeds. You examine the patient, formulate your thoughts, convey it at the same time, and then also think about the next step. So you basically conveying your knowledge, your whatever thoughts that you have gathered to the examiner directly and live at the same time as you are examining the patient. So these are the basic steps when the patient is in front of you. Now, two very important points that you have to remember in FRCS, and as Devendra touched upon it, is that you always should remember the sight-threatening problem that might be associated with the condition that you are examining, or a sight-threatening problem that may be associated with the management of that particular condition. And the second, even important, is a life-threatening association of the condition or of the management. So for example, if you're given a patient, if you're asked to examine a patient on a slit lamp, you see a dislocated or subluxated lens, you see that patient can be having Marfan syndrome or homocystinuria, immediately you tell the examiner that my concern at this point in time is that if I take up the patient for general anesthesia and if it's homocystinuria, then they're associated with the general anesthesia risk. The second tip here is that a lot of times when you are asked that you should already tell the next steps to the examiner, we start rattling off the whole list. I would like to check the vision. I would like to check the ocular motility. I would like to check the pupil. I would like to check. Well, it has to be whatever you tell the examiner, there has to be a rationale, and probably you should tell the rationale. I would like to check the visual acuity because I expect the vision to be lower in this patient. Ocular motility, if you have a rationale. So instead of really telling the whole list, which you anyway are supposed to perform in all the patients, whatever that you tell the examiner should have a clear rationale behind it. As I said, the steps to be followed and whatever question that you are asked are generally clear-cut, but it's just that you require a little practice. Let's look at some of the examples. Now, this is one of the common patients that might be asked. You see here, patient has a little bit of ptosis and has an exotropia. You might be asked to examine this patient or demonstrate the ocular motility. And this patient actually had a recovered third no pulses. So you see there is a little bit of a ptosis here. There is exotropia, but the ptosis has improved. So it's not a complete ptosis. And this patient, the video is not playing, this patient had a very subtle aberrant regeneration. So when the patient looked down, the ptosis reduced. Now, why these patients are kept? As I said, sight-threatening and a life-threatening problem. This aberrant regeneration is a clear sign that patient might be having a compressive lesion of the third nerve, which can be because of aneurysm of posterior communicating artery, which can bleed and can lead to subarachnoid hemorrhage. Another important examination patient has both bilateral ptosis, and you will be asked to either examine the ptosis or be asked to examine the ocular motility. And you will find here that while ocular motility is being checked, patient has already developed a fatigue. There is an increase in ptosis because of fatigability. Now, why this is important? Because myasthenia gravis can generalize and can again lead to problems if it affects the diaphragm. As I said, a patient with a ptosis, and here when you see, you'll find that the pupil is involved. So you have to immediately jump saying, my immediate concern is this patient having a compressive lesion of the third nerve? I would like to perform MRI brain orbit with MRA to rule out aneurysm of the posterior communicating artery to make sure that patient is not suffering from it. So, and I'll conclude with this example that again we give quite often, that patient of thyroid-related orbitopathy is coming to you for a follow-up. He's on treatment for his hypothyroid status and he complains of cough. His endocrinologist is not in town. What would you advise to the patient? The reason why this scenario is given to the patient, to you, is because you need to know that many of these anti-thyroid medications can produce neutropenia, and the cough can be the first sign of that neutropenia. So instead of telling the patient that you can go away and don't worry about it, you should be aware that this can be a relatively serious problem and make sure that you order for suitable investigation. I would end here. Thank you so much, Swapnesh, and would be happy to take any questions.
Our final speaker in this session, Dr. Rohan Sawant, who was to be joining us from the UK, has unfortunately not been able to join us. So he sent a recording of his presentation, which I would play. But at this point, if there are any questions on the ICO and FRCS examinations, maybe we could cover that because his topic is on the FRCOph examination.
I think that was an excellent presentation, and as rightly put, it is very important to have a very good body language while examination. The thought process has to be conveyed to the examiner, and the practice of how to answer in these examinations is only learned by doing it in groups or having a partner. I had a partner, Dr. Manoj Khatri, and he motivated me. Dr. Chinmay Sahu passed the exam when I was giving fellowship. So you have to find your peers who are already giving the exam, take tips from them, make them your partners while studying, and then give. In fact, I had flown back to Chennai, and a private practitioner at Egmore had spared his free time on Saturday and Sunday and trained both of us. So that's very important. Devendra, there are no questions on the chat. I think we'll move on and you can share the slide.
Okay, is it visible, the video?
Yes.
Good evening, friends and colleagues. My name is Dr. Rohan Sawant. I work as a specialty doctor on the Isle of Wight NHS Trust. At the outset, I would like to thank Dr. Rashmin Gandhi sir for giving me this opportunity to present in front of you. I also like to thank my dear friend Dr. Devendra Venkatamani, who has kindly agreed to allow me to present my talk in proxy. My topic today is from the other side. A word about the Royal College of Ophthalmologists. It was founded in April 1988 and was slated to be considered as the voice of the profession in the UK. So how does it help? It is considered to be an exit level examination, which is a necessary but incomplete requirement to be a consultant in the UK. It now provides exemption from the PLAB exam as well. So as with every other fellowship exam, this examination also has been divided into three formats. There is a part 1, there's also a refraction certificate, and a part 2, which is divided into written and oral exams. Coming to the part 1 of the fellowship exams, a few rules. To be eligible for the exam, you don't need any previous experience in ophthalmology. The exam is based on the learning outcomes of the first 2 years of ophthalmic specialty training. In the UK, training is considered to be for 7 years, and they set out competencies based on how much needs to be achieved in terms of exams and also in terms of experience from year 1 to year 7. And for the part 1, that is supposed to be achieved within the first 2 years of training. It's generally takes place about 3 sittings per year. Maximum allowed is 6 attempts. Recently, there have been changes secondary to COVID and also the way the exam is conducted. It is now a 2-hour multiple choice MCQ paper 2 of those, 90 questions each, that is 180 questions in total, considered to be one best answer out of 4 options, like an MCQ exam basically. Now from October 2020, with respect to social distancing due to COVID, it is now an online proctored exam, so you can take that exam at home or at a workplace. It is online, delivered over the internet to the candidate's computer at a pre-agreed date and time, and in between the 2 papers there is a 1-hour break. A typical example of an MCQ for this part, just to put across the kind of level of difficulty expected. The question is, with regards to optic nerve, which statement is most likely to be correct?
I think the slides are not sharing. I'll just restart the video in a different format. Sorry about that.
So as Swapnesh and Devendra mentioned, basically all these would require a lot of practice. It's not really that we don't pass this exam because of lack of knowledge, just that we sometimes do stumble in these exams because of lack of orientation. So make sure that you have a group. There are lots of resources which are available on the website. There are lots of people now who have gone through this process, and they would be able to help, and in their courses as well. Yes, Devendra.
We don't need to have any patients, and paper is not allowed due to COVID regulations. This exam has gone fully electronic. The responses are recorded on an iPad. As there are no patients, the retinoscopies are completely simulated with a high-end retinoscope trainers which have hidden trial lenses within them. This is just an OSCE sitting example. It has been just taken as a copy from the college regulations. So now we have 10 stations in which we have 9 stations of simulated retinoscopy and 1 of photometrial lens neutralization. After part 1 and refraction certificate comes the part 2 fellowship examination. It's open after passing part 1 and refraction certificate. Previously, they had combined to 2 examinations, as in if you pass the written, you have to give the oral subsequently, and if you do not pass the oral, you have to start all over again by writing the part written again. Now they have decoupled it, thankfully. So if you pass the written, you can still have a shot or more than 1 shot at the oral examination. This is considered to be a synoptic exit examination that uses several different and complementary assessment methods. Again, this has been highlighted in the ophthalmic specialty training curriculum. You can find this OST curriculum on the website of the Royal College. The reasoning for testing different complementary assessment methods is they want you to know if you have the knowledge and the depth of understanding which is required for you to be an independent consultant in ophthalmology. If you're a trainee, they have to pass it before they finish their training, that's before the year 7. Maximum 4 attempts each of part 2 theory and part 2 practical. Coming to part 2 fellowship written examination, it's generally held twice a year in either June, July, 1 sitting, and November, December with the other sitting. Just like part 1, it can now be taken from home since December 2020. It has 2 MCQ papers, 90 MCQs in a single best answer format from an options of 4. 2 hours each paper, 1 hour break in between. Again, it's OST curriculum based. Coming to the blueprint of the examination, this is again taken from the college website. As is described, and if you look at this chart very carefully, you can see that they have made sure that you not only cover clinical ophthalmology, you also cover pharmacology, also cover investigative ophthalmology, and there are 16 questions of miscellaneous like statistics, research, evidence-based medicine, nutrition, ethics, and a few questions of basic sciences as well. Includes genetics and a single question of optics. I'm presenting a couple of examples of MCQ just again to know what to expect. So the question goes, a 63-year-old man presented with an intraocular pressure of 23 millimeters of mercury, currently on latanoprost and timolol once daily in both eyes. He now has an intraocular pressure of 18 millimeters of mercury in both eyes with central corneal thickness of 500 microns. Optic shows cup-disc ratio 0.6 right eye, no field loss, left eye 0.9 with increasing nasal arcuate field loss. According to the NICE guidelines, and that's the reason I put this question across, CG85, what would be the most appropriate next line of management for the left eye? So you got to be well versed with the guidelines as well. In this case, after reading all 4 options, the best response is augmented trabeculectomy. Next question, 2-year-old girl referred because her mother suspects poor vision. No family history of eye problems, parents are first cousins, fundus examination is difficult because of photophobia, but you do not find any cross-retinal abnormality. ERG indicates reduced photopic ERG, normal scotopic ERG, and absent flicker ERG. What is the most likely diagnosis? The response is given this, I don't want to test anyone's knowledge, it's just to expect the kind of difficulty of the exam. Another example of international vitreomacular traction study classification. So you should be well versed with studies and trials as well. That's the reason for this question. We'll go past it now. Regards to what you need to read. With my preparation, I can definitely say that I read these 3 books, Kanskill Clinical Ophthalmology, Oxford Handbook of Ophthalmology, and Moorfield's Manual. I found amongst all these 3 Moorfield's Manual to be very useful for theory as well as for the oral part 2 examination. There are other resources. Recently, again, Oxford Specialty Training have come up with a new book, specific MCQs for part 2 FRCOph, and of course, the evergreen Chua website is always useful. There are a few online MCQ resources as well, iDocs and Off the Questions. Off the Questions have a particular group of questions which is specific for FRCOph. I myself used Off the Questions when I was doing my exam and I found it quite useful. Not to forget, important Royal College of Ophthalmologists clinical guidelines which are widely used and followed within the NHS. Royal College of Ophthalmologists ophthalmic service guidelines. You can expect questions from that. NICE guidelines related to ophthalmology, of course. Another important factor is you should be well aware of the vision requirements for driving, due to which is very widely popular with DVLA, that's the Vehicle Licensing Agency. And you can also expect a few questions in the theory as well as in the oral for GMC's Good Medical Practice Guidelines. Again, these are freely available on the internet, on the GMC website. After the written comes the part 2 fellowship oral examination. You're eligible after you pass the written examination. It's again held twice a year in the UK and once a year in Singapore. Maximum of 4 attempts allowed for this examination. And the good news is once you pass the part 2 written examination, your pass is valid for 7 years. So within those 7 years, you can attempt the exam 4 times. It's divided into 2 parts, structured Viva, which generally happens on Monday and Tuesday, and OSCE, which is taking place Wednesday, Thursday, and Fridays. Of course, with Viva, it has case-based discussion of 5 stations, and the 6th station is a communication skills station. So each station lasts for about 10 minutes. I've just given you a blueprint of what they expect you to know. So the first station is has patient investigations, and you'll be given a biometry chart, for example, and they'll ask questions based on that. You'll be given an MRI or a HES chart or an electrophysiology printout, and the examiner will ask you questions. Also working with uncertainty, we're working with colleagues who can sometimes pose a problem. So these are basically guidelines which are routinely and regularly followed within the NHS. Station 2 as patient management 1. In Viva, they generally ask sight-threatening pictures or questions related to that. So they might give you a picture of anterior segment photograph and endophthalmitis and ask you about various trials, about ocular trauma and what to do in different situations. Again, the same with patient management 2, mainly emergency neuro-ophthalmic or general ophthalmic conditions. Station 4 is specific to do with attitudes, ethics, and responsibilities. For example, what you do if you suspect child abuse, consenting issues. As you read for the examinations, you'll realize that consent is done a bit differently in UK. They have consent forms 1, 2, 3, and 4. Each of them has their specific importance. Duties of a doctor regarding appraisal and revalidation, which happens every year in the UK. How to manage a complaint, how to report a critical incident, and how do you report or deal with a poor performance by a colleague. Station 5 deals with audit research and evidence-based medicine. These are again evidence-based with the guidelines pertaining to the college guidelines or NICE guidelines, so they can ask you about driving rules, medicine side effects, and how to deal with them. Station 6 is a communication skills station. It involves an interaction between a candidate and a patient, which is an actor. It could be specific to either consent taking for cataract surgery, ptosis surgery, or you have to talk and counsel a patient. For example, if the patient is not happy with the kind of treatment that's been happened in the hospital, and also it's mainly to do with counseling and advising patients. For station 1 to 5, we'll have one examiner. Station 6, we'll have two examiners. One is a consultant ophthalmologist, another is a non-ophthalmic examiner. With OSCE, we'll have 5 stations, 20 minutes each, 2 examiners. Used to be 3 patients per station, now 3 videos. I'll come to that very soon. It's again highlighted in the college regulations. You have 1, 2, 3, 4, 5 stations, anterior segment, glaucoma and lid station 2, and so on and so forth. I'm presenting you with an example of videos which are now replaced patients in these examinations. Trying to see if it's working. It's probably not. Sorry about that. So as a temporary exam requirement, now because we don't have patients anymore, before the exam, your clinical skills will be assessed beforehand in a clinical setting at your local trust hospital by a Royal College appointed examiner, and they will test you for 7 clinical competencies. This needs to be done at least 2 weeks before the examination, and you'll have 3 shots of giving or passing this temporary exam requirement of clinical competencies before you actually sit for the exam. So if you give it once and if you don't go through, you can reschedule it straight away within a week or 2, and then once you get that, then you'll be eligible for the actual examination. Agreed clinical assessments are again these codes CA3, CA5, CA6, CA7, CA9, and CA10B and 10D are part of the ophthalmic specialty training curriculum. So there'll be a locally appointed examiner who will ask you questions, or there will be one of the nurses within the trust who will be used as a patient, and you have to demonstrate different skills, clinical skills basically. How to go about preparing? As you know, that's from what we have discussed in the last few slides, that WAWA is basically about clinical scenarios. OSCE is again about practice, especially with subspecialty clinics. You need to be well versed as it has been slated to be an exit level examination with different conditions of different subspecialties, and you should have a good amount of knowledge to be able to answer the questions, because the standard is set at a slightly higher standard than which is again set by the examiners, by the college. Other resources, again, I think it's a repetition of the previous slides. You should be well versed with NICE guidelines specific to ophthalmology, the Royal College guidelines, GMC documents, for example, Good Doctors, Safer Patients, they have a document of revalidation, and a general good medical practice guideline as well. DVLA related to ophthalmology, strategic papers, new studies, new trials. Sometimes they will give you an advance notification with a particular paper that you have to read for discussion at a forthcoming examination. So when patients used to be there, they expected you to have that kind of demeanor. I've taken out a few slides of this because demeanor is considered very important in these examinations. Because patients are not there anymore, that demeanor is tested at the locally taken exam by the examiner. Knowledge and conduct wise, you still need to be at the top of your game. They sometimes even check the way you sit, the way you speak, and your facial expressions. So if you don't know something, don't show that anxious expression on your face. They will then start to give you a slight negative opinion as to, oh, this person is not knowing this. All they want to know is, what are you thinking, rather than what is the diagnosis. All right, last point, remember to switch the slit lamp off before you answer any questions. Useful in a clinical setting where patients used to be there. I'm hoping in the near future that they would ditch this video system and come back to real patients, hoping for all of us. Nothing special written here. Prepare early, score well. You should make sure that you treat each patient that you see in your clinic, treat it as an exam patient, interact, those kind of practices with good ophthalmic and medical care in day-to-day practice with skill examination, high level of knowledge, and safety, of course, because that is easily transferred in the examination. Good luck. If you have any questions, this is my email and this is my number as well. I'm happy to answer any questions. And again, apologize for not being present in person. And I thank Dr. Rashmin sir again and my good friend, Dr. Devendra. Good luck for exams. Thank you.
I think that was a brilliant presentation and must have motivated many of us to take up the next step, which is FRCO. Devendra, when are you giving that?
No, that's a whole other can of worms. I think, like Rohan said, and I think everybody agrees, one really has to be very sure of how one enters, because if you enter, you better well exit. It's not worth entering and not getting out of the Chakravyuh of these examinations.
Expensive Chakravyuh.
Expensive Chakravyuh, emotionally and mentally draining Chakravyuh.
I'm so happy to see Lane sir at our session.
No, I'm really missing this all, because at that time there was no Devendra, no Akshay, no Swapnesh, nobody was there to guide me. So because of that, I have not done anything. So I was just, I think, fascinating. I should have done that at time, but there was no guidance as I was in totally rural area in Ambizogai. But what I heard is, yes, such type of guidance, it was possible that time. But I think for new generation, it is a excellent opportunity. And I think the way you have put up, I think now I can tell my students that, yes, you can go ahead and you can do all these things. Thank you very much. Thank you.
Thank you, sir. Thank you. So with that, we conclude day 1 of the symposium, and have the best of the rest of the Sunday that you had, and join again for day 2, which is glaucoma and pediatric ophthalmology on the 16th of May. Thank you very much. Stay safe. And thank you, Lane sir, once again for giving all of us the opportunity.
Swapnesh, I appreciate your efforts day and night you have put in for this conference. And hard work, what is hard work, I have seen, Swapnesh, and I'm proud of you that you are my student. And really, I'm very happy that you have done such a wonderful conference. Thank you very much. My best wishes and congratulations. Thank you for everybody. Thank you very much.
Thank you.